programs in Mumbai. Welcome, Jay. Thank you for joining us. And I will now hand it over to you live, so that then you all can take proceedings from here.
Good morning, both of you. And the innumerable enthusiastic biological psychiatrists, researchers across the country. It's a great pleasure to start with this poster session, which I'm happy to say that already more than 750 delegates are registered and already logging in. So it's going to be a great session. I would request the chairpersons to just time it, because we are really tight on the time. About 3.5 minutes presentation and maybe one question each for the presenter. Thank you very much.
Thank you, Prasad Rao sir. Dr. Avinash, thanks for giving us the opportunity. I would like Dr. Jay Shastri to start the session.
Okay. Good morning, everybody. And I think without any further ado, as Dr. Prasad Rao sir has already mentioned, there will be sticking very strictly to the time. And for each poster, we'll have around 3.5 minutes presentation and 1 or 2 questions maximum. So we'll start with the first poster. I have Dr. Rajesh Singh on live.
Yes, sir.
Okay. So Dr. Rajesh Singh, his topic is dementia as a delayed complication of intracranial hemorrhage, right?
Yes, sir.
Okay. So you can start your presentation now, Dr. Rajesh.
Okay.
Rajesh, we cannot hear you.
You're not.
Yes, sir. Yes. Good morning, sir. My name is Rajesh Singh. Today I am presenting poster. My topic is dementia as a delayed complication of intracerebral hemorrhage. Introduction. Pathology. Head injury may be penetrating and close, with fall being the most frequent cause of close injury, precipitating primary and secondary brain damage. Primary brain damage results from contact and inertial force that occur at the time of injury. Secondary brain damage is produced pathological process that are initiated at the moment of injury but span is variable period following the traumatic episode. These include brain damage secondary to ischemia, brain swelling, rise intracranial pressure, and infection, laceration, usually accompanied by extracerebral hemorrhage. Intracranial extracerebral hemorrhage occur in the epidural space, subdural space, and subarachnoid space. Neurobiological change. Evidence from experimental models suggests that diffuse neuronal damage and cell loss may progress over week to month after initial insult in selectively vulnerable region in prefrontal cortex, hippocampus, thalamus, striatum, amygdala, and forebrain nuclei. Furthermore, chronic axonal change occur following experimental TBI that are not limited to Bayesian degeneration. Whereas WHO guidelines, mild traumatic brain injury constitute transient alteration, mental status, and consciousness, amnesia of less than the 24-hour, transient focal neurological deficit, initial Gross-Momer scale of 30 to 15, intracranial lesion not requiring surgery, loss of consciousness of less than the 30-minute, transient seizure, not post-concussion syndrome, or sign of significant head injury, including loss of consciousness from several minutes to hours, persistent headache or headache that worsens, repeated vomiting or nausea, convulsion and seizure, dilatation of one or both people of eye, clear fluid draining from nose and ear, inability to awaken from sleep. My case, Krishna Ji Tiwari, son of Rajaram Tiwari, 70-year-old male, married Hindu, upper socioeconomic status, broad speech attended with chief complete diminished functioning, bare minimum speech, rigidity, holding saliva, urination in cloth with exacerbated symptoms since 7 days with no significant past psychiatric history, medical history of tuberculosis and head injury and spinal injury by fall on stair 2.5 months back, not associated with loss of consciousness, vomiting, any orificial discharge, neurological deficit, or any transient seizure, which was treated with skin sutures. He was hypertensive on admission. Mental status exam, general appearance, behavior, and ectomorphic, main camp, tidy, appropriate age, not in touch with surrounding, not maintaining eye-to-eye contact, lying on lateral position on bed with anxious facial expression, rapport not established, psychomotor activity retarded, rigid, negativism present, speech soft, low tone, low productivity, speak less than the 20 word in 5 minutes, increased reaction time, very slow output, hesitant, irrelevant, incoherent, not goal directed. Cognitive functions, patient was not oriented to time, place, person with impaired attention and concentration. Mood dysphoric, affect, shallow, constricted, mobility, restricted range, non-reactive, non-communicative. Bush Francis catatonic skills scores is 10, and activity of daily living and instrumental activity of daily living skills subsequently 0 and 6 and 1 8 respectively. MRI of brain revealed moderate size of late subdural hemorrhage along with right frontoparietal convexity with focal subarachnoid hemorrhage in right frontoparietal sulci, resulting in mass effect over right hemisphere. Conclusion. Head injury in the third leading cause of dementia after infection, alcoholism in patient less than the 50 years of age. However, dementia in late year generally seen in gradual process. Head injury is generally reported in case of repeated trauma. Dementia due to head injury usually start within 1 month gradually or rapidly and does not progress. Cases as discussed above seldomly report, thus it is advised to consider intracranial hemorrhage as a cause of dementia. Reference.
Okay, thank you, Rajesh. If you can stop sharing your slide.
Yes, sir.
There are no questions in chat box or question answer.
So, Rajesh, I have one query. What were your dementia-related finding in this particular case?
Sir, patient is difficulty in functioning, in executive functioning, and aphasia or फॉरगेटफुलनेस प्रेजेंट सर, मतलब डेली रूटीन एक्टिविटीज जो थी सर उसकी इम्पेयर होने लगी थी, वो से फॉरगेटफुलनेस से स्टार्ट होके फिर फर्दर डिटीरिएट होने लगा.
And what was the delayment, as your title mentions that delay in dementia finding? So what was the delay in onset? When was the hemorrhage? When did the hemorrhage happen? और dementia के changes कब से शुरू होने दिखे हमको?
सर 2.5 month बाद पहले फर्स्ट जो इंजरी हुई थी उसमें पेशेंट कॉन्शियस था, सब कुछ नॉर्मल था, केवल माइनर सूचर्स के लिए, और उसके बाद उसे कोई प्रॉब्लम नहीं हुई. एट ए टाइम ना कॉन्शियसनेस, वोमिटिंग, कोई साइन सिम्टम नहीं थे. बट आफ्टर 2 month पेशेंट प्रेजेंट आवर डिपार्टमेंट विद लॉस ऑफ कॉन्शियसनेस और with delirious feature or later he developed dementia.
Okay. Thank you so much. Do we have any other questions?
No, I don't think so. We'll go for the next participant, Dr. Umesh.
Thank you, sir.
Unexpected emergence of catatonia after ketamine infusion in depression, suicidal patients. Dr. Umesh, you can.
Yes, sir.
Yeah.
Is my screen visible?
Yes, your screen is visible.
Good morning. I am Dr. Umesh Pathak from Samsa Medical College, Riva. I am presenting a case report on unexpected emergence of catatonia after ketamine infusion in depressed suicidal patient. Ketamine, an NMDA receptor antagonist, is currently being used for induction and maintenance of general anesthesia, chronic neuropathic pain, and sedation. Ketamine has been earlier also used in field of psychiatry as anesthetic agent in ECT for catharsis and psychedelic, and its use has been expanding ever since. Recently, FDA has approved nasal spray esketamine as both antidepressant and as anti-suicidal for depressive disorder. Multiple psychiatric adverse effects of ketamine have been documented over the recent years, such as anxiety, confusion, disorientation, dysphoria, dissociative state, emergence phenomena, delirium, including the hallucinations, unusual thoughts, extreme fear, excitement, and irrational behavior, and insomnia. Most of these adverse effects were mild and transient in nature. In this case report, we found unexpected emergence of catatonia in a depressed patient who was being treated with ketamine infusions for depression and suicidality. A 34-year-old married Hindu female presented to psychiatry OPD with a duration of illness of 3 years. Patient had chief complaints of low mood, reduced interest in previously pleasurable activities, sleep and appetite disturbances, reduced energy, feeling of worthlessness, and suicidal thoughts. Mental status examination revealed downward eye cast, reduced speech output, as well as reduced volume and rate, sadness of mood, depressed affect, worthlessness, hopelessness, helplessness, along with the suicidal ideations in thought content. A diagnosis of major depressive disorder as per DSM-5 criteria was established. No past psychiatric or medical history was present. There was a positive family history of depression in elder sister who was under treatment. On detailed interview, history of failed response to a total 4 adequate antidepressant trials, including fluoxetine, paroxetine, sertraline, and venlafaxine. She was given augmentation with lithium and olanzapine in past. Patient was admitted for further management in the view of suicidal attempt. All routine investigations were carried out and were within a normal range. After obtaining informed consent, general and systemic examination and fundus examination, patient was taken up for repeated dose ketamine protocol consisting of 3 times weekly on alternate days. Intravenous ketamine 0.5 mg per kg, that is sub-anesthetic dose, in 100 ml NS normal saline over 40 minutes was infused. After first dose of ketamine, patient showed significant improvement in HAM-D 17 and modified scale for suicidal ideation scale. Patient just after receiving second dose of ketamine suddenly developed signs of catatonia such as vagy flexibility, mutism, posturing, and stupor. A complete physical examination was conducted, which was within normal limits, followed by investigation including urgent CT head, which was normal as well. Patient was started injection lorazepam 4 mg infusion and repeated again for the management of catatonia, but it doesn't improve the catatonic symptom. About 3 to 4 hours after the onset of catatonic symptoms, patient started improving spontaneously and resolved by the end of 4 hours. Ketamine therapy was terminated and patient was taken up for ECT for further management. 3 cycles of ECT along with lithium, fluoxetine, and olanzapine orally given. Patient improved within 7 days and was discharged for the same. This case report probably support the glutaminergic hypothesis of catatonia, that NMDA receptor hypofunction by antagonism can cause catatonia. Although recent case reports have casted daylight upon the use of low dose ketamine for rapid management of catatonia, but from this case report we can conclude there remains insufficient data in the therapeutic use of ketamine to promote as treatment of catatonia. Thank you, sir.
Do we have any queries? Questions, Minaj?
No, very good. Relevant presentation, Umesh. And more number of people are going for ketamine use, and with intranasal ketamine coming up, we think that ketamine use will be like it will be used by most of the psychiatrists. And you, as correctly said, that some people have tried in catatonia, but since data is insufficient, we should keep the thing in mind. Thank you.
Can I ask one question, Umesh?
Yeah.
Yes, sir.
What does the review of literature says?
The review of literature says that low dose ketamine improves the catatonic symptoms. Low dose sub-anesthetic dose ketamine.
Are there any such cases reported like yours?
No, sir. This was the first case, as per my knowledge. After which I get.
Okay.
We can move on to, we can move on to the next speaker, Dr. Ravi Kiran. Abdominal seizure, a case report. Dr. Ravi Kiran. Dr. Ravi Kiran, are you there? I can see you. your video and audio is not on. Dr. Ravi Kiran.
After which,
ठीक है.
We can move on to, I think, sorry. We can move on to the next speaker, Dr. Ravi Kiran.
Yes, sir.
Abdominal seizure, a case report.
Yes, sir.
Dr. Ravi Kiran.
Yes, sir. Yes, sir.
There?
Yes, sir. I'm there, sir.
I can see you. Your video and audio is not on. Dr. Ravi Kiran.
Yes, sir. I'm there, sir.
Start your presentation, Ravi.
after which,
Quickly, the children behind
We can move on to, I think, sorry. A case report.
Yes.
Dr. Ravi Kiran.
Yes, sir. Yes.
There?
Yes, sir. I'm there, sir.
I can see you. Your video and audio is not on. Dr. Ravi Kiran.
Yes, sir. I'm there, sir.
Start your presentation, Ravi.
Yes, sir. I'm not able to share the slides, sir. Can I read it aloud, sir?
No problem. Go ahead.
Yes, sir. So, abdominal seizure, a case report under the guidance of our HOD, Dr. Sanjeev Kale from the D.Y. Patil Hospital, Nerul. So, the introduction is abdominal epilepsy is a rare condition usually found in children. It is associated with gastrointestinal symptoms and associated with epileptic activity. It is responsive to anticonvulsive. I'm not able to share the slides, sir. Can I read it aloud, sir?
No problem. So,
It is responsive
Ravi,
to
can I
anticonvulsive
ask
treatment and weakness done during periods of abdominal pain generally suggest of epileptic activity. Symptoms include stomach pain, nausea, and vomiting. Some patients may have tonic-clonic seizures. 8-year-old girl admitted in pediatrics was referred to psychiatric hospital in view of abdominal pain, query functional. The patient and relatives gave a singular complaint of abdominal pain associated with cramping, not associated with nausea or vomiting. The complaint had started since 4 years. The patient also carried 2 discharge
Sorry to interrupt.
cards in which
Sorry to interrupt, Ravi sir.
previously for the same complaints.
Ravi sir,
and
Ravi sir, sorry to interrupt. Ravi sir, सर एक सेकंड. रवि सर होल्ड करना सर, एक सेकंड. सॉरी टू इंटरप्ट. सर आपने 2 डिवाइस से लॉगिन करा है क्या? रवि सर आपने अनम्यूट करो एक बार. रवि किरण सर अनम्यूट योरसेल्फ. रवि किरण सर अनम्यूट योरसेल्फ. हाँ सर आपने 2 डिवाइस से लॉगिन करा है क्या सेम टाइम पे? सर
So the sound is lagging behind me a lot.
हाँ सर इसीलिए that's why we are asking you just join with 2 devices. इसके वजह से जो है साउंड मत. रवि सर आपने अनम्यूट करो एक बार.
Sir, I am unmuted, sir.
रवि किरण सर अनम्यूट योरसेल्फ.
I am unmute, sir.
हाँ सर अभी चालू करो सर स्टार्टिंग से प्रेजेंटेशन आप. और स्क्रीन शेयर कीजिए सर आपके मिडिल.
रवि किरण आपके साथ में जो लोग हैं उनको बाहर निकलने का बोलिए, कमरे में मत रहने दीजिए. मेरे ख्याल से उनका वीडियो ऑन है, उनका ऑन है, इसकी वजह से साउंड वापस आ रहा है. There are people.
Only one device that is on, sir.
की वजह से जो है साउंड मत.
So there is only one device that is on with me, sir. Sir, I am unmuted, sir.
हाँ सर अभी चालू करो सर स्टार्टिंग से प्रेजेंटेशन. हाँ सर आपके सेंटर बॉटम में ग्रीन कलर से शेयर स्क्रीन लिखा हुआ होगा. प्लीज क्लिक ऑन दैट.
में जो लोग हैं
सेंटर बॉटम
निकलने का बोलिए, रहने दीजिए. मेरे ख्याल से उनका वीडियो ऑन है, उनका ऑन है, इसकी वजह से साउंड.
No, sir. There is only one device that is on with us.
नहीं सर आप बोल नहीं रहे लेकिन आपके बैक से तो बिहाइंड से तभी भी आवाज आ रही है. और किसी का माइक चालू है. सर एकदम सेंटर बॉटम में शेयर स्क्रीन का ऑप्शन है. क्लिक ऑन दैट.
Okay. No, sir. There is only one device that is on with us.
सर आप बोल नहीं रहे लेकिन आपके बैक से तो बिहाइंड से तभी भी आवाज आ रही है.
Sorry, sir. There is some problem with the device that is again getting lagged for some reason.
सर एकदम सेंटर बॉटम में शेयर स्क्रीन का ऑप्शन है.
I think till that time we'll move on to the next speaker with permission of Dr. Jay. Hello, Dr. Jay.
Yeah, we can move on, Minash.
Dr. Srivastava, are you there? If Dr. Srivastava is not there, then Dr. Simran or Dr. Sneha, I can see. Dr. Sneha, are you there? Sneha Raju?
Yes, sir, I'm here.
Yeah. Can you start your presentation, Sneha?
Yes, sir.
Thank you.
Morning, everyone. Ashirin Raju. I'm a junior resident from MGM Medical College. My topic for poster presentation today is Syndromic Neuropsychiatry, a case series on neuropsychiatric comorbidity across rare syndromes. My co-author for this poster is Dr. Darpan Kaur. Coming to the background, syndromes, Ellis-Van Creveld syndrome, Lennox-Gastaut syndrome, and Dyke-Davidoff-Mason syndrome. These are three rare syndromes which shows sparse literature on the neuropsychiatric comorbidity of these syndromes. My aims and objective being to describe three interesting cases of neuropsychiatric comorbidities across these syndromes. I'd like to discuss three cases. Case 1, patient A, an 8-year-old girl, was brought to the clinic with history of delayed milestones, dysmorphic features. We diagnosed it as Ellis-Van Creveld syndrome with intellectual disability and behavioral problems. Her IQ testing was done, which turned out to be 32. She was managed by giving tablet risperidone 0.5 mg HS. Coming to case 2, patient B, a 5-year-old boy, was brought to the clinic with complaints of behavioral and speech problems in form of restlessness, irritability, aggression, regressive behavior, and regression in speech. The diagnosis being Lennox-Gastaut syndrome with seizure disorder and childhood disintegrative disorder. Here, his EEG was done, which showed epileptiform activity over the temporal and bilateral frontal region, along with slow spike and waves in the bilateral frontal region. He was managed by giving tablet risperidone 0.5 mg HS along with anti-epileptics. Case 3, patient C, a 32-year-old female, was brought to the clinic with complaints of irritability, anger outbursts, and difficulty in initiation of sleep, along with history of unresponsive episodes and facial dysmorphism. Diagnosed it as Dyke-Davidoff-Mason syndrome with seizure disorder, along with intellectual disability and behavioral problems. Her MRI was done, which showed hemiatrophy of the left and the right cerebral hemisphere, along with compensatory thickening of the frontal and bones. She was managed by giving tablet risperidone 0.5 mg BD, which was titrated along with anti-epileptics. Coming to the discussion, three syndromes, Ellis-Van Creveld syndrome, Lennox-Gastaut syndrome, Dyke-Davidoff-Mason syndrome. These three syndromes have a constellation of symptoms and should be treated and evaluated in a multi-systemic approach so that to identify and treat the structural, cognitive, psychiatric, and neurological complications. For example, in our patient, we had given IQ testing, behavioral therapy, and rehabilitation. Such therapies not only improve the quality of life, but also help in the prognosis of the patient. Therefore, there is a need for further awareness and research in this domain of syndromic neuropsychiatry. Thank you.
Thank you, Dr. Sneha.
Good morning, sir. This is Dr. Simran. Sir, I'm here now. May I present?
Any questions for Dr. Sneha?
Sneha, the Dr. Jay Shastri here, you mentioned about mineral therapy. If you can just talk about it a bit. What was the mineral therapy given?
Sir, behavioral therapy, the patient was quite agitated. The patient had speech problems and behavioral problems. So we referred her to a speech therapist, and learning disability was there. So learning disability was introduced. However, we lost to follow up, so not much details are known about the patient. Behavioral therapy, we had continued her on risperidone. She showed improvement on the same, but then we lost her.
Okay, thank you so much.
Thank you, sir.
I think we can go to Dr. Simran. Dr. Simran is here.
Yes, sir. Yes, sir. I'm here.
You can start sharing your screen.
Yes, sir. Good morning, sir. Good morning, respected teachers and colleagues. The topic that I'm going to present today is a case of focal somatosensory epilepsy. The International League Against Epilepsy of 2019 classification divides seizure disorders as either generalized or focal or unknown origin. Focal seizures, when further divided, can be motor or non-motor type. Focal non-motor seizures involve a sensation that occurs at seizure onset without any objective signs that can be evident to an observer externally. Focal non-motor seizure types can be of 5 types: focal somatosensory seizure, focal visual sensory seizure, focal olfactory, auditory, or gustatory. There is a second sensory area in the brain located behind the insular cortex, which may give rise to a type of focal seizures, which may be either unilateral or bilateral with respect to the site of origin. When arising from the second sensory area, seizures are typically give rise to sensory symptoms. Now, studies have shown a wide range of sensory symptoms have been reported by the patients, including tingling, stiffness, numbness, or pain in the head or limbs. Thermal or shock-like sensations have also been reported. There can also be alteration of autonomic function like flushing, sweating, or piloration. All of these symptoms can present with or without an alteration in the awareness of the patient or in cognitive impairment of cognition. Some patients may report feelings such as fear or a sense of impending change, detachment, or feelings of depersonalization. All of these events, which occur as sensations but are not directly observable, we also a 14 with giddiness, tingling, and numbness in the whole. It was. Am I online, sir?
Yes, yeah, you are online. Now you are audible.
Yes, sir. The sensation of tingling and numbness all over the body and giddiness lasted.
Simran, you are not audible.
His bandwidth issues हैं. इंटरनेट कनेक्टिविटी सही नहीं है सर मैडम की.
These episodes occurred when the patient was unaccompanied and resolved on their own spontaneously. There was complete recollection of the events during the episodes and ability to comprehend and respond to commands. There was no history of crampite, incontinence, abnormal body movements, or uprolling of eyeballs throughout these episodes. A thorough medical workup for the patient was done under medicine department, and routine investigations which were within normal limits. An MRI brain was done. Conduction studies were done, which did not show any abnormal.
Simran, again, you are not audible. Jay, can you hear?
No, I can't. I think we lost quite a bit of her presentation in between too.
Yeah.
No specific stressors, psychological stresses found, and there was no history of substance abuse. On mental status examination, patient was calm, conscious, cooperative, oriented, and time-tasking person. Eye-to-eye contact was initiated, maintained, attention, arousable, sustained. Mood was, there was some anxiety associated around the episodes, but pervasively, mood of the patient was euthymic, affect was euthymic, thoughts were
Simran, can you hear us? I think we have lost her audio as well as video. I can't hear her.
And since focal intellectual epileptiform spikes or sharp waves, they support the
Simran, can you hear us?
diagnosis of focal seizures. The patient was diagnosed as having focal somatosensory epilepsy. She was started on tablet divalproate 250 milligrams HS in January 2021, and she's yet.
Hello. Okay. Simran, can you hear us?
I think you should ask a question if you have any. Simran.
Napa, is she able to hear us?
Yes, sir.
Are you able to hear us?
Yes, sir.
Okay, because we actually missed quite a bit of your presentation in between. There was some network issue.
Yes, sir.
But if you can just tell us, because now we are able to see you, what is your takeaway from this particular case? If you can just give a small understanding, a brief understanding about the case, a very small. Okay. I think she has network issue. Minat, shall we move ahead?
We can move ahead, I think, with Dr. P. Dharinder. He is there.
Dharnidhar.
Dharnidhar. Sorry. Dr. Dharnidhar, are you there? Dr. Dharnidhar, are you there?
Yes, sir.
Yeah. Please start sharing your screen.
Not unmuted, sir.
Hello?
Yes. We can see you, Dr. Dharnidhar.
Yes, sir.
Share your screen if you have.
I'm sharing my screen, sir.
Yeah, we can see your screen. Carry on.
Good morning to one and all. I'm Dr. P. Dharanidhar from Kamreni, Nalgonda, Telangana. Today I'm presenting an interesting topic in our study. Are early onset schizophrenic patients with minor physical anomalies more vulnerable to risperidone-induced? It's a window for introspection into neurobiology. Schizophrenia Exact cause are unknown. The research suggests that combination of physical, genetic, and psychological and neurobiological and environmental factors can make the person vulnerable to develop this. My topic involves majorly on three aspects, that is early onset schizophrenia, minor physical anomalies, and drug-induced bruxism. The exact cause, the genetic factors are unknown, but the gene APA1A3 is mostly responsible for early onset schizophrenia. Minor physical anomalies are characterized potential markers due to its structural aberration. Can you hear me, sir?
We are able to hear you. Please go ahead.
As there are structural aberrations in early neural development. A critical analysis done in 2010 ponders upon the conflict of schizophrenia as a neurodegenerative or a neurodevelopmental disorder. The recent theories are supportive more towards neurodevelopment. And the bruxism, which is hypothesized to cause by variations in the neural structures, somatosensory, motor, premotor cortex, supplementary motor area, and parietal cortex, thalamus, and cerebellum. It has more relations for D2 receptors, which are discussed in the further. The fMRI study in childhood onset schizophrenia revealed very slow annual growth rate in cortical gray matter compared to healthy control, which may correlate with neurodegenerative hypertension. Coming to aims, aim of a study is to evaluate if early onset schizophrenic patients with minor physical anomalies are more vulnerable to risperidone-induced. The dopamine hypothesis development of the schizophrenia is most accepted, which correlates with the PET scan studies indicating that D2 receptor abundancy in caudate nucleus causage. The linkage between high affinity of antipsychotics such as haloperidol, risperidone, pimozide to D2 dopamine receptors through raclopride and bruxism association with D2 dopamine receptor with premotor cortex and sensory motor can indicate the drug-induced bruxism effect. The methodology here is in past 1 year and 6 months, we collected around 300 cases of schizophrenia cases. And among them, I've selected 15 early onset schizophrenic cases. There are among them 4 minor physical anomalies cases were noted, where we initiated the drug treatment risperidone around 4 to 6 milligrams per day. The duration for evaluation of bruxism was 2 to 3 months. The number of patients we observed who developed bruxism were 2 out of 4 with minor physical anomalies. The inventory we used here is a Waldrop's inventory to assess the minor physical anomalies in the patient who are presented with variables of palmar creasing, high arch palate, set ears, altered hairline, and palpebral fissure anomalies. As I discussed, the mutation of ATP1A3 gene leads to early onset schizophrenia. In these individuals, the chromosomal aberrations may lead to minor physical anomalies. Because of this association with schizophrenic individuals being considered as an endophenotype marker of the neurodevelopment. The D2 receptor has high occupancy in the schizophrenic individuals, resulting in risperidone-induced bruxism. And with this, we can form a basis to theorize that vulnerability of minor physical individuals to risperidone-induced bruxism is more. This can be utilized for a novelistic approach to stratify these individuals and provide better care to avoid these adverse effects. Thank you.
Great. Do we have any queries, questions here?
your sorry. So your takeaway point is like if person has some along with early onset schizophrenia with some minor defects, we shouldn't prescribe risperidone. Is that the takeaway?
Sir, I suggest that we should approach them in a different way to avoid the side effects like bruxism or any other risperidone or antipsychotic induced side effects.
What do you suggest? Which antipsychotic?
We can go to olanzapine or less side effects of aripiprazole.
Thank you. Thank you, Dr.
Thank you, sir.
Barinder. Dr. Srivastava is there. Dr. Srivastava, are you there? We have missed you. Dr. Srivastava? Adviya Srivastava? Yes, can you start your presentation?
Yes, sir.
Yeah, please start sharing your screen.
Yeah. Sir, I want to know that whether the poster which I have that will be shown on the screen, or I'll have to share.
Yeah, you will have to share screen.
Okay, okay. Then can I take some time, sir?
Oh, okay. After this, we'll give.
Yes.
Dr. Makan, Shakya, Dr. Makan, are you there?
Yes, sir.
Can you start sharing your screen and start the presentation?
Jesus. Visible. Hello. Good morning, sir. Am I visible?
Yeah, you are.
Yes, please.
And you are audible. Please start.
Okay. Thank you. So today I'm here to present a case report of a patient with oxcarbazepine induced stress, that is drug rash with eosinophilia and symptomic symptoms syndrome. So drug rash with eosinophilia and systemic symptoms, also known as drug-induced hypersensitivity syndrome, is a rare, acute, potentially life-threatening, idiosyncratic, severe cutaneous hypersensitivity drug reaction characterized by fever, skin eruption, hematological abnormalities including eosinophilia and atypical lymphocytes and internal organ involvement. The estimated incidence of this syndrome varies from 1 in 5,000 to 1 in 10,000 drug reaction. Pathogenesis of DRESS is not well understood and may consist of interaction between following factors as hereditary deficiency of enzymes involved in detoxification, which results in drug metabolite accumulation, or genetic association between HLA association and drug hypersensitivity associated with carbamazepine, induce Steven-Johnson syndrome and toxic epidermal necrolysis, or a probable drug interaction with virus. Registrar criteria for diagnosis of DRESS includes at least 3 of the following 7 characteristics, in which there is a skin eruption, fever, lymphadenopathy, involvement of at least one internal organ, most commonly liver, lymphocytosis, lymphocytopenia, and blood eosinophilia and thrombocytopenia. Aromatic anti-epileptic drugs such as phenytoin, carbamazepine, phenibarbital are the most common cause of DRESS. Management include early diagnosis of syndrome, stopping the offending agent, and symptomatic and supportive management include using corticosteroids. So, oxcarbazepine, which is a keto analog of carbamazepine, and is used principally for treating epilepsy and associated for relieving neuropathic pain as mood stabilizer, for treating anxiety disorder and benign motor tics. It is prodrug which is activated to L-carbazepine in the liver, and notable side effects include sedation, dizziness, ataxia, nausea, which is usually dose dependent, and headache, nystagmus, abnormal gait, confusion, nervousness, fatigue, vomiting, abdominal pain, dyspepsia, vertigo,
abnormal vision, and rashes. Hyponatremia and suicidality are rare side effects. It is thought to have the same mechanism of action as carbamazepine, that is, inhibition of sodium channel. It shows some drug interaction with NSAIDs, commonly ibuprofen, which is a non-selective COX inhibitor, which is effective, especially against inflammatory pain due to tissue damage. In the case described subsequently, generalized erythema is complication of oxcarbazepine as well as is its interaction with NSAIDs. Now discussion. Anticonvulsant therapy in general is associated with various side effects as dizziness, drowsiness, fatigue, coordinated disturbance, nausea, tremor, cognitive deficit, mood alteration, sexual dysfunction, rashes, weight gain. And these side effects are usually dose dependent, appear early in the treatment and disappears with reduction of dose or stopping drug altogether. Sedation and cognitive side effects are more commonly associated with barbiturates, benzodiazepines, topiramate. Meanwhile, cutaneous reaction ranging from benign rashes to severe and life-threatening reaction as Steven-Johnson syndrome, DRESS and TEN, are commonly associated with lamotrigine, carbamazepine, oxcarbazepine, phenytoin, barbiturates, and felbamate. DRESS syndrome was coined by Bucket et al. In 1996 with features such as fever and hematological abnormalities, along with the involvement of internal organ. Carbamazepine, a relative new drug, induced definitive case of DRESS symptoms are rare. Our patient fulfilled 3 out of 7 registrar criteria, and as per Naranjo scale, which is used to uh, uh, identify whether these adverse reactions are due to drug or due to some additional factors. For estimating the probability of adverse reaction, the probability category was probable with a score of 7. Thus, the case was diagnosed as carbazepine induced DRESS syndrome with possible adverse interaction of oxcarbazepine with NSAIDs. The patient shows recovery with adequate treatment. Now, case a 30-year-old married Hindu female living in rural locality belonging to upper middle socioeconomic class, known case of seizure disorder. 10 years presented with complaint of generalized scaling, blisters, and erythema all over the body since last 2 days. History of changing from carbamazepine 200 milligram BD to oxcarbazepine 300 milligram BD 30 days back was present, following which there was exposure to NSAIDs, and which was unknown. For fever 1 week back. Following admission, oxcarbazepine was stopped, and there was no history of benign rashes around 3 years back. Also, a history of benign rashes around 3 years back when patient was on tablet lamotrigine 150 milligram BD. On examination, patient was febrile, tachypneic, and tachycardia, conjunctival congestion with diffuse swelling all over the face and body, and pitting edema in bilateral legs. Baseline laboratory
5
investigation
seconds left.
revealed leukocytosis with 8% eosinophilia, raised SGOT, SGPT, decreased urine serum sodium, and raised chloride, whereas renal function tests, bilirubin, and serum protein were normal. There was she was administered with methylprednisolone 500 milligram OD, injection amikacin 500 milligram OD, injection metronidazole 400 milligram BD, injection ceftriaxone salbactam 1.5 milligram BD, injection 3%
Thank you, Dr.
NaCl
Martin.
tablet.
Your time is over. Thank you.
Okay. जी.
Can we move on to the next speaker, Dr.
Hello.
Saida Hira Fatima?
Am I done, sir?
Yeah, Dr. Makani, the time is over.
जी. Okay. Thank you. Thank you so
Thank
much.
you.
Thank you.
So can I have a word with the organizers? Can we just coordinate with the earlier speaker, Dr. Ravi Kiran, regarding his problem? So whenever he is ready, we can take him up also. Whatever, if somebody can talk to him,
Sir, he is ready actually.
take him up also.
Sir, he is ready actually, Dr. Ravi Kiran.
Okay,
Sir, I'm
so
ready,
can
sir.
we, Minaj,
I will
can you
ask
take
him to. I will
Yeah, sure.
ask him to join. Sir.
I'm ready,
Okay.
sir, actually.
Okay,
Okay, Ravi, please go ahead, Ravi.
May I start, sir?
Yes,
Yes.
please.
Okay,
Your
sir, is
screen
the
is
slide
visible.
visible?
Yeah, visible.
Yes.
Okay, Sir, here is the case report of abdominal seizure under the guidance of Dr. Sanjeev Kale, our HOD and my guide. So the introduction is abdominal epilepsy is a rare condition usually found in the children. Sir, am I visible and audible?
You are visible and audible. Clear.
Okay. Thank you, sir. It is associated with gastrointestinal symptoms during epileptic activity. It is responsive to anticonvulsant treatment and EEG done during the periods of abdominal pain generally suggest of epileptic activity. Symptoms include stomach pain, nausea, and vomiting. Some patients may have tonic-clonic seizures. The cause of the patient that we saw in our OPD was an 8-year-old girl admitted in pediatric wards, was referred to the psychiatric OPD in view of abdominal pain query. The patient and relatives gave a similar complaint of abdominal pain associated with cramping, not associated with nausea or vomiting. The complaint had started since age 4 and had persisted. The patient also carried with her 2 discharge cards in which had been admitted previously for the same complaints and had been treated with multiple antibiotics, antispasmodics, and analgesics. The patient also carried with her reports of USG abdomen and pelvis, CT abdomen and pelvis, CBC, LFT, serum creat, urine culture, which were all within normal limits. After detailed interview, mental status examination, and physical examination, the patient was advised for a EEG. After reporting the EEG, which showed bilateral, bitemporal, and left central sharp wave activity throughout the record, the patient was put on 250 milligrams of divalproate once at night. The patient was asked to follow up monthly and she showed drastic reduction in the pain complaint of abdomen. On the subsequent follow-ups, the patient had near total improvement and reported no side effects and good tolerability. The above 3 EEGs, we had actually many people to the EEGs, but we could not fit in the regarding number of slides here. The above EEG is a pre-treatment EEG, and the below EEG is we took the EEG after 4 months of the treatment. And the conclusion of the case report is that abdominal epilepsy is a rare condition that is generally missed or misdiagnosed to be a somatic symptom, and the exact pathophysiology behind the mechanism of the cause of seizure is not known, though the symptoms improve with anticonvulsant treatment. And these are my references, sir. Thank you.
Okay, great. Ravi, I have 1 or 2 queries. What was the rationale of using divalproate? And was she maintained on this 250 milligrams throughout her course? And
Yes,
what are your concerns while starting a divalproate in a young girl?
Sir, actually, divalproate was, we could use any anticonvulsant, sir. It is not particularly divalproate. And divalproate in a young female, we could actually cause disturbances in her acne, hair loss, and reproductive cycle. We could cause disturbances, sir. But we generally, in our hospital, we are very well versed with divalproate. So it was my choice to use divalproate, sir. But nothing as a first line.
So did she experience any of these side effects?
No, sir. No, sir. We actually lost the patient after lockdown, sir. It was in 2019 that this patient came to us. We followed up with her for 4 to 5 months up till February, end of February, and after March she didn't come, sir, with us. Not anymore.
And she was on 250 milligrams all throughout when you saw her.
Yes, sir. Yes, sir. For 5 months we followed her up. For 5 months on 250 milligrams once at night. She was tolerating it well, sir.
Right. Okay. And so was it weight appropriate dose, or you just started with a low dose and you saw the response, that's why you continued?
Sir, she weighed 22 kilos, sir. When I weighed her, she was 8 years old and she was 22 kilos. So I approximately put her on 250 milligrams at night, sir, regarding her weight.
Okay. Thank you. All the best, Ravi.
Thank you, sir.
I think we can move to Dr. Srivastava. He is also ready. Dr. Srivastava? Dr. Srivastava?
Yes, sir. I'm trying to do the screen sharing. Is it visible, sir?
No, your screen is not visible. Please switch on your video. I think your video is off.
Yes, sir.
Dr. Srivastava, you are seen. Can you start now?
Yes, sir. Is it visible, sir?
Yeah, you please switch on your video.
Sir, the video is on, right?
No, video is not on.
No.
Okay.
Yeah, now the video is on. Can you share your screen, or you just want to read out?
Sir, I'm trying to share the screen, sir.
Can we move on to next if you are unable to do that?
No, so I think Divya, if you want to just talk about your presentation, it's okay with us. Without share screen, if you have difficulties with that.
I think he's using phone and
I know.
phone it is difficult.
Okay, so let's move on, and then we'll just let us know whenever you are ready, Adivya. Can we go to the next?
Dr. Sayyida Hira Fatima, are you there? Dr. Hira Fatima?
Yes, sir, I'm here.
Yeah, please start sharing your screen and start your presentation.
Okay. Video start karo.
Yes, your screen is visible. You can start now.
Good morning, everyone. I'm Dr. Sayyida Hira Fatima, Junior Resident, Department of Psychiatry from Kamineni Institute of Medical Sciences, Narkatpalli. Today, I'm going to talk about does hyperemic abnormalities predict the course and causality of new onset psychosis. It is a multi-center study from India. Hello.
Yeah, go ahead.
Yes. Although several researchers have attempted to study individual components such as baseline hemoglobin concentration and mean corpuscular volume, they ignored the hyperemic determinants of blood flow regulations and their progression over the period of onset to chronicity. Hyperemia is dependent on hematocrit, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration, including cellular elements which were proven as fundamental construct for blood flow velocities, as said by Bhaskar et al. In 2003. In the present study, we basically investigated the prevalence and predictors of common hematological abnormalities and to validate if hyperemic parameters progressively changes or they are linked to course or causality in patients with psychosis. So I had these three groups wherein group A were healthy controls, group B were drug naive people, and group 3 was people who were taking antipsychotics since the past 2 years. So I tried to assess and compare the prevalence of MCV, MCH, and MCHC in all the groups. So these are the hyperemic parameters. Next, it was the platelet count, hemoglobin, RBC concentration, white blood cell counts, and neutrophil to lymphocyte ratio. So this study was conducted in 3 areas. It was in the Konkan region, next is the Vidarbha region, and next is our institute, that is Kamineni Institute of Medical Sciences, Narkatpalli, Nalgonda, after being approved by the respective institutional committees. It was an accelerated longitudinal study design, cross-sectional, and a one-time assessment. So total, we had 423 patients with schizophrenia, out of which 115 were drug naive and 376 were chronic schizophrenics. And there were 504 healthy participants. They were evaluated by automated Porter counter. The values were assessed and PAN scale. And statistical analysis was done using SPSS. So the results were the platelet counts were significantly higher in the chronic schizophrenia group than in the newly diagnosed drug naive and healthy groups. So the neutrophil to lymphocyte and hyperemic parameters like MCH and MCHC were strikingly higher in newly diagnosed drug naive patients when compared to chronic and healthy controls. So in 1941, David Abramson, he published his remarkable study in the Archives of Neurology and Psychiatry, emphasizing that the schizophrenic group was characterized by an abnormally slow and highly variable rate of blood flow when compared to controls. So in the 1990s, there was an interesting finding which said that peripheral endothelial dysfunction was observed in schizophrenic patients, and there was more cardiovascular mortality in them when compared to general population. And then the research was on this perspective was even carried by Anna Caroline Israel in 2011. And the reason for slow blood flow, it lies with two fundamental constituents of blood, that is MCH and MCHC, which determines the dynamic velocity of blood flow in the brain, as said by Barter et al. In 2003. So in the present study, it showed the association of hyperemia in causality, course, and chronicity of psychosis using an accelerated longitudinal study design. I would like to conclude by telling that we found the association of hyperemia being more pronounced in onset, followed by progressive reduction in hyperemic scores during chronic course compared to the control groups. The preliminary findings suggest that hyperemia should be added or considered to the battery of descriptive variables as plausible contributory factor in addition to other factors that influences the modulation of neurodevelopmental as well as neurodegenerative processes and treatment response in course and chronicity of psychosis. These were my references. Thank you.
Thank you, Dr.
Hello,
Hira.
sir.
Yeah.
Thank you, sir.
Thanks for the nice presentation.
Thank you, sir.
Dr. Jay, do we have any questions?
I don't think so. There is anything in the chat box. I'll just. No, I don't think so. I think we can go ahead. Thank you, Dr. Fatima.
Thank you, sir.
So Daisy, are you there?
Sir, yes, sir, I'm here. I'm sharing my screen.
Thank you.
Is the screen visible?
Your screen
Yes,
is visible.
it's visible.
You're audible. Please, you can start now.
About a unique case which was presented in our OPD, psychiatric OPD, case of neuropsychiatric and vestibular manifestations in space occupying lesion. Intracranial space occupying lesions account for about 5 to 10 per 1 lakh population, and about 4 to 5% globally, and India was ranked as third highest country with positive cases of space occupying lesions. Also, they are the 10th leading causes of death. They present generally with physical symptoms as headache, nausea, vomiting, weakness, and neurological symptoms as seizure, focal neurological deficit, and behavioral changes. This graph shows which are the predominant behavioral changes in a space occupying lesion, personality being the most predominant. Now, the case of 45-year-old female who presented with chief complaints of vertigo, decreased hearing, recurrent fall, low mood, weakness of lower limb over 3. A general examination was within normal limit, but there was unstable gait present. Local neurological revealed hypertrophy of bilateral lower limbs by Babinski, positive in bilateral limbs, exaggerated knee reflex. A cerebral signs revealed negative Romberg test, negative heel toe test, finger to finger test, and on admission her MMSC was 15 and HAND was 14. MSc revealed speech with low tone, low volume, decreased productivity, increased reaction time, Affect was depressed with restricted range and decreased mobility. Attention and concentration were not sustained and maintained. Abstract ability was impaired. Immediate and recent memory was also impaired. Thought process revealed bradyphrenia, worries about her health, and some death vision. Judgment was impaired and insight was grade 3. She was predominantly concerned with her weakness and her recurrent falls. The intervention which we did for her was she was admitted in our ward for further evaluation. We thought her as being a case of depression, so we admitted her, and suspecting the falls to be of vestibular or cochlear origin, she was sent for ENT department for reference, which was within normal limit. Her pathological blood investigation, including routine investigations, thyroid profile, vitamin B12, they showed anemia, and rest was within normal limit. Neuroimaging was done to further divulge into the cause of recurrent falling. Neuroimaging via CT scan revealed a large space occupation with dimension of 4.4 centimeter into 4.4 centimeter into 8 centimeter, involving left cerebellar hemisphere, causing moderate compression of fourth ventricle with possibility of neoplastic astrocytoma. Then the patient was further transferred into neurosurgery department, where she was advised for a series of operations, and she was advised to visit psychiatry OPD also post surgeon visit. This is a CT which revealed a large space occupying lesion in left cerebellar area, which was suspected to be a neoplastic astrocytoma. This shows a histopathologic slide of pilocytic astrocytoma. Classic pilocytic astrocytoma architecture is biphasic with compact areas of neoplastic pilocytes in juxtaposition to loose microcytic stroma. Now the discussion about this case. Astrocytomas are tumors that arise from a type of glial cells in nervous system. Cerebellar astrocytomas encroach on the fourth ventricle. Astrocytic neoplasm of the cerebellum span the full gamut from blastoma. Early recognition of pilocytic astrocytoma is important because it can be potentially cured through complete surgical excision. The histologic architecture of pilocytic estroma consists of clustered fascicles of elongated bipolar neoplastic astrocyte cells. Now, it is also typical to find several markers of chronicity and degeneration, such as Rosenthal fibers, eosinophilic granular bodies, and nuclear atypia. The SOL this takeaway from my case, that the patient presented with her complaint of recurrent fall and her depressed mood. Other cerebellar signs, as I mentioned earlier, were negative. So through thorough focal neurological examination and high index of suspicion, lesion psychiatry is often diagnostic and should be obligatory for further and adequate management of the patient. These are my references. Thank you.
Thank you, Daisy.
Dr. Daisy, Minaj, can I ask?
Yeah,
yes.
please.
Okay, Dr. Daisy, do you have any follow-up on this patient? You refer to neurosurgery.
Yes, sir. Yes, sir. We followed her. We followed up with her for 2 months. Because from our institute, she was sent to another institute, and where she was operated for 2 surgeries. But after second surgery, she went into coma and died thereafter due to some surgical complications. It's a 1-year-old case, so she's died. She is dead currently.
Okay, thank you so much.
Okay.
Can we move on to next one, Dr. Anil? Metazapine induced somnambulism in case of geriatric depression. Dr. Anil?
Somnambulism.
Somnambulism.
Hello.
Anil? Dr.
Yeah,
Anil?
I am audible.
Yeah, you are audible.
Barely.
Yeah, barely.
Yeah. Can my screen is visible?
Yes, screen is visible, but you are like your voice is very low.
Hello.
Yeah, now you are audible.
Yeah. Good morning, everyone. Today we present a case report about metazapine into somnambulism in a geriatric depression. Somnambulism, so-called sleepwalking, and is classified as DSM-5 as parasomnia. It consists of complex motor activity, including eating, talking, and walking during sleep. Occurs in the first third of the sleep cycle. Case report exists for different psychotropic agents, somnambulism, including SSRI, bupropion, tricyclic antidepressant, risperidone, and zolpidem. Mirtazapine also has reported to induce somnambulism in two separate cases report. Today we present here a case of 68-year-old male with antidepressant who developed somnambulism on mirtazapine. Here is a case, 60-odd-year-old male, depression since 8 years. He started on 50 milligram of mirtazapine and shows 70% improvement over 3 weeks of treatment. The dose then increased to 30 milligram at night for further enhancement of improvement. At a dose of 30 milligram with 2 days of starting treatment, patient had episode of getting up and walking in the house and thus expression and some muttering to self. And the next day morning, patient claimed to no memory of what transferred to previous night. The episode were attributed to 30 milligram of butalpine as they did not occur when the dose was 50 milligram. Now the discussion is that somnambulism is occurs during the stage of slow sleep. Prevalence is uh, 1 to 2.4% in adult. The cause of neurological of somnambulism is unclear, but medication, high fever, and sleep deprivation and illness, obstructive sleep apnea syndrome have been associated with this condition. Mirtazapine is a non-androgenic specific serotonin antidepressant. It also potent antagonist of H1 receptor. And serotonin has hypothesis to be cause somnambulism, particularly at the 5-HT2 receptor, and the varying affinity of 5-HT2 and H1 receptor at different doses of mirtazapine could probably patient express sleepwalking episode excessively at the night dose of mirtazapine. The takeaway of message is that key clinician must be vigilant about the use rare yet dangerous adverse effect related to mirtazapine and concern when administering the drug in the elderly and special population. Here is the my references. Uh, Hello.
Are you done, Anil?
Yes, sir.
I have one question, Anil.
लेक्चर आहेत काय त्यांचं म्हणून नाही आलंय
Anil,
माहिती नाही
Hello.
Yeah, Anil, I have one question.
Yes, sir. Please.
Why did you call it as somnambulism and why not epilepsy? Why this episode was not your episode? How did you differentiate? Sorry. How did you differentiate between seizure and somnambulism?
Sir, yes, mirtazapine can cause increased slow wave sleep and deep sleep. And it's not it's just depreciated from the seizure disorder to no sign suggestive of any seizure disorder or other abnormality in such patient. EEG report is normal.
You did EEG after the episode?
Yes, sir.
Anything more to differentiate?
And yeah, it is depending on the dose. In a smaller dose, it's not somnambulism. I mean, when the mirtazapine dose is increased, the patient is suffering from the somnambulism.
I say that it was because you increased doses of mirtazapine, it was a seizure episode at night. And EEG, if I'm not wrong, then EEG only picks up 70% of the cases.
Yes, sir.
How do you differentiate? There's no problem. I just asked. Jay, do you have any question?
I'm good to go.
Can we move on to the next speaker, Dr. Sachin? Dr. Sachin, are you there? Dr. Sachin Yevle?
Yes, sir.
There is a resound.
Sir, I have one request.
Hello.
Sachin, are you there?
Yes, sir, I am here.
Okay, please start.
Good morning, sir. I am presenting a case regarding a retrospective chart analysis of 34 cases with the use of cerebroprotein hydrolysis in dementia in a tertiary hospital. Dementia is characterized by memory loss, cognitive dysfunction, and behavioral symptoms. And dementia affects the life of the patient, and it puts a huge, has huge psychological ramifications to the entire family. And we have very limited pharmacological interventions. One of the agent which is available is a cerebroprotein. So it is a nootropic as well as neurotropic, and it is manufactured in the laboratory by the enzymatic breakdown of lipid-free, porcine-free brain proteins, and it has multifold mechanism of actions. It helps in enhancement of neurogenesis with improved neuronal survival, and enhancement of neurogenesis and generalized neuroimmunotropic mechanism. It is available in intravenous, intramuscular, and oral formulation. And we carried out this study from 1st January 2019 to 31st December 2019. And all patients, they were given oral cerebroprotein, 90 milligram in BD dosage. And course was given to each patient for 3 months. And we took the help of our social worker department, because being it's a cost-wise not affordable to everyone. So for initial 3 months, our social department helped getting these medicines reimbursed. And we 2 scales, Edenbrook's cognitive examination revise scale and mini mental status examination, both before starting and at the end of completion of our therapy. So all our 34 patients, they received cerebroprotein, of which 30 were males and 4 were females. And their ages, they were all above 65 years, with range being 66 and 87 years, with mean age being 73 plus 73.76 plus minus 5.35 years. And majority had diagnosis as a mixed dementia with Alzheimer's disease and vascular dementia. And 10 patients had pure vascular dementia, while 2 had Alzheimer's dementia. So mean Edenbrook's scale score at the start of therapy was 15.35, and at the end of the course of therapy, it rise to 37.97. And mean mini mental status examination score at the start of therapy was 11.41, and at the end of therapy, it rose to 19.67. The changes in both these screening tests, they were significantly significant. And all these 34 patients, none had any major side effects. So the areas where benefits, they were noted. Changes in scores were modest, but even with modest score, when patients, they had certain areas of improvement, which were much relieving to their caregivers and which were appreciated by their relatives. 6 patients, they regained bladder control and 1 regained bowel control, which was a much big relief to the caregivers, as patients were independently able to have bowel and bladder activity. And their aggression and anger reduced markedly in 6 patients. Being caregivers, they are not available round the clock at home. So it was a much relief for them. And 1 patient had pathological laughter, which improved because of this cerebroprotein medication. So at the end, I would like to discuss that cerebroprotein is a good as an add-on with our regular acetylcholine esterase inhibitors and NMDA receptor blockers drugs. So oral formulation is available, and it is compared to injectable formulations, it is much cheaper. Though around one strip it costs 200 rupees. And main thing noted was, though cognition improvement was not that much, but other areas, just like where caregivers responsibility or their load can be reduced. So this was a much relieving to caregivers, and it is well tolerated. None of our patients showed any significant side effects. I would like to.
Thank you, Sachin. Cyan has this social worker scheme, which we can give medicines, even costly medicines, to patients. That is a very good thing.
Yes.
I wanted to know whether the other agents were added along with cerebroprotein, like
Yes, sir.
donepezil and mementamine were added.
Yes, conventional. It was in addition to our conventional, just like acetylcholine is donepezil and memantine. It was added on these two agents, sir.
Yeah, even in my practice, I see many cases where cerebroprotein has added advantage. Thank you.
Sir.
Any questions, Jay? Do you have any questions?
I think we can go ahead.
Dr.
Thank you,
Omkar. Thank you, Sachin. Dr. Omkar.
Hello.
Yes, Omkar,
Yeah.
you are audible.
Am I audible?
Yeah, you are audible.
Yeah.
Can you start your video and
Yeah, sure, sir.
screen share?
Hello. Yeah. Can you see the screen?
Can see your screen.
Yeah. So can you see the slide? Is the slide visible?
Your slides are visible.
Okay, thank you so much, sir. Good morning, sir. Good morning, everyone. This is Dr. Omkar, and I'm going to present a case report on lithium-induced bruxism. So lithium has been the drug of choice in the treatment of bipolar mood disorder since many years, and it was the first mood stabilizer that was discovered, and it has a narrow therapeutic index and a range varying from 0.6 to 1.2 milliequivalent per liter. The use of various psychotropic agents like lithium, it has long been associated with oral movement disorders like bruxism, orofacial dystonia, and oromandibular dyskinesia. So here it is. So here I am reporting a case of an 18-year-old girl who developed lithium-induced bruxism. It was correlated with elevated serum lithium levels, and it resolved after the discontinuation of the drug. So yeah, an 18-year-old girl was diagnosed as bipolar mood disorder and was well maintained on lithium carbonate 400 mg once a day and olanzapine 10 mg in divided doses. So she had exacerbation of symptoms wherein there were grandiose ideations and a decreased need for sleep and big talks, following which lithium was up titrated to 800 mg in divided doses. She developed grinding of teeth throughout the day, which would stop only when she would be asleep. So this is the first time that it had happened for that patient. Earlier, she had no such episodes after up titrating lithium or starting lithium. So she developed teeth grinding, and it would take place throughout the day, which would stop only when she was asleep. And she persisted even when she was eating and even when she was distracted. So she also started developing coarse tremors and gait disturbances, although her mood symptoms had resolved and behavioral disturbances had decreased. So there was no evidence of rigidity, no evidence of slurring of speech or any other extrapyramidal reaction. Physical and central nervous system otherwise was normal. As the symptoms were distressing, she was admitted and lithium was immediately stopped and serum lithium levels were sent for. She was then switched over to divalproate sodium 500 mg per day, and olanzapine 10 mg per day was continued. Her serum lithium levels were found to be 1.7 milliequivalent per liter, and all routine investigations were within normal limits. We had also sent serum creatinine phosphokinase to rule out neuroleptic malignant syndrome, but creatinine phosphokinase levels were within normal limits. Bruxism improved within 8 days of stopping lithium, and about 90% overall improvement was reported. At the time of discharge, the serum lithium levels were repeated and they had come down to 0.9 milliequivalent per liter. The diagnosis of lithium-induced bruxism was made on the available evidence. The Naranjo's algorithm was applied and the score was +5, which indicated that lithium can probably be a cause of the adverse drug reaction. The patient and her relatives actually refused a rechallenge with lithium, and eventually she was discharged on divalproate 1 gram per day or olanzapine 10 mg per day in divided doses. So to conclude, bruxism has been reported in literature with antipsychotics with SSRIs as well as with lithium. In this particular case, bruxism was correlated with raised serum lithium levels, and what was relieved on stopping lithium, which brought the serum lithium levels back to normal. So it is important for the clinicians to be aware of this rare but distressing side effect of lithium due to its common use in psychiatric disorder. Hello.
Yeah, Dr. Omkar, are you done?
Yeah.
So, Omkar, I have a query. Is there any other known treatment for bruxism other than stopping the psychotropic agent?
Sir, we had tried the drugs and we had tried. Mostly in this particular patient, we didn't try any other treatment, but one particular patient, I still remember, we had started the patient on buspirone. Yeah, we had started that particular patient on buspirone, and that particular patient had, that was responded very well to buspirone, and bruxism had stopped. It was a case of psychosis, schizophrenia, and she had obsessive compulsive features as well. So probably what we thought at that particular time was that bruxism was because of those OC features, and buspirone was given. It was because of increased anxiety. It was thought to be secondary to the OC features, and after buspirone, her anxiety calmed down a lot, and bruxism also stopped, as noted by a relative also.
Okay. So bruxism is known to have a very strong psychological basis, but then per se, other than NSAIDs, because the kind of pain that can be caused because of the grinding and the constant use of muscle, other than painkillers, I don't think so there are any known treatment for bruxism.
In literature, no.
Right.
Agomelatine, they say that agomelatine also helps in bruxism.
Okay.
I had one query. Can I ask, Dr. Jay?
Yeah, please.
Why this was not toxicity, lithium toxicity? I was wondering why this was not lithium toxicity, and you call this a side effect.
Yeah, it can be lithium toxicity also, sir, because the patient had tremors also.
Because once the levels were decreased like to 0.9, then
then the bruxism also stopped. Yeah, so we can say this is lithium toxicity only. But bruxism was not seen earlier as a part of, we had never seen lithium bruxism as a part of lithium toxicity in any patient.
Maybe it can be early sign of toxicity.
Yeah, it can be. It can very well be. Yeah, agreed.
Can we move on to next one? Dr. Sagar, you're there.
Thank you, sir.
Yes, sir.
Yes, Dr. Sagar, please start your.
Yeah, the video, the host, they have stopped the video. So can I ask them to allow me the video?
Yes, please.
Yeah. Yes.
You can start sharing your screen, Sagar.
Yes. Yeah. There. Just a second. Yeah. Is the slide visible, sir?
Your slide is visible, Sagar.
Okay. So good morning, everyone. I would like to present a real-world chart review study of the monotherapy and adjunctive therapy of vortioxetine in clinical practice. Now, as we all know, the vortioxetine is a novel antidepressant which is having a multimodal action. Like it acts on various ways. The main is the serotonin transporter inhibitor. Along with it, it antagonizes other serotonin receptors, that is 5-HT3, 5-HT7, and 5-HT1D. It is known to have partial agonist action on 5-HT1B and full agonist action on 5-HT1A receptors. Due to this multimodal mechanism of action, it is known to have a fast response in the treatment of depression with minimal side effects. It was US FDA approved in the year 2013 for treatment of depression, and it got available in India since October 2018. The added advantage of vortioxetine, what was found in various studies, was helpful in anxiety and treatment of OCD. There is very scarce Indian data as it is just a newly launched molecule. So we thought of doing a real world study and the chart review for looking at the utility and the efficacy of this vortioxetine. The following three psychiatrists, as mentioned on the screen, Dr. Sagar Karia, myself, Dr. Sayeda, and Dr. Avinash D'Souza, we participated in this study and we did the retrospective chart review. We had kept the records of all the patients who were prescribed vortioxetine. So we analyzed this record from 1st January 2019 to 31st December 2019. And vortioxetine, irrespective of the other drugs the patient was receiving, were included in this review. No specific scales were administered as it was purely a clinical study and the clinical experience study. It was not a formal double-blind study or anything randomized control trial. So no scales were applied, just clinical efficacy and side effects were noted. In all 131 patients we reviewed, the mean age, if we see, it was 38 years, range being from 14 years to 82 years. Majority were females, 72 of them, and 59 males. 64 out of 131 had received as a monotherapy, while 67 had received as an adjunctive medicine. 90 patients were started on 5 milligram and 41 had started on 10 milligram. Though the company and the guidelines say that we start with 10 milligram and then titrate the dose, but we had seen majority were being started at 5 milligram the dosing. 20 of them were being started newly for the first time the treatment of any psychotropic agents, and they were first started on vortioxetine, and the others were not getting better with the previous medicine, so they were shifted to vortioxetine or added on vortioxetine. 20 of them had comorbid diabetes, some had hypertension, and 6 of them had thyroid disorders. Surprisingly, if we see, again, as it is approved for treatment of major depressive disorder, majority, 83% were given for depression, but there were other indications apart from MDD where it was used. We can see 5 of them were having bipolar mood disorder, and in depressive episode they had been given vortioxetine. A few had anxiety disorder. Classically, I would like to mention that couple of them were given cognitive disorder and one for dementia, and a couple of patients for borderline personality disorder. Majority continued the medicines, but out of 131, 46 of them had stopped the medicines. 17 were lost to follow-ups. 3 stopped due to some side effects. 5 had to be stopped due to switch to mania. 10 of them found it too expensive, so they discontinued the treatment. And only 6 of them did not find much improvement, so they stopped the treatment. Coming to the side effects, if we see, 119 of 131 people did not have any side effects. 5 of them had gastric-like side effects of nausea, vomiting. Were switched to mania, out of which 1 more again went to depression, so he was added again to vortioxetine in lower doses. The discussion, it is a very effective in management of major depressive disorder as a monotherapy or as an adjunctive medication with minimal side effects. None of them had any complaint of sexual dysfunction after starting vortioxetine, and if you see, the mean age was 38, so they were typically young age group. But as I said, it was a no randomized control trial. It was just a clinical study. Further studies with RCTs, blinding and all, and head-to-head comparison with our routine antidepressants are warranted. Thank you.
Thank you,
Great.
Sagar.
Inaj, you want to ask something?
No, nothing.
I cannot leave Sagar without asking a question.
Yes, sir.
Sagar, tell me something. You did mention in your final discussion about head-to-head trials, but then I'm genuinely interested, curious, knowing the level of evidence of chart reviews, right? Because you three are excellent clinicians. I'm sure data-wise one can have discussions like kaise maintain kiya, kya rakha, but then no doubt about the clinical acumen of all three of you. So what is the level of evidence this chart reviews have? Because another student of you also presented chart review. So what is the level of evidence? If you can just throw some light on that.
Sir, the chart reviews definitely adds to our literature, because any new drug which is started, the only good clinicians or the academic clinicians, like in our college also for ECT, we keep our chart reviews. We do ketamine therapy, so we keep all those records with us only. And I think timely basis, if we review those records, and make some paper and give the evidence. So same with the cerebroprotein, which we did. We had kept all the records of injection cerebroprotein also, and we had published those data. Now it is the oral one we are in the process of publishing. So it is definitely adding to our literature. And any new people, if a youngster is starting, if he goes on the
behavioral therapy क्या
website,
दिया था?
so then he'll be happy to or confident to start this
Last
work. That
patient to
is
follow.
very helpful.
I feel as a clinician, these are also very important observations and pearls of wisdom, as they say. Not everything has to be evidence based. Experience also is equally important. Only thing, if we can get like a structure in a way that you can project with the same confidence as we do randomized control trials. So maybe while we are conducting chart reviews or while we are collecting data, if we can bring in some structure or some protocol to that, probably I think it will make even more sense, and we'll be able to say with a lot of confidence. अभी तू बोल रहा था तो थोड़ा confidence कम लग रहा था, but then so that's what I was saying.
Because now we are having this trial of vortioxetine in our institute. So I think soon we'll come with the scales and all, and definitely we'll be more confident with the efficacy and all.
All right. Thank you so much, Sagar.
Thanks, sir.
And the next one is Dr. Garima. Dr. Garima, are you there?
Yes, sir. Good morning, sir.
We have paper from Dr. Garima.
Yes, sir. Yes, sir.
Please.
Sir, is it visible?
Yeah, your slides are visible.
Yes, sir. Good morning to all present.
Your voice is slightly low, Garima.
Okay, sir. Sir, is
Hello?
it okay now? Yes, sir. Is it okay now? Hello.
Still, if you can speak louder.
Okay, sure, sir. Sure, sir. Good morning to all present. Sir, is it okay now? Good morning to all present. The topic for
you can start.
Yes, sir. Thank you, sir. The topic for today's poster presentation is enabling behavior in the vibes of substance dependent individuals. I'm a student of the DMCNH PG resident third year. Addiction affects not only the addicted person, but the entire family, where the family members, knowingly or unknowingly, they nurture, protect, and support the substance abuser. Enabling is a term which is used synonymously with the substance abusers for fostering their needs. Enabling, it is a psychosocial condition which is characterized by preoccupation and extreme dependence emotionally, socially, and sometimes physically. It is an attribute of human nature to help others, but sometimes this behavior might work as a double-edged sword. Enabling is basically disabling in a way that the enabler person, they sacrifice their own interest for their dependent individual. Now, the aims and objective of the study was that we need to study the enabling behavior among the spouses of substance abusers and coping strategies used by the spouses of the substance dependent individual. With the present study, we would like to direct the attention of spouses towards being an enabler knowingly or unknowingly and helping identify these behaviors. The materials and method used, we took a total of 100 patients in the age group of 18 to 60 years. 50 of them were the cases of alcohol dependence and 50 were the cases of opioid dependence, and the spouses, they were introduced. The patients, they met the dependence substance dependence criteria of ICD-10, and those who gave the consent for the study, they were considered for the study. The significance of the results, they were checked at p-value less than 0.05. The tools that were used, sir, am I audible?
Yes, you are. Please, Garima, go ahead.
Okay, thank you, sir. The tools that were used, they were the socio-demographic performer, which included the age, the gender, the educational status, the type of substance abuse of spouse, the duration of substance abuse of spouse, the Span-Fisher codependency scale, the coping questionnaire, and the addiction severity index performer. Now the results and discussion, all the spouses in our study, they were females. Majority of the spouses, they were educated up to matriculation. Overall, it was 50%. And amongst the spouses of alcohol, they were 56% were educated up to 10th. And opioid spouses, they were educated, 44% were educated up to 10th. 73% of the spouses that we interviewed, they were housewives, out of which 78% were housewives of alcohol dependent individuals and 68% were of opioid dependent individuals. Majority of the substance dependent individuals in our study, they abused substance from the duration range of 1 to 5 years, and the majority in our studies, they were having alcohol dependence was 36%. 14% of the spouses, they were not aware of their husband's substance abuse problem and the type of the substance they abuse. 26% of the spouses of opioid dependent individuals, they were not aware of their husband's substance abuse compared to 2% in case of alcohol dependent individual. Thus the spouses of alcohol dependent individuals, they were more aware of the substance consumption by their husband. The psychiatric morbidity was found in 53% of the substance dependent individuals, which was substance induced mood disorders. 60% of the spouses, they had codependency score which was more than 52.6, which indicated higher codependency. The Span-Fisher scores for alcohol spouses, they were 58% and 62% for the opioid spouses, which showed significant result in our studies. Now the limitation of the study, the limitation was that the present study, it included, the sample size included just the 100 participants. The sample was also limited to a one hospital setting. Another limitation was that due to small sample size, our study did not encounter any female addicts, thus their spouses, they could not be assessed. These are my references. Thank you.
Thank you, Dr. Garima. Dr. Jay, any questions?
Thank you, sir.
Dr. Jay?
Yeah. So what I wanted to understand is that how would you typically handle this case? So in terms of say spouses, whether they are aware, not aware, how would you handle them, and how would you handle a typical transference, counter transfer that you see in spouses of substance abusers?
Yes, sir. Thank you, sir, for the question. So when we interviewed the spouses, most of them, the spouses of the opioid patients, they didn't know, they were not aware regarding the substance abuse of their spouse. So we tried to ask them whether they put their interest before their husbands, or they still considered themselves like doing their daily work or jobs. But they said the priority, they themselves were not their priority at that present. They just tried to cover up the substance abuse patterns of their husband. So we tried just to give them a little hint regarding their enabling behavior, because most of them just in order to the quarrels they had at home, they used to just give their own husbands the substance from outside. They arranged it. So we acknowledged that, we addressed these issues, that they should stop it, and they should start they should take them to the de-addictions, and they should stop, not aggravate such behavior.
Okay.
Can we move on to the next? Dr.
Yeah,
Preeti?
sure. Thank you, Garima.
Thank you, sir. Thank you.
Thank you. Dr. Preeti Dugar? Dr. Preeti? Hello? Dr. Preeti, are you there? Dr. Preeti Dugar?
Good morning, sir.
Yeah, good morning.
Just a second, sir. Is the screen visible, sir?
Yeah, your screen is visible.
Okay. Good morning to all present. My name is Dr. Pratitya. I'm PG resident from DMC Ludhiana, Punjab, and I'll be presenting the poster of gender differences in coping strategies of the patients of bipolar depressive disorders. A little introduction into the topic. Mood is a diffuse, persistent feeling that stays for last hours, days, and longer, while emotions are short-lived responses to the stimuli that elicit
Dr.
adaptive
Preeti,
responses.
your screen is not visible. Poster is not visible. Can you share your screen?
Yeah, yes, sir. Yes, sir. Just a second, sir. Is it okay, sir?
Yeah, now it is visible. Thank you.
And emotional regulation is a part of individual's coping style, and we briefly has been categorized to the coping behaviors into the problem focused and the emotional focused coping strategies. The problem focused strategies include the planning and active coping, which has been defined as the stressor, and an emotion focused strategy, which is generally considered to be less effective, is mainly aimed at creating an emotional response to the stressor. The patients who respond to the stress with negative cognitive are complained of more depressive symptoms than compared to the others who use the same cognitive styles. It was found that the cognitive avoidance was significantly related to increase in anxiety and the depressive symptoms, especially over a time in women than in men. However, these studies indicate that women with particular negative cognitive responses styles tend to have more depressive symptoms, and thereby tend to have more depressive symptoms, and thereby it helps in predicting the future episodes of it. And the aims and objectives are we comparing both men and women with depressive disorder and their coping strategies. The material and methods, the inclusion criteria, the patients who met the criteria for DSM-5 bipolar depressive disorder, the age group between 18 to 60, and the HAM-D score below 20. Exclusion criteria was we excluded any other psychiatric comorbidity. The age below 18 and above 60 were excluded. Any history of substance was excluded. Intellectual disability. It was a cross-sectional study which was conducted on a total of 90 stable subjects who came on the follow-up in our OPD, and the sample was divided in three equal groups: the males with bipolar depression 30, females with bipolar depression 30, and healthy controls 30. The age was matched. The consent for the study and the socio-demographic performer were filled, containing the basic information. And the subjects were evaluated using the HAM-D scale and the coping strategies, the brief COPE questionnaire. Now the results. In our results, it was seen that female predominated the emotional focus strategies. As you can see in the graph, the blue are as indicated as females. The females were more usingly as the emotional support in the venting, positive reframing, and especially in the positive reframing, it was seen that the females who were highly educated were using these coping style more oftenly. And the males were using more commonly as problem focused, like distraction and other active coping, problem solving, and seeking social and instrumental support. Discussion. In a study, it was seen that males who used coping strategies as compared to the females who used emotional focus strategies. By the way of explanation for these findings were also described by authors like Motard and Patak et al., who suggested that these sort of differences were consistent with socialization hypothesis, which predicts that males are instructed to use more active, more instrumental coping behaviors, whereas females are taught to utilize more passive and emotional focus strategies. A limitation to the present study was it was just limited to 90 participants, and it was only limited to one hospital setting, which was in a big city, and due to small sample size, it cannot be generalized. These are my references. Thank you.
Any questions?
Yeah. Hi, Dr. Preeti, Dr. Shastri from Bombay.
Morning, sir.
Wanted to understand how effective were these coping mechanisms for the spouses? And if you would have, because when we are talking about bipolar disorder,
Yes,
it's a cyclic illness. If
Yes,
you say you think that in any other state or maybe the number of episodes would have made any difference in the coping?
Actually, thing is,
strategies?
actually, sir, we focused, especially in the females. We tried, we were using it as a predictor. The most of the females who were coming from a lower socioeconomic status and were less educated, we tried focusing, putting them onto more problem-focused strategies, and it was seen that we could predict that they had in future responses lesser number of episodes, sir. There was lesser of depression on the follow-up, sir. Yes, sir.
Okay. Okay.
Thank you, Dr. Preeti.
Thank you so much, sir.
Yeah.
Thank you so
We
much.
have Dr. Srivastav waiting. Can we allow him, Dr. Jay? And I wanted to give time, 2 minutes or 1 minute time to Dr. Simran and Dr. Makan. We had cut them, like Dr. Simran couldn't complete and Dr. Makan could. You're permitting, Dr. Jay.
Sure. So
we'll start with Dr.
Divya
Srivastav.
is ready, then Srivastav, yeah.
Sir, can you hear me?
Yes.
Good morning, sir. This is Dr. Adivya Srivastav, a junior resident first year in DY Patil Hospital, Navi Mumbai. My poster is regarding a rare case of adult primary nocturnal enuresis with the familial preponderance. So introduction, adult nocturnal enuresis is not a very common presentation. According to DSM-5 definition, there are certain criteria which needs to be fulfilled to diagnose a patient as a primary nocturnal enuresis. These are, first one, there should be voluntary or involuntary voiding of urine twice weekly for a period of at least 3 months. The second one is the child must have achieved the developmental and chronological age of 5 years. And the third one is it must cause some distress and impairment in the functioning to meet the diagnostic criteria. So the prevalence which we noticed was 5 to 10% in 5 years old, 1.5 to 5% in 9 to 10 years old, and 1% in adolescents 15 years and older. Plus, we have noticed that if the father is enuretic, there is more than 7 times risk in the child to be enuretic. The concordance rate was more in monozygotics than in dizygotics. So as we noticed above, the prevalence of enuresis decreases with increasing age. So according to a research published by Young et al. In 2004, the adult nocturnal enuresis prevalence was found out to be 2.3%. And 75% of enuretic children have first degree relative. So it has been noticed that there are certain psychosocial stressors which are directly or indirectly related to the development of nocturnal enuresis. These could be birth of a sibling, hospitalization between the ages of 2 to 4 years, start of a school, divorce in parents, or if there's a change or there's a move to a new environment. So our case report is there was a 22-year-old graduate Muslim lady who presented to our psychiatric OPD with complaints of bedwetting 4 to 5 times per week since childhood. And the patient was really distressed about these symptoms. The birth history was uneventful. I mean, it was a full-term hospital delivered child, cried immediately after birth. Birth weight was around 2.7 kgs. All the milestones were normal. However, the bladder control was never achieved till date. So for these complaints, the patient first visited to a homeopathic doctor 3 years ago, after which she didn't get a response. So she changed the doctor. She went to a psychiatrist, and this is the third time the patient came to our OPD. And the patient did not have any history suggestive of psychosis, substance abuse, or depression. No history of diabetes or hypertension. Interestingly, in our case, there was a positive family history. Like it was reported that 6 to 7 extended family members had the history of enuresis. However, the mother did not tell who all, but she was like 6 to 7 extended family members were there. So on mental status examination, we found that the mood and affect was anxious. So we did some investigations to rule out the organic etiologies. Like organic etiologies, it is very important to rule out the organic etiologies to give a diagnosis of primary nocturnal enuresis. Like organic etiologies like urinary tract infections, obstructions, or genitourinary pathology such as obstructive uropathy, spina bifida, and other organic disorders like polyuria and enuresis, like diabetes mellitus and insipidus, they can present as polyuria and enuresis. So we tried to rule out all these organic etiologies, and we did USG abdomen pelvis, which stated normal hematobiliary system, normal size kidney, no urinary calculi. Urine routine was normal. HbA1c was 5.3%, which is normal. Estimated average glucose is normal, and serum creatinine was also 0.7 within the normal limits. So discussion, we organic etiology was ruled out, and DSM-5 diagnosis of primary nocturnal enuresis was given. And the patient and relatives were counseled. The treatment which we started was tablet clomipramine 25 mg HS. We started this on the second visit of the patient, because in the first visit we tried to rule out organic etiologies by doing the investigations. So but the patient, after that, the patient and relatives did not follow up. So the possibilities could be like the patient must have responded to the treatment and has continued the treatment, or like before, the patient has a habit of changing the doctor, so she must have changed the doctors. And we have reviewed the literature, and we actually found out that there are not many reports at present regarding the adult primary nocturnal enuresis, their treatment and follow-up. So to conclude, I would like to say that adult nocturnal enuresis is only 1% prevalence in literature, and this 1% could be because the cases are probably going underreported because of the social, cultural, and the financial constraints from the family and society, the stigmas which are there in the society. So the patients do not actually follow up, and even if they don't get the treatment, they have a habit of changing the doctors. So this 1% prevalence which is there in the literature could be because of the cases going underreported. So we can finally say by concluding that the eyes can see only what the mind knows. So and the treatment, I would like to say that the first step in any treatment plan is appropriate toilet training and record keeping of the same to determine the baseline and follow the child's progress. We can also use behavioral therapy, alarm therapy, and pharmacotherapy. In behavioral therapy, we can do like restricting the fluids just before going to bed, and night lifting to toilet train the child. This can be included in the behavioral therapy. Then alarm therapy can be used, in which there is a battery operated device that can be attached to a child's underwear or mat. Then the alarm is triggered as soon as the voiding begins. Like there is a circuit which gets completed on getting wet, so that there's an alarm which is triggered, and it emits a loud noise that can awaken the child. Pharmacotherapy we can use, like we used clomipramine 25 mg, we started with it. And other things, other medications which you can use is desmopressin, which is a synthetic analog of vasopressin, which can be administered as a pill or as a sublingual melt or as a nasal spray. And its effect can last up to it works by reducing the urine production at night, and this method is optimal when no fluids are ingested in the evening. Adverse effects of desmopressin could be a hyponatremic seizure, because it is an antidiuretic and can increase the fluid amount in the body. other drugs which we can use is reboxetine, which is a norepinephrine reuptake inhibitor, 4 to 8 milligrams, which we can use. And it has a non-cardiotoxic side effect profile, and so it would be better
Dr.
than
Srivastava, I
any
think you have
other drug.
exhausted your time.
Okay.
Thank you for that excellent presentation. Very did we in history ascertain that it was truly primary enuresis and not secondary? Because generally speaking, developmentally, females are found to have an excellent bladder control and much more earlier than males. So whatever enuresis primary cases that we get is more in males
Yes.
or boys than in girls.
Yes, sir.
So this is definitely an atypical presentation.
Yes, sir.
So did in history we ascertain that particular aspect? Because 22-year-old
Yes, sir.
and sought treatment only 3 years back, never before
Yes,
that.
sir.
So till she was 18, they were not even went for any treatment.
Yes, sir. This is what is very atypical about this case is that the patient did not seek any treatment till she was 18 years, and for the first time she went to a homeopathic doctor when she was 18 years, and like it was a purely nocturnal enuresis case. Like according to DSM-5, there are 3 cases: nocturnal, diurnal, and nocturnal or diurnal. But this case was mainly nocturnal. So the patient hid her symptoms till 18 years, and it was a purely primary neurotic
That's what
case.
Dr.
You
Jay is
can't hide
asking.
anuretic. You can't hide enuresis. No, it's there.
No,
There is
not
bedwetting.
not like yes, sir. Sir,
And-
but might be, sir, that the parents must be knowing, but they didn't seek treatment till the age of 18 years. And they actually told me that they're looking for her marriage. So might be because of the, like they must be thinking that it would get revealed. So they started seeking the treatment at the age of 18 years. And this was the third time that they came to us.
any obvious psychosocial stressors that you find in her? She was anxious about her illness, and other
In
than that, any other
her,
things?
sir, actually, the patient was a young Muslim lady. So I think that the social background is like it. She must have thought that she should not seek treatment because mainly because of the social stigma. So this might be the psychosocial stressor in her. Plus, one of the other psychosocial stressor could be birth of a sibling. She has 4 to 5 siblings. So as we noticed, as I've already mentioned, one of the psychosocial stressors that birth of a sibling could affect this. So this might also be the psychosocial stressor in this lady.
All right. Thank you, Adivya.
Thank you, sir.
Can we ask Simran to conclude her thing, because her net was unstable and she wanted to speak. Simran,
Yes, please. Go ahead, Simran.
Yes, sir. So as I presented, sir, the patient presented with symptoms of tingling and numbness, giddiness. They only lasted for a few minutes. But sir, should I start over? Should I start?
No, just
you just
conclusion.
give your brief, because we could hear quite a bit. So if you can just conclude.
So the symptoms only lasted for a few minutes. They would always occur when the patient, they would occasionally occur when the patient was unaccompanied. They would resolve spontaneously in a few minutes. And it was not associated with typical features that would be found in a seizure disorder. And so we looked at the anatomical and the classification aspects of such symptomology. And so we had taken an EEG for the patient. So I have some sharing problems, so I cannot share my screen with you. But on my poster, sir, I have a record of the patient's EEG, which shows temporoparietal sharp waves, and so predominantly parietal. So, sir, we look at the overall picture, which states that seizure spikes originating in the second sensory area. There can be focal somatosensory symptoms, associated with autonomic aura. And sir, since the EEG findings were present, we concluded that the patient had focal somatosensory seizures.
Okay, thanks. Were you looking at any differentials when you started taking the history at first?
Yes, sir. So, sir, since it was very somatic complaints, we did look for an in-depth detail for anxiety or depression features, but could not be found. And then, sir, it could just as well have been a functional, like a functional cause. But, sir, any specific psychological stresses could not be elicited. And, sir, we also had to rule that out since the test EEG showed positive findings, and that's symptoms occurred. These episodes occurred when the patient was unaccompanied, and they would resolve spontaneously within a few minutes, and only 3 to 4 episodes in the last 8 months. Thus, we were able to rule out all these other causes.
All right, great. Thank you so much, Minaj.
Thank you, sir.
Yeah, we tried to contact Dr. Makan, but he was not online. So I think we are done with most of the all of the presentation.
Right. So, would you like to conclude, Minaj, by thanking the organizers and the IABP team?
Thank you, Dr. Jay, for co-chairing the session. Directed it very well, asking innovative questions, and thank you. I would Indian Association of Biological Psychiatry for giving us this opportunity to chair the session. I'd also like to thank the President Dr. Prabhat and Honorary General Secretary Dr. Avinash D'Souza. I would also like to thank Executive Committee and all the people who have taken pain to attend this session.
One
Thank
minute,
you, one and all.
Minaj. Yeah, Jay and Minaj, thank you so much for being with us for such a long time through the morning. We have a task for you all before you all go, that maybe by today afternoon, since you all have just been through all the presentations, you all could tell us who the best 2 posters were, because we have 2 prizes for the best 2 posters. And the thing is, we would like you to judge for us which the best 2 posters are, so that we would probably give 2 prizes. So you could let us know by afternoon. We will make sure that the prizes reach them. At the end of the session, of course, since we are in a hybrid mode, I don't have anything to offer you all. I can't even come and hug you all. So, but anyway, thank you for being there. And just to let everyone know, we've had 990 registrations online for the conference. Wow. So, which has never happened, I think, in the history of IABP ever. For an IABP conference, it's never happened. And probably we'll definitely cross 1,000 by afternoon. Even for the poster session, we've had around 89 people who've logged in the morning. So that itself is shows the interest that people have had. And I thank you for being there. I think we'll end the session and everyone will join us for the inauguration at 1 p.m. today. Yeah. Okay. Thank you. Yeah.
And thank you,
Thank you,
Avinash.
guys. Bye, Minaj.
Okay. Bye, bye, Jay.
check, check. Check test, check, check. Check, check, check. Check, 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 check. Hello, 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 hello. Check, check. Hello, 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 hello. Check. रुको. Check, 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 check. Test, test, test. Check. Hey. Check, 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 check. 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 Hollow, hollow. Test, 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 test. Check. Hollow. Test. Hey. Check, check, check. Hollow, hollow. Check, check. Hey. Check, check.
Hello, 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 hello.
निशांत सर फोटो क्लिक करा रहे हैं क्या?
Sir, we are live in 5 minutes.
Okay. Okay, okay.
Sir, we are live now.
And my video. You can see me now. You can see me now?
Yes, sir.
Okay. What about Prasad? Prasad Rao?
Mohandas,
Yes,
namaskar.
sir. Yes, sir.
We are starting in a few minutes. We are
No problem. No problem.
Yeah, lock in.
Okay, എനിക്ക് ഒരു ക്ലാസ് നാല് നാല്
Check, check, check one test. Hey, check, check.
Hello. We started inauguration online. Today 1 o'clock. Okay. Okay. उनसे बोलो कि बीच बीच में आपका फोटो भी दिखाते रहना। हाँ? मेरा लैपटॉप कहाँ है? उधर ही। हेलो, हेलो, हेलो। गौतम दादा कहाँ है? हाँ हाँ, उनके पास रख दिया। उनके Amita is going to give me one new iPhone 12 and Samsung. हाँ? हाँ? वो भी 256 GB का।
Good afternoon, everybody.
Good afternoon. Gargi, how are you, man?
I'm fine. Thank you, sir. Namaskar.
Hello. Good afternoon, everyone, and I would like to welcome everyone to the inauguration function of the 16th Annual National Conference of IABP. I would like to invite our dignitaries on the dais. Our guest of honor, Dr. Gautam Saha, a president of the Indian Psychiatric Society, accompanied by our president, Dr. G. Prasad Rao. One of our founder members, Dr. Rajesh Nagpal, is here with us. It's a unique afternoon for us here because we are organizing this conference for the first time in a hybrid mode. And we would like to start the inauguration function with a digital lighting of the lamp with the playing of the Saraswati Vandana. So wherever you all are, I would just request you all to sit still and be with us for the inauguration.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It now is my pleasure to invite our president, Dr. G. Prasad Rao, sir, to give his presidential remarks.
Thank you, Avinash. Over 1,050 participants who have registered and who are slowly getting logged in. I welcome each one of them. I'm very happy to preside over this sweet 16 ANSI app. I'm also proud to be the president during the wonderful teenage years. About 16 years back, about 15 founders following and during a World Federation Congress of Biological Psychiatry. Mohan Das, Anukant Mittal, Rajesh Nagpal, myself, Venu Jawar, Dr. M.S. Reddy, UC Garg, Sunil Mittal, and others have joined together to form this Indian Association of Biological Psychiatry. We have seen at least 15 congresses before, 3 world congresses which has a brand of itself, the Global Congress of Biological Psychiatry, where we boast of the rich academic content from the world biological psychiatrists. We are proud to join here, and historically, this is probably the first hybrid congress for the Indian Association of Biological Psychiatry. Already we started in the morning. There's a heavy demand. 16 posters were presented in the morning, and they are one of the best qualities posters already. We also have a free paper session tomorrow. but most important, the real biological psychiatry research across the country is being presented, showcased by the best speakers in today and tomorrow. I personally welcome each one of you for this Congress. This year already 1,050 participants registered and it's still ticking. So at the end of the day, maybe we'll be crossing quite a big number, and that's a record. Being a hybrid virtual mode Congress, we are probably attracting much more people than who are live, but I'm proud that we have crossed 1,000 members. During the midterm online virtual Congress this year, we had a wonderful lecture by Ganesh Venkat Subramanian talking on the TDS and the neurostimulation in psychiatry. We had 2 workshops done by Avinash D. Souza on brain stimulation, RTMS. During the year and during the last 16 years, we have actually 3 great books released, and today on this platform of hybrid, in a while, we are going to release the first e-book, which I'm going to release soon. I'm very proud, and during the year, we also had 2 EC meetings and 2 FMB. The way forward and looking forward for this biological psychiatry, the new team is going to join us, which I'm going to announce at the end of this. But I'm proud to welcome Dr. Gautam Saha, the President of Indian Psychiatric Society, for this meeting. Welcome, sir. The chief guest for this meeting in this virtual meeting is none other than our mentor, E. Mohandas. E. Mohandas is the only Indian who was awarded the International Award by the World Federation of Biological Psychiatry for the best mentor. Welcome, Mohandas. And here, sitting with me, my dear friend Rajesh Nagpal and Avinash, who has been my heart and mind over the last 2 years. We have conducted, I think, last year National Congress quite well, and this is my proud privilege to welcome each one of you. Maybe this is a moment which I cherish, but I would already like to announce 2 important things. Tomorrow between 9 to 10, there is a competition for the IABP Asha Award. 3 presenters would be presenting between 9 to 10. And today already in the posters, 2 important contributions were recognized. One is Sachin Evelyn and Ravi Kiran. They are the 2 best poster presentation in this conference. Thank you very much. And I now invite our guest of honor, Dr. Gautam Saha, to bless this conference.
Thank you, sir. Good morning, ladies and gentlemen. Dr. G. Prasad Rao, President of IABP. Dr. E. Mohandas, virtually present, the mentor of IABP. Dr. Avinash D. Souza, the Secretary of the IABP. And my dear friend and one of the other mentors of IABP is Dr. Rajesh Nagpal, sir. I'm really happy today to be present here. Only I have seen also Darpan. I'm really happy today to be here because it is the first conference I am attending after becoming the President of the Indian Psychiatric Society. IABP is not very new for me because IABP, I am also one of the founder members. I always love IABP because of its scientific activity. Very much concentrating on the scientific activities always. They are always organizing the program, conferences are full of scientific activity and the newer things. This time also, not an exception. We are talking about next 2 days on newer techniques in mental health or in psychiatry. It is very important, you know, there are lots of things came in the last 5 to 10 years, starting from RTMS, TDS, deep brain stimulation. There are lots of things, especially in India also, it is available, widely available almost. But till we have to go long time. And there are lots of newer techniques have come, and we have to know, every psychiatrist, we should know what are the techniques, how to implement it, and what are the benefits for the patient side. So I wish this program is a grand success, and be with us with IABP, and we'll definitely, from the platform of IABP, the scientific materials which are given today and tomorrow, it will be really not only help the psychiatrists, it will help the mental health. With this short comment, I want to stop myself here. Thank you. Thank you so much. Thank you, everyone.
It's now my proud privilege to invite Dr. E. Mohan Das, our founder, member, mentor, guide, and someone who needs no introduction in the field of biological psychiatry in India and abroad, to please say a few words. He's our chief guest for the inauguration. Sir, you're with us virtually.
Yeah, I am.
Can you hear? Yes,
I am here.
Yes.
Yeah. President Dr. Prasad Rao and my dear friend, the current IPS president, Dr.
So is your
Gautam.
camera on, sir?
My camera is on.
Yes. Okay, sir. Yes.
Is it? Am I audible?
Yes, sir. Yes.
Yeah. So respected IABP President Prasad Rao and the chief guests, my friend Gautam Saha, the current IPS president, and his first meeting after he became the president, and my dear friend Dr. Rajesh Nagpal, who is in the podium, and Avinash D'Souza, who is standing, and all other officials of Indian Association of Biological Psychiatry, and dear friends. At the outset, those people who are interested in biological psychiatry would like to know how this all got evolved. The first biological psychiatry event happened in 1974, in Buenos Aires. And in that year, September, World Federation of Biological Psychiatry was formed. However, in Stockholm Conference in 81, it was called World Federation of Biological Societies for Biological Psychiatry. There's a reason behind it, which I will not talk about it. In India, how did we form this thing? We had a conference of the Second Asian Biological Psychiatry at Seoul in 2004, where some of our friends, led by Dr. Anugand Mittal, we had a discussion with the Joseph Zohar, and later in 2005, Vienna Congress, we had some preliminary discussion, and we thought of forming Indian Association of Biological Psychiatry, and under the leadership of Anugand Mittal. That is how the inception of Indian Association of Biological Psychiatry happened. And like-minded people joined. We had our first Congress academic event at Dhaka, where Joseph Soher himself was present. Another speaker whom I remember is Pratibha Murthy. I mean, it was a wonderful event. Now, in 2019, the 15th Congress at Agra, which I could not attend. My friend was a chief speaker, I think, in Mali. Gautam and Garg, Uttam Garg organized that program. In 2019, some of us were there in Vancouver for the World Congress. That was at that time, Dr. Takeda was handing over the responsibility to our Lakshmi Yadav. Lakshmi Yadav is the current president of World Federation of Societies for Biological Psychiatry. So much so for that, and we had already organized 15 meetings, Indian Association of Biological Psychiatry Scientific Program. This is the 16th event. And as our president, Prasad, has already told that because of the COVID, this has to be now, that is the 16th conference. And I still remember, I will not forget, those backbones of the society in Anugam Mittal, Rajesh Nagpal, Prasad Rao, M.S. Reddy, Sunil Mittal, Gautam Sahab, Avinash D'Souza, Pradeep Kumar, now Pradeep Kumar and his friend Nitin, and all the biologically oriented psychiatrists from NIMHANS. We had a good support, especially the researchers, Venkat Subramaniam, Narain, Vivek Benagal, like that it goes on. I cannot name each and every one. And we had good inputs from KG Medical College in Lucknow. Lucknow people, they were interested. Chandigarh people were very supporting for us. Apart, Delhi people were supporting us. All over India, we had support. I won't say, I don't forget Vihang Vakia from Bombay. The good researchers in biological psychiatry, I am not a researcher in biological psychiatry. Chittaranjan Andrade, Venkat Subramaniam, they are all stationed up in NIMHANS. And I'm happy that Venkat will be joining, Narain will be there, and all others. I don't know whether I am forgetting anybody. Many youngsters had the opportunity to present at the world venues because of the efforts of the Indian friends. And Dr. Prasad Rao, who has done a wonderful job for the world of the Indian Association of Biological Psychiatry, he has already commented on our GCBP program, which was internationally and even nationally were a good scientific extravaganza. Especially the first one, people really they were so happy to join it. But I would request, I mean, it is my wish, let new people, young people, those people who have done presentations in poster, they got awards, and others, they let them join hands together and come forward to join World of Indian Association of Biological Psychiatry to enrich the scientific background and also, if possible, some of the research held in India. They will be of health for us to project our image abroad. The next Congress, World Congress, is in Vienna in 2021 in June under the leadership of Siegfried Casper and the team. And I hope maximum number of Indian delegates and faculties join. Let me just, Prasad, am I to declare it is open? Yeah, let me just declare this 16th annual National Conference of Indian Association of Biology Psychiatry open. Let the participants get a rich scientific experience. Thank you very much.
Thank you, sir, for your words of wisdom and taking us back down memory lane through the history. Now it's my privilege as the secretary of the Indian Association of Biological Psychiatry to just give you a review of the work done during my tenure. During my tenure, we've had two conferences, national conferences of the Indian Association. We've had one international global conference of biological psychiatry organized with the Indian Association at Mumbai, which had over 13 international speakers attended by over 800 delegates. Today's conference is a unique one because it's in a hybrid mode. We've crossed 1,020 registrations, which has never happened in the history of IABP. Apart from that, I've had a number of people who have been messaging in and saying they love this mode because they can attend to specific talks, attend to specific events while carrying on with their routine, which is something which is unprecedented. We've released one book on recent advances in biological psychiatry at the GCBP in Mumbai. There's one more book which would be released a little later here today by Dr. Prasad Rao. I've had a great team to work with. And all I can say is my thankfulness to all the EC members, to our president, and of course, a big thank you to Dr. Prasad Rao, because if I've had the ability to fly, he's been the fuel beneath my wings. So thank you. And I would now like to invite Dr. Prasad Rao to please present the election report.
It's my privilege to also announce that I think I did forget during the World Congress at Vancouver. We had certain young biological psychiatrists who were selected by the World Federation, and I have Darpan Kaur here and few others from our country whom we nominated and were selected. So this trend has been going on. Having said that, we are proud that the young biological psychiatrists are really bringing great names to us. Now, things have to change to a much better water. We are just crossing the young teens to a little older teens. The new team, as decided by the FMB meeting, the new president is Dr. Uttam Chand Garg. Dr. Garg.
Thank you. Thank you very much.
I'm sure you're going to take, though I'm going to hand over the baton to you at the end of this Congress. I congratulate you and I wish you all the best. I'm sure you would take the responsibilities of lifting this association to a much greater heights. There are two vice presidents. The senior vice president is Dr. Sunil Mittal from Delhi. Dr. Mittal, hope you are there. And Dr. Pramod Kumar from Chandigarh. These are the two vice presidents. The senior vice president is Sunil Mittal. Then the Secretary General the baton is going to change from a very responsible Avinash D'Souza to another responsible Ruksheda from Mumbai. and the editorship is changing from Nitin Gupta to the new editor is Dr. Aleem Siddiqui from Lucknow.
Thank you,
And
sir.
the treasurership is changing from Jay Shastri to Prasanjit. We have the new Joint Secretary Abdul Majid, and this committee has also decided that there will be a new scientific committee which would guide through the 2 years, both for GCP, BP and the IABP Science. The chairpersons are Dr. Gautam Saha and myself. The other convener is Dr. Rajesh Nagpal, and members are Anukant Mittal and Smita Deshpande. Thank you, Avinash, for helping me in receiving the nomination. There were other 2 members from which the FMB has nominated. One for the web committee and web projection, Dr. Darpan Kaur, and Dr. Atul Ambekar and Janardhanan would be the scientific leads, and they would be in charge of the scientific research committee, which is the newly formed committee from now onwards. Thank you very much. Now, with these words, now this is my proud privilege to release this book. I hope you are seeing the recent advances in biological psychiatry, very ably edited by Nitin. I thank Nitin for his perseverance, and this is incidentally again historical milestone because this is the first e-book we are publishing, the recent advances in biological psychiatry, where all the national and international authors have contributed significantly to this book. May I take this opportunity to congratulate Dr. Nitin and of course Avinash, who coordinated all these things together, along with Pramod Kumar, Ashwin Mohan. So with these few words, I think we'll close the inaugural function. I would now request before closing to request Rajesh Nagpal to bless this conference. He's one of the founder member and a previous chairperson and past president of the Indian Association of Biological Psychiatry.
I thank the president, the secretary of the IABP, the guest of honor, Dr. Gautam Saha, Darpan Kaur in the audience, and all my friends sitting there, including Dr. Mohan Das, my mentor too. Indeed, it's been a very long journey in the last 16 years. And the most gratifying thing is for this hybrid mode, we have 1,000 plus participants. We'll be having the GCBP in the month of August in New Delhi. It will be again in a hybrid mode with about 29 satellite centers and main console in Delhi. We expect the same audience and a larger audience. And we solicit your comments, your initiatives in this regard. It's indeed very gratifying to be here and very gratifying to see a new change of guard. So from the entire team here, God bless the IABP. Thank you.
So we'll close this national anthem. We'll have a national anthem to close the inaugural function.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Yeah, you will announce.
Not. Hi.
I welcome all of you now to the first session of the conference. The chairpersons for this session are Dr. Pramod Kumar and Dr. Nitin Gupta. Dr. Pramod Kumar is a consultant psychiatrist with a private practice in Chandigarh. He is the chairperson of the IPS Technology and Psychiatry Task Force. His prime areas of interest are addiction psychiatry, general psychiatry, marriage and sex therapy. And he's been recently honored with the International Fellowship of the American Psychiatric Association. Dr. Nitin Gupta is a consultant psychiatrist in the private sector since October 2019. He's worked as a professor of psychiatry in the Government Medical College and Hospital, Chandigarh, with additional in charge of being the medical superintendent of the Mental Health Institute, Chandigarh. His areas of special interest are psychotherapy, clinical psychopharmac, risk management, community, and rehabilitation. And I also know he has a special interest in long-acting antipsychotics. I welcome both our chairpersons. Are you all with us, Dr. Nitin Gupta and Dr. Pramod Kumar? Sir, are you all there?
Yes.
Yes. So please take over proceedings. Yeah, thank you.
Thank you, Avinash. And can you confirm? Am I audible to you?
Yeah. You are audible.
Okay.
And visible too.
Yes. Thank you. And my co-chair, Dr. Nitin Gupta, is also there, I suppose.
Yeah.
Yes.
Yeah. Okay. Now, to begin like an opening batsman for this annual conference, the first topic is the first speaker, Dr. G. Prasad Rao, and he is the president of almost all the organizations. He is going to speak about biomarkers in psychiatry. I think this is something which we have been hearing for the last a decade or more, how biomarkers are going to make the understanding of psychiatry disorders and help us in treating people with this understanding. So over to Dr. Nitin. You want to add something?
Let us hear Dr. Prasad Rao.
Okay, now
to hear the president.
Okay.
Thank you, chairpersons. It's my privilege both to have you both as chairpersons and also as a privilege as a president of the Indian Association of Biological Psychiatry to give this talk. The biomarkers in psychiatry, I thought I will have a peep look into the future. The way I would wish to go is to start with the history and the definitions of biomarkers, the types of biomarkers in psychiatry, of course, the serum, the metabolites, the neuroimaging, the changing scenario of CSFs, and finally, a few words on the critical usefulness of the biomarkers. But I think we have to look for the future, and that's how I'm going to end. There's no conflict of interest, and except I'm a clinician and a researcher, so I do carry a bias, as everyone in the field of any science have a bit of bias for themselves. To start with, can we differentiate our psychiatric disorders from one another biologically? That's the greatest question which needs and probably is we don't have a clear-cut, lucid answer at this point of time. But when we take an example, as you see in this cartoon, when 5 decades back, we try to understand the theories and myths of understanding of schizophrenia. It was like 6 or 7 blind people giving their own theories. But it did change the picture. For example, it was said it's a developmental disorder. It was said a spiritual breakthrough and not a nervous breakthrough, like somebody who are anti-psychiatrists like Lang. It's a sane response to an insane world by SARS. It's due to this schizophrenogenic mother, but everyone felt it was due to dopamine. Some of these things did change. For example, mother is no longer being kind of attributed, kind of a thing. Likewise, for example, the anti-psychiatric movement did fade out with evidence coming from the biological psychiatry. The dopamine still stands, but a lot more we need to understand. We do think it's developmental, we do think it's dopamine, we do think it's autoimmune, but it's much more than this. But the problem, as more than 100 years back, dementia praecoxi, as enunciated by Kraepelin, from that point, even Kraepelin felt it is a conglomerate of symptoms, positive symptoms, negative symptoms, affective symptoms. But what has changed in the recent times? The cognitive deficit seems to be, though even Kraepelin has hypothesized. So can we diagnose schizophrenia based on all these things together as a single entity? But we all know this disorder in the end leads to social occupational dysfunction, and it's a chronic disease. Likewise, you take the second most common psychiatric disorder of importance, though, is bipolar disorder or the mood disorders. Even there, we try to look them as symptoms, as enunciated in this slide. And to add this, the newer concept in the last 3-4 decades is the comorbidities, both comorbid medical disorders, as you can see here, or the comorbid psychiatric disorders. What is changing? And the other disorder which I would take for the sake of the discussion of today is the dementia. What we now know very clearly is almost there are other etiogenesis we can have in as a biomarkers for high blood pressure, diabetes mellitus, high cholesterol, obesity, but then the real causes for dementias are much more than this. The most important disorder in the last 4 decades, which was benefited by the research of biomarkers, is cancer. And there is no gainsaying to say that the treatments of cancer has changed based on the biomarkers identification. But if you want to clearly define a biomarker is a characteristic that is objectively measurable, evaluatable, and is an indicator of a normal biological process, but it should also indicate the change in the pathological process. And finally, that biological process or response should be beneficial in the therapeutic. So this is probably the best definition given by the biomarkers definition working group, which sat in this world it was set up by the WPA and the World Federation of Biological Psychiatry in the year 2014. It should describe the best. I would give an example here of one of the good publication which tried to differentiate the validation using varieties of parameters as shown in this cartoon. For example, if you take just a functional connectivity or fMRI, you get this much. There is a difference, as you can see in this slide, and the protein biomarkers, then hippocampus volumetry, and if you take a collective multimodal things, in fact, the accuracy gradually but progressively increase. So we are now changing in psychiatry from probably a single biomarker to a multimodal. And I come to this point a little later now. One does not simply claim prediction via biomarkers. As I said, there is a complexity in the diagnosis, but prediction requires more than an association. Let us say in a set, There is one item which you are looking, you get a simple, and you add 1 and 2, you get a little better prediction. Add 1, 2, 3, 4, and 15, you get a much more complex. I think we are now slowly changing, and I was looking through the research in the last publications of fMRI. If you leave out and add, if you have a collective thing, there is an increment in terms of prediction. So contrary to the other diseases, mental illnesses are not classified by diagnostic category. That is one of the big bear which Keshavan commented, and his research 2008 and 2014 did validate patients diagnosed from the same psychiatric illnesses present with a great heterogeneity. This is probably one of the big bugbear of biomarkers. The cross-validation, is it a solid evidence? You can see the multiple presentations, multiple disorders, multiple researchers, multiple reviews. The sample size, if you keep on increasing in the literature, the effect size effectively decreases. One of a beautiful article on the biomarkers is by Ganesh Venkatasubrahmanyam and Macheri Keshavan in the Annals of Neuroscience. What they commented was that in the critique, that it is probably difficult to have a single biomarker. Why is it difficult? For establishing a coherent and convergent evidence base of biological abnormality for a specific disorder, one needs to have a stable set of criteria that defines the diagnosis. Thus, psychiatry has the unenviable catch-22 situation. That is, on one hand, the current classificatory systems are not specifically designed to pave the way for identifying valid biological things, and also lack of gold standard diagnostic criteria at this point of time, and the methodological limits of existing studies, small sample size, multiple biases, lack of in vitro models in psychiatric disorders, and issues of pathogenic paradigms related to conceptualization of psychiatric disorders all add to the difficulties of the biomarkers. The biomarkers working group has very clearly defined the characteristics role. The primary role of biomarkers seems to be in the last 2 decades in the drug development research, where certain parameters have been used. An ideal biomarker should be sensitive and specific, should stratify the risk of progression, should be cost effective to test, should be personalized management, quantifiable, and correlate. I'm sorry to say that we don't really have an ideal biomarker in psychiatry, but we do have a multiple, and I'm going to delve some of the examples in my next few minutes. The genomics is the evolving biomarker paradigms. The genome sequencing has really helped us, but the research is now percolating and getting translated. Second is the transcriptomics. The microarrays and the gene expression data is now adding on, and then comes the proteomics, which probably is helping us a little more. And then finally, the metabolomics, which would add to the NMR and mass spectrometry. And finally, other technology, including the nuclear magnetic resonance, nano biotechnology, and finally, the neuroimaging techniques. Now, all these things are probably adding. The classification of biomarkers can be done also in another way. Type O is based on the natural history of a disease, example, symptoms of the disease. I think psychiatry comes in this group, whereas type 1 and type 2 is much more specific. For example, in diabetic research, the blood glucose lowering quality of an anti-diabetic can be a biomarker, or a radioactive isotope to evaluate the perfusion of the heart muscle is a. Likewise, sometimes in type 2, surrogate markers, for example, the lipid markers, can be a predictor of the progression of the heart disease. So, considering this, biomarkers are multiples, and the basic research started as a group in 2001 by the Biomarkers Definition Working Group, and that group keeps meeting and are modifying and improving the definitions. So the gene, a set of gene, it can be a proteins, biomolecules, morphological characters, can also be involving neuroimaging, So this is the progression over the last 2 decades in terms of the definition. I would take Alzheimer's disease. You find CSF, you find neuroimaging, you find plasma, you find genetic, and off late, we are even testing the retina amyloid to get as a biomarker for the Alzheimer's disease. Likewise, a newer component in schizophrenia research is the cognitive testing. As shown in this slide, the varieties of cognitive functions can be assessed both when compared to the normal controls, how they are different. And this is one area. But the significant key reasons which have been studied in neuroimaging are, for example, the emotional regulations related functions, dorsal anterior cingulate cortex, medial prefrontal cortex, and lateral prefrontal cortex, and ventral anterior cingulate. These are the areas of study for the neuroimaging, which I'm going to show you. A lot of work has gone on the genomic biomarkers. We are still evolving. Suffice to say that the identification of genetic biomarkers now has gone further. For example, why did I get this illness of schizophrenia? The Manhattan plot and the genetic cause of schizophrenia, they found in 2014, and that probably is the peak, 108 gene loci in schizophrenia. Among them, the most interesting aspect is the largest, as you can find in this plot, is an HLA major histocompatibility region. So we are probably zeroing on something, though a lot of almost many chromosomes had some genomes, but predominant one seems to be the developmental and channel genes. The genetic markers, especially in dementia, the PSP, the presenilin 1, presenilin 2, the amyloid precursor protein, and certain others are evolving. And my interest of late is on not only on this, the dopamine receptor binding variants, the genes which are associated with the mood symptoms. The genotype of X and interaction with the life events has been well established by this time. My recent interest is on the ApoE, which we are studying in dementia group. This ApoE is again has multiple allele, but most important, the pre-symptomatic testing of E4 and the other things are being studied increasingly in dementia. The inflammatory biomarkers in schizophrenia is one of the area, especially the IL-2 receptors is probably most sensitive, multiple ILs like IL-1 beta, IL-6, IL-8, IL-10, IL-12, all have been studied, but I think we are now reaching some kind of an understanding in relation to both schizophrenia and mood disorders. The cognitive testing is now being correlated to the neuroimaging, and especially in the dementia, the newer protocols and a lot of research in trying to get a score from the raw data using software dementia protocols. As you can see in this, a progression of an Alzheimer's in a case, and MRI, especially the hippocampus, as you can see in this, the scores varies depending on the seriousness of the disease. This has to be correlated with the cognitive function. The newer neuroimaging is the PET FDG, and this differentiates actually the multiple dementias as we go forward. So as we move forward, the newer inventions is the Pittsburgh compound and other compound which can be used to very identify as a biomarker. As you can see here, the molecular pathology is now being used as a multiple ligands to study both the amyloid binding, and you can differentiate between MCI and MCI converters. As we progress, the tau imaging is now slowly getting added on to the amyloid. And if you add these three biomarkers, the plain MRI on my left, the middle is tau, and third is the amyloid, you can get a better diagnosis in the same patient. But I think this is the area which we are improving. The other biomarkers which I would think is changing is the bio or serum, the CSF. And as I said, One of the other area which I am studying right now is the retinal amyloid, which is for the dementia. The inflammatory biomarkers probably has a place and it has to go further. And to add, I think today's understanding is using a multiple biomarkers might lead to a much more better specificity and increased sensitivity, especially for dementia. The hybrid model neuroimaging, combining the neuroimaging with the genetics, is the research of this decade. And as you can see, and the future, as I'm going to end, the future is like this canvas, large canvas. Machine learning is useful and must be done properly to get a much more better answers. For machine learning to do, we need quite a large sample, as you can see. This is one of the area which right now I'm studying. I'm using the white matter tractography. This has been well published from NIMHANS by Ganesh Venkatesubramaniam and his co-workers. The white matter tractography in the psychiatry as a biomarkers, or the research is young, but it's going to show. This is one of my patients' dementia, where we can get a tractography, as you can see. So the diffuse tensor imaging, the raw data can be using a software we can evolve, and the accuracy of the new criteria in the future is going to be by multiple biomarkers as shown here. The conclusions are, for example, the clinical symptoms, cognitive deficits, psychiatric comorbidity, genetic factors, neuroimaging features, all need to be coupled to get into a continuum. And the newer research will have to lead to our understanding by much larger, probably changing our own diagnostic specificity using CDOC research based or similar research which might evolve in the near future. That's one of my dream, that our conceptualization of psychiatric disorders is going to change. And we need to understand our etiological basis of our psychiatric disorders much better as we change our understanding. Then and then only our understanding and clarity with the biomarkers in psychiatry will improve. And finally, in the emerging genetic environment interaction will help us in better understanding. Yes, we can. That's what my theme, but we need much larger sizes research, reduced analytical variability and clean validation. And a reliable prediction of clinical endpoints would be the game changing. The biomarkers at this point of time probably will help us in the early assessments, some bit of prognostication, and some bit of proxy clinical endpoints. But I think times are changing for a more reliable biomarkers once we start using larger samples, clean evidence, so that generalizations and higher standards are reached. The way I look for the future is probably something like this cartoon. Based on the supervised learning, or that is the machine learning, based on the largest data of fMRI, defining brain ROIs, connectivity parameterizations, and we use a good software like in this example, NeLearn, and there are multiple softwares. It is time to rethink our current symptom-based approach to diagnosing psychotic disorders towards biomarker should be finally biomarker-based categories. And I'm just showing this cartoon the way I think it will evolve, that we would combine the current evidence as shown in this, for example, schizophrenia, so that we would reach to a better understanding. I acknowledge all my knowledge in biological psychiatry and this presentation to my patients who remind me daily how little I know about the wonders of the neuroscience of psychiatry, about which I continue to learn even today. I'm still a student today. Thank you, ladies and gentlemen. Remember social distancing and let us stay free of corona. All the best for you in the future. Thank you. Over to the chairperson, sir.
Yes, thank you, Dr. Prasad. And I request Dr. Nitin Gupta to carry on the discussion.
Yeah. Thank you, Dr. Pramod. Well, it was a very lucid and nice presentation by Dr. Prasad Rao. I think I don't know whether we have any questions from the audience. I've not received any questions at the moment, but I just...
Even I have not received it.
Yeah. So I thought...
Do we have a, Nitin, just a second. Do we have a separate link for questions?
Dr. Ganesh,
no, sir. All the questions are reflected in
Venkat,
the...
you want to comment anything on this? I would be very more than helpful. Though it is a presidential topic, I just thought your comments is much better. You are the one who gave a nice paper of review.
Okay. Yes.
I think the summary that you have given about the biomarkers are very apt. And in terms of the idea of combining multiple types of biomarkers to examine the potential of a biological basis for psychiatric disorder is very attractive. I concur, sir. That is a future way in which we need to pursue the research in biological psychiatry, and especially link it with the clinical manifestation, perhaps the prognostication, so that the translational potential is enhanced. Thank you. Thank you for inviting me to comment, sir.
Thank you.
Sir, I was just wondering a couple of things. One is that it was a very good overview and giving some directions. But if you could just highlight as to what is the state of play specifically regarding the Indian scenario. Although you did mention a little bit regarding the research which you have been doing, but like we do have the NIMHANS, which is the designated National Institute of Importance. And they do have a lot of different departments which are carrying out biological research. But where does India stand with respect to the rest of the world regarding biological psychiatry? Especially, we do have our own association of biological psychiatry also. How much of strides we have taken in developing biological markers and contributing to the scientific world in psychiatry. That is one. And the second is that the focus has generally been on psychotic disorders and dementia or organic mental disorders, including delirium. Not much of work has probably gone into other disorders in relation to psychiatric disorders. So what would be your thoughts on that?
Yes, I would like to thank our chairpersons for being there with us today and Dr. Venkat for his comments. We now move on to the next talk, and it's my proud privilege to introduce the chairpersons for our next talk. The first chairperson, Dr. Rukshida Saida, she is a psychiatrist and psychotherapist born and raised in Mumbai. She's a celebrated speaker on mental health who has 2 TEDx talks to her credit. International awards, including a prestigious WHO fellowship from South Korea in psychosocial rehabilitation. She has a thriving practice in Mumbai spanning over 18 years, specializes in adolescents, young adults, women, families, and their mental health problems. My second chairperson is a very close friend. Rukshida is also a close friend, but Amrit is also a closer friend, Dr. Amrit Pattojoshi, who's a consultant psychiatrist from the AMRI Hospital, Bhubaneswar. He's a leading psychiatrist from Bhubaneswar, rendering professional help in overall mental health with key skill areas in mood disorders, anxiety, substance abuse, child psychiatry, and sexual disorders. He has dealt with various psychiatric cases and provided psychological counseling to thousands of parents and students. I'm proud that he is one of our direct council members who's associated with me and Dr. Chawda on the IPS College Mental Health Task Force. I hand over now to Dr. Amrit and Dr. Rukshida. Are you all there?
Yes, sir.
Yes, please.
Thank you, Avinash.
Thank you so much, Avinash. Though I will let you bribe me out of myself because Amrit is closer to you than me, apparently. Amrit, please, go ahead.
Yeah. So I welcome all of you to a very, very interesting and very, very topic that is the need of the hour, that is data science and neurobiology for interventional psychiatry. I hope a speaker which Dr. Rukshida is going to introduce will take us how to investigate the early signs of psychiatric illness, mediators, mechanisms to understand psychiatric disorders, maybe get through the data, get into molecular and cellular processes. It's a wide and very topic, and I should not take much time from our esteemed speaker. So Rukseda, if you can get on with the things fast, people won't tolerate as much. So over to you, Rukseda.
Thank you, Dr. Amrit. Welcome everybody at the outset. It's an extreme honor for me to chair this particular session, and a singular privilege to introduce Dr. G. Venkata Subramanian. I think a lot of us who are interested in research and schizophrenia, OCD, and data sciences and social media and algorithms, I think all of us are a little aware of his contribution towards all of these particular fields, and it is the emerging field, and he has gained a lot of accolades around the world. He has multiple publications on these on the topic that he's going to speak to, so he's an amazing expert that we have, and we're very honored and privileged to have you here, sir. And I know you're used to teaching a lot of PG students, so please consider all of us are all your students, and maybe make the presentation in a way that might even get through a brain like mine, which is so technologically challenged. Wonderful to have you, sir. And please, without further ado, I would invite you to share your insights with us.
So good afternoon. Hello. Am I audible, sir?
Yes, sir.
You're audible and your screen is visible. You're good to go.
Okay, thank you. So good afternoon. At the outset, I thank the organizers as well as Dr. Prasad Rao for this opportunity, and thank the chairpersons for the generous words. And I'm as much a learner as all of us. So I will share some of the learnings I have had with respect to the data science and neurobiology, especially looking at its applications in interventional psychiatry. To introduce the data science and its relevance to psychiatry, if you look at the paradigms in science, there are four major components. The first one is the empirical, which started in many years before, where the approach in science was primarily to describe observations. And later came the theoretical approach, where people started proposing models and concepts to explain the genesis of observations. Then came the computational paradigm, in which the observations were simulated, which perhaps dates over the past few decades. And what we have in the present time is the data-driven science paradigm, which is intensively influenced by scientific computing, and where an attempt towards synthesize different observations and compute with what is called as the statistical learning. This paradigm is also famously put forth as the fourth paradigm. If you look at an overview of the data science roadmap, the approach is simplified in this slide, where if you want to understand the science of, say, the biology of psychiatric disorders, say Dr. Prasad Rao nicely put forth in terms of the need for biomarkers and the challenge of heterogeneity in psychiatric disorders, we frame the problem, then we collect and understand the data, then we extract certain features and then model these features, and then this in turn will help us to refine the framing of the problem, and we keep on iteratively go through these cycles till we achieve a refined solution. So this is a simplified version of the data science roadmap, in which there is quite a bit of scientific coding in terms of the computational algorithms to implement all those analysis is involved. So it is a merging of different sciences, right from the clinical approach, clinicians' knowledge domain. Then we have people from all the research techniques, as well as computational specialists who conglomerate in the science of data. And Complementing this are different kinds of paradigms like chemoinformatics, bioinformatics, and imaging informatics. Some of these aspects are nicely described by Dr. Prasad Rao in his previous presentation. Now, if we look at the difference between the traditional research model and the data-driven research model, this slide summarizes that. In traditional research model, we propose a hypothesis, we do experiments, and then we analyze, and then it keeps on rotating. Whereas in data-driven science methods, not only the empirical hypothesis, but also there is a data-driven hypothesis which comes through, and a conglomeration or a merging of these two approaches is something which is new, especially with the advent of techniques to analyze big data. Now, coming to what can data science do for mental health research? This is an article that was published in Nature Human Behavior a couple of years before. As we could see, there are profound implications of data science across most of the applications in psychiatry, most of the domains in psychiatry, starting from understanding the development of the mind and brain, as well as looking at the genetics, as well as looking at what are the ways in which we can potentially prevent mental illnesses, and then looking at certain predictive analytics in terms of what is the most effective treatment for each person, which is also called as the precision medicine or the individualized treatment approach. And then looking at some of the things like in terms of the whole public health implications, as well as the system related impacts in terms of how the improvement in health and social care can overall be effected. Now, coming to the specific focus of this topic in terms of the relevance of data science in the context of neurobiological paradigms in psychiatry, and how it can inform interventional psychiatry as well as several interventions in psychiatry. What we have to remember is the complexity of psychiatric disorders, where there are multiple genes that are responsible for the genesis of almost all psychiatric disorders, which are also called as polygenic etiopathogenetic basis. And the current understanding is these multiple genes, they interact with one another and they result in the formation of a symptom pattern. Perhaps this symptom pattern and its link with the genes could be well understood by certain intermediary biological markers or intermediate biomarkers, which are also called as endophenotypes, because they are considered to be more closer to the genetic architecture that underlies the psychiatric disorder. So this is the concept of endophenotypes and how it links the gene and the disease manifestation. And this is something which is important because once we look at several lines of data streams, say we have genetic data, we have data that comes from the cognitive science background, like say like working memory, and then we have data that comes out of brain imaging, and then there are fundamental research derived data like glial cell abnormalities and so on and so forth. Essentially, we are in the era of big data, multiple streams of data, and that is where a scientific approach towards understanding and refining and analyzing the data becomes very important, given the challenge of complexity that we handle in the context of psychiatric disorders. Now, in that context, interesting concept that is gathering more and more attention is understanding the brain as a connectome. If you look at brain, which is a complex system of networks having as many as 100 billion neurons, which perhaps can result in 100 trillion synapses. But all these are packed in a small volume or a relatively small volume of 1.5 liters of skull capacity, which illustrates how complex the brain could be. And this complexity is understood at the anatomical level, where we could see neurons as being organized over multiple scales of space and functionally interactive. and clinical disorders of human brain networks like dementia, schizophrenia, and these are considered as amongst the most disabling and therapeutically intractable global health problems. In the context of the complexity of the brain and the enormous therapeutic challenges these disorders offer, the need for advanced neurobiological techniques is more compelling. So this is where some of the modern concepts of connectome becomes important. When we look at brain connectivity, it can be at the level of anatomical or it could be at the level of functional. Functional connectivity is defined as the temporal correlation between spatially remote neurophysiological events. Whereas there is something called as effective connectivity, which characterizes, if one wants to put it, an etiological influence of one neural system over the another. So this is the map that depicts brain as a connectome. And if you look at several functional networks, there are major functional connectivity patterns that have been understood, starting from somato-motor, dorsal attention, visual, salience, of course, default network, and there are networks related to control. So essentially, the approach is to look at the brain as a set of networks which interact within themselves as well as between themselves. And that is nicely exemplified by this concept of brain connectome, which is defined as a matrix representing all possible pairwise anatomical connection between the neural elements of the brain. The connectome concept is gathering more and more attention, and basically this concept helps in conceptualizing our focus towards quantification, visualization, and understanding of the brain network organization across multiple scales of space and time. So these are some of the modern advances in the physics which has helped us to refine the brain network structure understanding, and such computational approaches have given phenomenal insights in terms of how the brain network is organized and how it functions. Essentially, some of the important characteristics that are contemporary and topical include brain being seen as a small world architecture, which is modular and having a hierarchical basis, and there is a centrality and distribution of network hubs, which is depicted in this cartoon on the right hand side, where the brain is seen as a hierarchical modular network where there are individual modules which are essentially small worlds which have a set of small worlds in between, and as a whole all these modules interact with each other. The term small world is a concept which is derived from graph theory, which helps us to apply certain powerful computational principles to understand the brain organization as well as its function. Moving beyond connectome, so till now what we have seen is a connectome, which is basically a static capture of the brain connectivity pattern. And if we look at much more recent advances, we know that time domain or a temporal domain is something which is very, very important when we understand the brain function. So if you look at the brain function and the maps of the brain across time, that is dynome or dynamic functional connectome. So the concept of dynome is essentially integrating the component of time, while the human connectome will provide a detailed mapping of brain's connectivity. Further understanding of brain function and dysfunction will require an integrated framework that links brain connectivity with the brain dynamics. That is essentially, we have a temporal pattern, which is exemplified in this slide, where the window correlation matrices mapped across time is something which will help us to understand this dynome. So essentially such concepts which brings in deep skills across several specialties like cognitive neuroscience, computational neuroscience, cellular and molecular neuroscience. Importantly, computer science and engineering is very much important in the era of data science, and this has led to the emergence of a rich interdisciplinary field of computational psychiatry. So, which is essentially the approach in psychiatry, that is the computational psychiatry is essentially the approach in psychiatry which has two major components. One is the data-driven, theoretically agnostic data analysis methods from machine learning, which is complemented by theoretically driven models that mathematically specify mechanistically interpretable relationship between variables. So this is an example of how computational psychiatry can help reduce a very high dimensional data set through the application of machine learning techniques, through which we can look at prediction and classification. When we say prediction, it could be something related to predicting the likely diagnosis from a set of brain images, or predicting the prognosis of a particular patient based on different types of biomarker data that are collected at the baseline. Now, coming to the potential application of such advances in data science and data science informed neurobiology is the neuroscience informed psychiatric treatments. We know that at least about a third of patients with major psychiatric disorders persist to have symptoms despite adequate psychopharmacological treatments. Though we have the armamentariums like psychological and psychosocial interventions to complement the psychopharmacological approaches, these additional interventions are limited by their resource intensiveness. Given the exponential increase in our knowledge about brain areas of cognition and behavior, more than ever, there is a compelling need for neuroscience-informed approach to understand and treat psychiatric disorders. And these discoveries in neuroscience are ably matched with advances in neurotechnologies, and which has led to the era of digital psychiatry, where the concept of digital phenotyping is gathering lots and lots of attention. And this is one area where there is a close interface between the clinics and the data streams and data science-based approaches. And this is the future of mental health that is envisaged in the era of digital technology. And it is also complementing our need for alternative avenues, especially that we don't see so many effective neuromolecules. This is one area where a lot of support we can derive from technology, which has led to the field of interventional psychiatry, which has essentially two components. One is to harness the potential of neurotechnologies to elucidate the circuit level brain dysfunction, which I was summarizing in the initial set of my presentation slides, and application of brain stimulation techniques, which have emerged out of recent advances in these neurotechnologies, so that the aberrant brain circuits could be modulated. Contextually, it is interesting to note that the brain, while it can be conceptualized as an electrochemical soup, modulating the electrical component has not been so intensively pursued to match the psychopharmacological intervention that have targeted the chemical component. We have a plethora of neuromodulation techniques, starting from the age-old electroconvulsive therapy to the recent advances in terms of ultrasonic and infrared-based neuromodulation. So what I will illustrate here before I complete my presentation is an example of how some of these neurobiological advances, which are informed by the data science, can help in potential treatment implication. If we collect brain MRI, this can be subjected to computational modeling workflow through which all these steps can be implemented automatically. And there are tools that are being developed which can make it quite user-friendly and clinician implementable and translatable technique. For instance, if you look at the brain image here on the left-hand side of the lower column, it can be subjected to certain kinds of pre-processing in which we can simulate what will happen to the electrical field if we have to apply any of the neuromodulation techniques. What we did in an attempt to look at its clinical application is that there are two patients. In patient one who had been treated with transcranial direct current stimulation and showed near total improvement in auditory hallucination, and patient two who showed minimal change in auditory hallucination. When we subjected these patients to a neuroimaging informed neuromodulation analysis pipeline, we were able to delineate the patient that responded having the optimal electrical peaking in the area that we wanted, that is the left temporoparietal junction, whereas the other patient did not show this kind of optimal peaking. So essentially, application of such techniques a priori before initiating the treatment may help us to tailor-made neuromodulatory interventions to suit the individual anatomical profile of the brain. And similar attempts can be done, say for instance, looking at pharmacogenomic data or combining multimodal data to predict who will respond to what kind of medication and so on and so forth. So these are some of the potential application that one can envisage. So this is the magnified image of the differential profile of electrical peaking. So essentially, this will help us to enter into the era of personalized treatment, and in this specific context, personalized neuromodulation. Also, we have been applying some of these machine learning techniques in which we were able to successfully differentiate the first degree relatives of people with schizophrenia, that is all the unaffected first degree relatives, where we were able to differentiate them into two groups using some advanced machine learning techniques. And interestingly, the set of people that were classified as having the possibility of diseased brain pattern had high schizotypy scores. So this is something very, very interesting, where some of the machine learned diagnostic models were able to predict state independent vulnerability. So these are some of the futuristic applications of such techniques. And also there are illustrations where we are able to show that the electrical field intensity having a meaningful correlation with the quantum of improvement. So essentially, we are looking at an era where we should combine clinical scores, brain imaging, psychophysics, and blood parameters, and look at, say, for instance, if you are interested in effect of novel neuromodulated treatment, we can apply such data-driven computational modeling techniques like machine learning, deep learning, and related methods, through which we'll be able to achieve an integrated analysis of multimodal biomarkers, along with clinical, psychophysical, and other biological metrics. And this will help us to understand the neurobiology as well as optimize and personalize treatment protocols in psychiatry. While this avenue looks very exciting, it also comes with its own set of challenges. One important set of challenge that we need to appreciate is the need for reproducibility, making sure that the data is available across multiple centers, especially because we have heterogeneity in not only the patient population, but also the data types that are collected across different centers. We need longitudinal studies, and we need robust pipelines to manage data, that is data management techniques. And very importantly, we also need to evolve research methods through which we capture all the relevant information about the potential confounding factors. And these kinds of approaches may, at some point in time, if indeed there is a biological basis, may help us to differentiate disorders like schizophrenia versus bipolar from schizoaffective. Of course, more and more the clinical neurobiological research indicate that there are tremendous overlap in the biology, but the challenge is to see whether there are meaningful ways in which we can dissect out, if not at the level of diagnosis, even at the level of prognosis, it will be really, really useful. And these are some of the models that are being proposed and in which we can apply these data science techniques. Of course, such approaches in the data science also has some unintentional consequences. Heavy dependence on technology may inadvertently lead to reduction in the skill of physician, which is much more compounded because of the intrinsic uncertainty in medicine. And many of the machine learning techniques are like black boxes, so we need more open approaches in terms of understanding what is exactly happening in terms of the computational basis. And what is recommended is the two cultures, that is the computer and the physician, must work together. Because if the brain were so simple we could understand it, we would be so simple we couldn't. So which essentially means we need complex and much, much more advanced techniques to understand brain and its disorder. So with this, I will stop. And some of the important points I tried to communicate are data science and its potential for immense application in psychiatry. And then I highlighted some of the concepts of brain in terms of connectome and the dynome, which is the dynamic functional connectivity profiling of the brain. I just briefly touched upon some of the concepts of network neuroscience, looking at the modular and small world brain. Then I talked about the need for computational psychiatry, especially in the era of big data. And then given the limits that we are having in terms of psychopharmacological approaches, especially in treatment-resistant psychiatric disorder, I highlighted the role of interventional psychiatry and how neurotechnologies as well as novel interventions can be combined in the context of data science approaches like computational modeling, which essentially may help us to refine our approaches in treating psychiatric disorders through precision medicine. And needless to say, there are lots and lots of challenges, and we need a blending of multiple specialties as well as merging of machine and mind, which will help us to have a very important approach, that is personalized medicine in psychiatry. So with this, I will stop with mentioning about one of the program that we have initiated, which is the Clinical Research Center for Neuromodulation in Psychiatry, which is a multi-center initiative where we work along with the Central Institute of Psychiatry, Ranchi, as well as the Kasturba Medical College, Manipal, and in which we have started a fellowship called Clinical Research Training Program Fellowship, which may be a potential option for early career psychiatrists who are interested in clinical research career. And we are in the process of implementing this fellowship. Potential aspirants for this fellowship may want to attend a webinar that we have scheduled on Tuesday next week. So with this last slide, I will stop and thank the organizer again for this opportunity.
Thank you so much, Dr. Venkata Subramanian. It was a very, very lucid presentation, and a lot of us, I think, are now more interested in technology because of it. Because we're running out of time, but I still wanted to have a couple of quick questions before we let you go. According to you, what might be the limitations for machine learning, artificial intelligence, and even deep learning? Not so much in terms of the imaging information that we may have, but maybe even including that based on gender, based on racial profilings, or the data, because the machine learning is going to evolve only from the source that we've put in originally, isn't it? So what are your thoughts on that?
So if I have understood your question correct, it is basically the most of the work has happened in some of the variables that you mentioned, not so much on imaging. Is that what you were mentioning, madam? Sorry.
I'm just trying to see whether whatever data that we have and we start from. So there are a lot of, like, let's say if we are using sound and voice and face recognition, and we already understand with AI there are a lot of difficulties with recognition of that, And then if you're going to use that technology and encourage our younger colleagues to use that technology for clinical applications, for crisis recognition, predicting suicides or predicting panic attacks and schizophrenia, how might that limit us, especially,
Yes.
you know?
Yes. I fully concur with your view in the sense it is a naive field. It is just evolving. And the inspiration and the hope comes from the applications of data science. Say, for instance, if we want to type a message in our mobile smartphone, many a time it was able to now predict to a decent extent what is our next word that we want to type. Of course, we also know that it autocorrects the name terribly wrongly. So I fully concur with your view. It is a science which is evolving. What is interesting is its potential application, application towards the complexity. If the data science can permeate smartphones where across so many individuals it is able to an extent predict what is likely thought of this person in the next moment, I think with more and more refinement, it may help as a useful aid. So I fully concur with your view. It cannot replace the clinical approach. It perhaps will aid us to refine our approach. So that's where we are. And still lots and lots of miles need to be covered. It is just an avenue which is worth exploring.
Thank you so much. Dr. Amrit?
Yeah, Dukshita, what sir told is absolutely perfect. Our smartphones, our smartwatches are our biggest gateways. So the way we type, it's not just what we type, the way we type, the way we put pressure on our mobiles, the sites we visit. Suppose somebody is manic, he has gone to 2-3 discs at night. That is how the data mining is done. Somebody was telling me yesterday night that how does Facebook know what I was searching in Insta? So I was looking up for somebody, and then the option came in my Facebook to buy something. So it's really sometimes dangerous, but maybe it might help us later on in life. So data mining is the biggest thing, and that is being sold nowadays. So I think with sir's input and the research, because some of the software which sir is telling we were using in CIP. In understanding, and we were laughing when our professor used to tell us to work on these things. And now after 20-25 years, we are finding that is coming in vogue. So maybe with time things will evolve and we will be better off, hopefully. Let the machines not replace us. Let them supplement what we are doing and help us in achieving what we want to do. Over to you, sir.
Well, thank you to our chairpersons, Rukshita and Amrit, for chairing this session. A big thank you to Dr. Venkat for joining us all the way from Nimhans. We now move to our next session, and it's my proud privilege to introduce the chairpersons for our next session. Our first chairperson is Professor Dr. Anukant Mittal, who is the founder president and founder member of the Indian Association of Biological Psychiatry. He's also been a professor and should I continue? Yeah, he's also been a professor and head Department of Psychiatry, Rajiv Gandhi Medical College, Kalwa, Thane. He's been the president of he's currently the national president of the Indian Association of Private Psychiatry. He's also been he's currently the UNESCO professor of bioethics and head Western Region UNESCO Asia Pacific Chair in Bioethics. Our second chairperson for today is Professor Dr. Vihang Vaya, someone who needs no introduction in Indian psychiatry. He's a consultant psychiatrist at the Breach Candy and Leelavati Hospitals, Mumbai. He's a member of the DSM-5 task force of the IPS. He's part of the National Advisory Board of the Indian Association of Private Psychiatry. The past member of the membership committee of the American Psychiatric Association, former chairman of the CME committee of both the Indian Psychiatric Society and the Indian Association of Private Psychiatry, past secretary of the IPS for 6 years, an international distinguished fellow of the APA, and has several publications in index medical journals, chapters and textbooks, and monograms, and of course has been the past professor and head and currently professor emeritus at the Cooper Hospital and Medical College, Mumbai. I welcome our chairpersons, is Dr. Vaya and Dr. Mittal sir with us. Sir. Yeah. Can you hear me, Dr. Vaya sir?
Yes, I can. Thank you.
Yes. Yes. And Dr. Mittal, sir, you're there?
Unmute yourself, Dr. Mittal, please.
Okay, I hand over the session to you all. Yeah.
Thank you for inviting me to chair this session today. Dr. E. Mohandas. I guess somebody is going to put up that slide which tells us all about Dr. E. Mohandas. Any attempt to introduce Dr. E. Mohandas to this audience is like showing the candle to the sun to brighten the sun. And describing or introducing Dr. Mohandas or share all that I know about Dr. Mohandas, he will have no time for his talk. He is a man who thinks and lives psychiatry. He can speak on 6 different occasions, on 6 different topics within a week, and still have a lot more to tell us. I can go on and on and on. And if Dr. Anukant Mittal permits, we may straight away ask Dr. Mohandas to start his talk. We are already behind schedule. Dr. Mohandas.
I have no problems. Dr. Mohan, you can please start.
Yeah, I will share the screen. Can we just share the screen? Can you see the slides? Can you see the slide? Hello?
Not yet.
Can you see the slides?
Not yet.
Can you see the slides? Yeah?
Not yet. Let them share. Amita, can you
I
share,
have
please?
started sharing my screen.
Right. So once you share your screen and we get it started.
Is it okay? Fair?
Yeah,
Right. See your slides now.
yeah, we can see it now. Mohan, please go to slide view, please.
Okay.
Mohan, go to slideshow view, please.
Is it okay? Now you can see?
Yes, we
Yeah,
can.
perfect.
Yeah, I think already late. Respected chairpersons, after hearing Prasad Rao and Venkat, both of them are researchers. Venkat talked on especially the structural, functional, and dynamic anatomics. But I am asked to present vaccine pipeline 2020 and beyond in dementia, especially in dementia and Alzheimer's disease. With my greetings to Jeffrey Cummings. He is a living legend of dementia. So I had published along with him. Now we'll go to the topic. I will be discussing dementia, primarily Alzheimer's. Multiple causes, genetics and epigenetics, neuroinflammatory hypothesis, oxidative hypothesis, hormonal metabolic hypothesis, neurovascular and metallotoxicity hypothesis. This will produce toxic amyloid accumulation and tau hyperphosphorylation, produces a synaptic failure, primarily presynaptic cholinergic deficit, and later excitotoxicity. When we talk about the future, The past is a source of knowledge. The future is a source of hope. And love of the past implies faith in the future. I don't know whether this cartoon is clear. We have to know about the past, evolution of the drug development, the clinical treatment, acetylcholinesterase inhibitors, you can see here, then NMDA antagonists, and some of the medical foods. And the lower down in the blue, these are all experimental ones. What we have is beta and gamma secretase inhibitors or alpha secretase enhancers, but we do not have anything now. We do have anti-tau agents in theory, but in practice, not good. Only cholinesterase inhibitors we use right and left. NMDA antagonists, memandin, sometimes these two drugs together we give it, and antioxidants. The approved drugs for dementia Alzheimer's is donepezil, rivastigmine, galantamine, memandin, and donepezil memandin combination. Go back to the donepezil, 1996 US approval, 97 launch in US for treatment to mild to moderate Alzheimer's, 2001 in fine granule formulation, rapid rod oral disintegration tablet in 2004, oral jelly formulation 2009, all in Japan, and sustained release high dose 23 milligram 2010 onwards, and even in India. Donepezil 1 weekly transdermal formulation in collaboration with Shikoku Shiaku was submitted in June 10, but nothing has come out. Rice syrup formulation is the pre-registration in Japan. Fast dissolving oral film strip formulation is in clinical evaluation. Donepezil transdermal patch with lab-tech donepezil hydrochloride with the nitodeng and COVA. It's a 3-day patch formulation co-developed with NAL Pharmaceutical, but it is in preclinical evaluation. Analysis in 2017 told it was to be more efficacious than galantamine or rivastigmine in controlling the global Alzheimer's disorder symptomatology. What is needed is slow titration, then go up to after 4 to 6 weeks, increase the dosage, then you may do it after 3 months, even up to 23 milligram dosage. This is the expert opinion on drug safety in 2020. Rivastigmine available both in oral transdermal patch, oral form approved for the treatment of mild to moderate Alzheimer's. Transdermal patch is supposed to be better tolerable. Rivastigmine came in 2000 in European Union and US, 2010 in Japan, transdermal patch, European Union 2007, and Japan later. Recently, 1-day patch formulation, Bio D3 transdermal drug delivery system is in preclinical evaluation. Galantamine, 2001 in Europe. In Japan, it was late. Extended release capsule formulation in 2005. 1-day patch formulation, Bio D3 transdermal drug delivery system 2012, memogaine, it's a prodrug benzoyl ester, up to be 15 times higher bioavailability in the brain than the same dose of galantamine. It's in phase 1 since 2011. The recent information, it is not going to be pursued. Present, only available in China, 1995. Once weekly sustained release transdermal patch, 2008. Topical gel formulation, preclinical evaluation. But what are we going to do with cholesterol inhibitors? It can only improve 3 to 4 points of gut score. And there is no meaning in continuing for years together if there are no improvement. If there are improvement, continue. But when to stop it, no definite guidance. The trial shows with cholinesterase inhibitors very small NNT. NNTs are smaller with the larger doses. So, depending upon the good and safety tolerability of new cholinesterase, still whatever we have is only donepezil. It is okay. Once daily memantine is supposed to be given for moderate to severe Alzheimer's disease, and memantine and vitamin D combination was tried in UK. That is the cholinesterase inhibitors. Anti-tau agents, they inhibit the misfolding or aggregation and also the clearance. But do we have any agents? So far, so we have failed. What is the drug development in 2020? This is published online in July 2020. If you see this cartoon, it's so crowded, very crowded. The anti-amyloid phase 3 trials, phase 2 trials, phase 1 trial. Outer one is phase 1 trial. 121 agents in clinical trials for treatment of Alzheimer's. 29 agents, they are in 36 phase 3 trials, multiple places. 65 agents. Can you hear me, Anugam? Can you hear me?
We can hear you, Doctor.
Okay.
Dr. Mohandas, go ahead. We can hear you.
Yeah. 65 agents are in 73 phase 2 trial and 27 agents are in 27 phase 1 trial. What are they? Agents in trial for cognitive enhancement, there are only 12, a dozen drugs. A dozen drugs are being tried for BPST. The new term is called neuropsychiatric symptoms of dementia, NPST. And 97 agents are disease modifying agents. So these are the out of the drugs in pipeline in phase 3, 29 agents in phase 3. Out of this, 28% for neuropsychiatric symptom management, 14% only for cognitive enhancement, 59% disease modifying therapies. Neuroinflammatory, 18%, and vasculature, increasing blood circulation, and anti-amyloid immunotherapy, 35%. Phase 2 trial, 61 agents. Out of this, cognitive enhancers, only 9%. And the so-called neuropsychiatric symptoms of dementia, 6%. And all others are disease modifiers. But unfortunately, attempts to develop disease-modifying therapies for Alzheimer's and a 100% failure rate. So whatever we are doing, are we reaching anywhere? Unfortunately, no. We are still searching. What are the new targets? New cholinesterase inhibitors and hybrids, new NMDA receptor antagonists and synaptic function modifiers, 5-HT6 receptor antagonists, gut microbiota regulators, anti-inflammatory drugs, autophagy modifiers, circadian rhythm stabilizers, epigenetic targets, phosphodiesterase enzyme inhibitors, immunotherapy, TREM2 signaling. This has come in 2021 and 1 week back, and some other diets. New cholinesterase inhibitors are fencerin. It is pure non-competitive selective cholinesterase inhibitor, but it penetrates well to the brain. Brain plasma ratio is 10:1. Another cholinesterase inhibitor is tolserin, partial non-competitive. It has got selectivity of acetylcholinesterase 200-fold. Brain blood plasma is 24:1. So this will be better than fencerin. In China, huperzine analogs ZT1, nitidine and avicin derived from Sandoxylum rigidum. These are all herbal products, and it has got cholinesterase inhibition, monoamine oxidase inhibition, and amyloid aggregation negativity. Kelmindosporin derived from Rumex abysmus, and methanyl fluoride, it is a reversible inhibitor and a barbiturol derivative. This also has come in Biomolecules 2020 and also a recent publication, Acta Pharmacologica Senecia in 2020, still to be put as page numbers, still not page number. What about the hybrids? Cholinesterase hybrids. You change the structure. Heterodimers of tacrin and donepezil, combination of acridine or tacrin with a donepezil fragment, heterodimers of tacrin and huperzine, heterodimers of tacrin and bifendate, heterodimers of tacrin and lipoic acid, alpha lipoic acid, many companies promote, heterodimers of tacrin and trolox, vitamin E and others, heterodimers of tacrin and selenium, epsilon, and heterodimers of tacrin and vasodilatic beta blocker carbazole. This will be published in Molecular Neurobiology 2021, just published January, last week. Heterodimers of tacrin and 6-ferulic acid, hydroxyquinoline, heterodimers of donepezil and other drugs, heterodimers with donepezil plus serotonin 4 receptor agonist, and rivaroxaban and rasagiline combination, ladostigil, memandin and nitroglycerin combination, nitromemandin, heterodimers of memandin and 6-chloroacrid, and heterodimers of donepezil, chrome, and melatonin. These are being tried now. Up to 2021, that is the data. NMDA receptor antagonist, in a new product, RL208, JCC202, DT010. These are on phase 1 trials, so no names. And ringofilin derived from Angaria ringophylla. These are new ones. These are all in phase 1 trials. What about synaptic plasticity neuroprotection modifiers? Low-dose levetiracetam, as you pretty well know, anti-epileptic. It is a SV2A modulator. And another drug called blarcamesine, sigma-1 receptor agonist, M2 autoreceptor agonist. I think Venugopal Jawhar know about blarcamesine. Even the better glutamate modulator and riluzole, it's called troriluzole. It is being tried. Icosapent ethyl, purified form of omega-3 fatty acid, and non-peptide ligand of P17 neurotrophin receptor, and another drug called P38 MAPK alpha inhibitor for endosomal function to reduce synaptic dysfunction. And edonerpic activates sigma receptors. But these are on phase 1 and phase 2 trials. New names. It is mainly mind-boggling. But whether it will cross phase 3 trials, I don't know. Gut microbiota is gaining importance. Probiotic supplementation, many people are trying. Now, oligomenate, it's a putative amyloid disease therapeutic from seaweed, approved by Shanghai Green Valley Pharmaceuticals in treatment for mild to moderate Alzheimer's disease, November 2019. This can penetrate blood-brain barrier to directly bind beta amyloid and inhibit the beta amyloid fibril formation. It's a new drug. Anti-inflammatory agents, the previous ones, what we talk about it, evidence is very thin. But currently people are trying cromolyn and ibuprofen combination, mast cell stabilizer and anti-inflammatory, RAGE antagonist, that is advanced glycation end products, reduce amyloid transport into the brain, and bacterial protease inhibitor targeting gingival, the thing, especially gingival infection, that's called COR388, mastidip tyrosine kinase inhibition, modulation of mast cell-related inflammatory process, lenalidomide, reduce inflammatory cytokines, and montelukast, many of the pulmonologists use. That is also coming to in Alzheimer's disorder therapeutics as a leukotriene receptor antagonist. Autophagic modifiers to promote the degradation of beta amyloid tau, rapamycin, methylene blue, again coming, quercetin modified nanoparticles. Circadian rhythm stabilizers, not much evidence, all controversial, but only one drug, suvorexan, orexin receptor antagonist, that promotes sleep via selective antagonism of orexin receptors, that is being tried. 5-HT6 receptor antagonist, only one is used, that is called SUVN 502, as an adjunct to donepezil and memantine, is under investigation. What about immunotherapy? All failures. Aducanumab, monoclonal antibody directed at plaques and oligomers, these are on phase 3 and phase 2. Amyloid vaccine, gantenerumab, solanezumab, all gone with the wind now. Daratumumab, people are trying, CD38 and inflammation, and another drug called semorinumab, remove extracellular tau. Aducanumab, humanized monoclonal antibody, and solanezumab, base 1 inhibitor, verubecasan, which produces brain beta levels by 90% without changing the trajectory of the disease in Alzheimer's disease. It was not successful. But in October 2019, the company again submitted with a high dose aducanumab. They say it may be helpful. But 2 trials, emerged trial, the aducanumab was a failure. but engaged trial, they say it is beneficial. The data is from Biochemical Pharmacology 2020. Antibodies currently in clinical development, very difficult for you. This is only a repetition. Bapinosumab, solanezumab, etc. If you want to read Neurobiology of Disease 2020, it might have been published now. Tau immunotherapies also, but unfortunately, it may not be successful. The reason being, antibodies targeting the more abundant pools of domain of tau, phosphoepitopes of tau, multiple epitopes, and we have to have more conformational information about the diverse forms of tau before we target a specific immunotherapy. Epigenetic targets and mRNA targets, I don't know, Bhaskar Mukherjee is there in the platform. A drug HTRT, telomerase reverse transcriptase peptide vaccine, mimics extra telomeric function. It is in trial. Another one, antisense oligonucleotide targeting tau expression, microtubule associated protein tau RNA inhibitor, and HTAC demethylase inhibitor, that's called vafidemstat, and many microRNAs, they are trying microRNA 298, 31, etc., but they are in phase 1 and 2 trials. Phosphodiesterase inhibitors, 5 inhibitor. So you can ask, sildenafil, is it going to be effective? Depending upon the dosage, but you can have erection down, but not that much erection up. But it is under trial. PDA4 inhibitor prolongs CAMP activity and improves neuronal plasticity, and cilostazol PDE3 inhibitor improves cerebral circulation, reduce accumulation of amyloid and tau phosphorylation. These are under trials. Now, how to deliver a nanotechnology-based drug delivery system in Alzheimer's, nanomolecules, nanoemulsions, liposome, and even solid lipid and dendrimers. There are many forms. Intranasally you can give, intravenously, and some solid lipid particles orally. These are under trials. Neural stem cell therapy, is it going to be effective? It is still in experimental stage. You can read this journal, Experimental Neurology 2020. It is online, but it is yet to be published. And murine amyloid disease, Alzheimer's disease, has been successfully treated with stem cells, mesenchymal stem cells. Transgenic model translate very poorly. The effectiveness is usually modest only. Future preclinical research on stem cell therapy for Alzheimer's should place a special emphasis on safety, determining the best methods of sourcing and delivery of cells, assessing proper stem cell function, and the microenvironment in Alzheimer's disease. Harnessing both NSCs, that is neural stem cell therapy, vascular progenitor cells together to restore damaged cerebral blood vessels and recover compromised neurons may be a more effective strategy. Go through this journal in experimental neurology. Is still in a very, very, very infantile stage. That's the last part of it. Many people talk about Mediterranean diet, ketogenic diets, medical foods, and many foods are available in the market. Currently, people talk about epigenetic diet, meaning food, bioactives, folic acid, choline, oil, selenium, zinc, omega-3 fatty acid, and polyphenol. You can go through the journal Food Science and Human Wellness 2019, beautiful article. The most beneficial results of dietary approaches to Alzheimer's, including the use of medical foods, may be expected when applied only early. Most studies of medical foods have been conducted in patients with mild Alzheimer's, so it cannot be translated to other stages. Large-scale studies are needed. Caffeine, 65% reduction of incident Alzheimer's disease, caffeine use, consuming 3 to 5, finishing, 2 minutes. And cocoa and cocoa-derived products needs further studies. Curcumin, Japanese say it's very good, but add on garlic, magnesium supplement, and multi-domain intervention with omega-3 acids. Resveratrol and others, these are all add-on, and we do not have even any evidence. LPs, what about coconut oil? It's supposed to have some ketone particles. Mechanism of aging and development say the virgin coconut oil is rich in medium chain fatty acid, and it may be sometimes useful, at least in prevention. Honey as a potential natural source of cholesterol inhibitors, Spanish studies. Why these trials are failing? The reason is majority of trials are focused on amyloid targets. Reducing amyloid deposition alone may not be sufficient. Not clear about the specific disease mechanism related to different amyloid species. Blood-brain barrier penetration is problematic with several agents. This is the new Natural Reviews Neurology, 2020. It was published online. 2021, it has come. The future, what we have to think about the future, belong to those who believe in the beauty of their dreams. Will we be successful? I don't know. Thank you very much. Thank you. Back to orators.
Thank you, Dr. Mohandas. Excellent, very erudite as usual, and very, very detailed presentation. Listening to you at the end of half an hour, I believe I have started feeling that I have dementia because I can't seem to remember more than half the drugs or the category of so possibly going in for that. But particular drugs which are in phase 1, phase 2, phase 3 trials in the next few years to come and have been in the past few years. Majority of them are talking about disease modulation, disease progression. Very few of them are actually trying to be acting on, are supposedly be effective on cognitive processes or cognitive enhancers. And many of these drugs which have passed phase 1 and phase 2 have unfortunately been stalled by phase 3 and have been abandoned. So we are looking at different kinds of targets, starting from the tau protein to autoimmune to all these kind of medications, plus going back to traditional healing therapies, like Dr. Mohandas mentioned, he's from Kerala, God's own country, and coconut oil, curcumin, all these are supposedly be enhancing or supporting the efforts that we make towards reduction in the damage caused by dementia. Very well enlightening and very, very empowering to us to know that there is so much research still going on in this field, because as projected, I'm sure Dr. Venugopal is sitting there, he'll confirm the number of aged people will keep growing, although countries like Britain are now extending the boundaries. So people who are aged are those who are above 75, elderly, and So that changes the ballpark. Dr. Vaya, anything you would like to add, please? Dr. Vihang Vaya? Dr.
I think
Vihang Vaya.
you've done justice to the talk, and once Dr. Mohandas speaks, there is very little for someone excellent data like you. I did not remember some of the, I mean, I couldn't even get the pronunciations of so many of the products that he mentioned. So at my age, I'm really comforted to know that Dr. Mohandas would be able to help me out. God forbid, should I need some help. It's always
Yeah, absolutely. Right.
Thank you.
We hand over
to
mic
you, Dr.
to
Alim, or
and Dr. GP Rao. I can see Dr. G. Prasad Rao.
I can see Dr. Avinash Prasad Rao coming up.
Yes, the ever energetic.
I guess Dr. Prasad,
Good afternoon.
Machine.
Good afternoon.
Good
Should I introduce
afternoon.
myself? Yeah, I am Alim.
Oh, we have
from
to
Lucknow.
introduce.
I'm introducing myself. Yeah.
Yeah.
I think I'm there on the screen.
Yes.
And I'm from Lucknow. And the next chairperson is Dr. Ruma.
Hi, good afternoon.
Good afternoon and welcome to both of you. Yeah, we can see them on there. I can see Dr. Ruma and I can see the screen of Dr. Alim's biodata. Yeah.
Member of
Are the
IPS Central
presenters
Zone
there?
and convener. Now I request the chairpersons to introduce the next topic, which is we selected very consciously the treatment-resistant schizophrenia. So over to the chairpersons, Alim Siddiqui and Ruma Bhattacharya. They are the four speakers.
Thank you
You
so
have
much,
the
sir.
introduction here.
Thank you so much, sir. So nice and kind of you to invite us to chair this session, myself and Dr. Ruma. The topic is extremely important and it is a sort of bread and butter. And if it comes in your exams and you don't do it, you are supposed to fail. Because if you don't know resistant schizophrenia, I think you don't know much of psychiatry. So thank you, sir, for taking us to the basics. So we have a team of 4 people, 4 doctors who will be presenting on the topic. Dr. Ruma, can you introduce the speakers?
Is there a slide?
I think
Is
there
there a
was a slide there.
slideshow for the introduction of the speakers?
Yes, you can see the slides now.
Dr. Ruma, they
Yeah.
will probably share.
Yeah, so
Yeah, there it is.
Dr. Satish Suhas, he's currently working with the schizophrenia and the metabolic clinics at the Department of Psychiatry, NIMHANS, Bangalore. Dr. Vijay Kumar, he's Associate Professor, NIMHANS. Dr. G. Venkat, Professor of Psychiatry and Head, Department of Clinical Neurosciences, National Institute of Mental Health and Neurosciences, and Dr. Narendra, Additional Professor, NIMHANS, Bangalore. So I guess with the
I
introduction of the
might add that
speakers,
these are the core scientists who are working on the area of schizophrenia for the last few decades. They have
Wow.
contributed immensely to the biological psychiatry. They also contribute in the translational psychiatry of translating their research into the practical utility. And 4 of the speakers are going to cover the most important areas where we need to intervene in terms of treatment-resistant schizophrenia. I would now request Satish Suhas to start his presentation.
Good evening to everyone, and I thank the chairperson for their kind words. I request that I be permitted to share my screen. Thank you. I hope my screen is visible.
Yes, it is.
Thank you, ma'am. During the introduction, there was very kind word used by the chairperson and Dr. Rao, but truth to be told, I think the esteemed panelists who come after me, esteemed speakers who come after me, have also done much of the work in the field of treatment-resistant schizophrenia and schizophrenia per se. Having said that, I have taken the relatively easier topic wherein I set the proof to the rest of the topics that are going to be discussed in the coming hour or so. And hopefully, some of the things that I cover will be of use in understanding the translational utility further down this symposium. So now, when we talk about treatment-resistant schizophrenia and neurobiology, we need to really look into the area of schizophrenia research per se. And I thought that what Berrios reported in 2003, when he said that the problem with schizophrenia research is that there are multiple parallelly running research programs, each based on different conceptualization of what schizophrenia is, each based on different understanding of what mental symptoms are and the human mind is, and therefore to sort of use all of these available literature and to amalgamate it into one understanding, unified hypothesis of what is the neurobiology of schizophrenia becomes extremely difficult, but yet it is something that is very pertinent. What is clear, however, is over the past several decades, several epidemiological studies and neurobiological studies have established that schizophrenia is much beyond an illness, and in fact, it is a syndrome in which the course and the natural course and outcome of the illness is very much known, and so on and so forth. In the past, say 3 to 4 decades, there are definite neurobiological correlates of schizophrenia, and as evidenced by the linkage studies which have shown the importance of dysbindin, neuregulin, the disrupted in schizophrenia gene 1 and 2, and the association studies that have shown the role of various neurotransmitters, and of course the all important big 3 neurotransmitters in schizophrenia, which is the dopamine, glutamate, and GABA, which perhaps, although by themselves cannot explain all the symptom domains, but when understood in an integrative framework, can explain almost all the symptom domains of schizophrenia. There have been consistent efforts in understanding the neurobiological meanings of multiple domains of schizophrenia through imaging data, but however, what is available is yet emerging evidence for us to kind of understand what is the neurostructural correlates of schizophrenia per se. Having said that, since the topic is predominantly focusing on the neurobiology of treatment-resistant schizophrenia, I kind of divert the attention of all the esteemed audience who have come in this particular online forum to the TRIP hypothesis, which looked at standardizing the conceptualization of what is treatment resistance in schizophrenia. There is a very important point that is raised in this particular consensus guidelines, wherein they say that there is a prominence of understanding treatment-resistant schizophrenia with respect to only the positive symptoms. If we look at the core criteria and the modified criteria, we understand non-response to antipsychotics only in terms of positive symptoms of schizophrenia. We have yet to evolve consistent, universally accepted definitions of treatment-resistant schizophrenia, taking into consideration the other symptom domains, such as the negative symptoms and the cognitive symptoms, which perhaps are more prognostic significance. So we accept that, yes, given this particular lack of consensus, we are going to look at treatment resistance in terms of resistance to antipsychotics with respect to the positive symptoms. And having defined that, let us look at some of the symptom domains of schizophrenia and what probably are the mediators of this treatment resistance. The centrality of dopamine and glutamate in defining of these neurobiological underpinnings of symptoms in schizophrenia continues. It all kind of comes together when in our first year MD days we are taught about the different neurocircuitry that are there in the human brain, especially we focus on the dopamine circuits in schizophrenia. And all too simplistically, we understand that the mesolimbic pathway are perhaps responsible for the positive symptoms of psychosis, whereas the mesocortical pathway hypoactivity is responsible for the negative symptoms of psychosis. But yet, we are not able to understand what causes all the other symptom domains of schizophrenia. But there have been attempts to understand the role of dopamine in explaining and in an integrative framework as to how it can probably cause the other symptom domains, wherein we look at the experience of a percept and the presence of an emotion, which is integrated at the level of the thalamus. And after the level of the thalamus, it is in the prefrontal cortex. And through the role of insight and expression, it is comes together in the form of an understanding of meaning to the environment that we stay in. Now, the role of the dopamine pathways in altering the meaning of that we make with our environment and the aberrant salience of this particular meaning can give rise to the psychotic symptoms. If that is true, then what defines or how do we understand the treatment resistance in schizophrenia? Whereas associated striatal dysfunction and excessive dopamine signaling can perhaps give us an evidence for what happens in early psychosis, and that we give the typical or the atypical antipsychotics and the persons respond or do not respond to them. Further down in the stage 3 or stage 4 of the schizophrenia illness, we are yet to understand as to what is the exact circuit level disruption that happens, which contributes to the relative lack of efficacy for the typical or the atypical antipsychotics, apart from clozapine. This is wherein the role of glutamate in schizophrenia becomes increasingly more relevant, and the NMDA receptor regulation of the mesolimbic dopamine pathway, wherein the tonic inhibition leads to a better understanding of the environmental influence and a healthy understanding of self and the environment, whereas the NMDA receptor hyperfunction in the cortico-brainstem projections can lead to the hyperactivity of this mesolimbic dopamine pathway, thereby leading to onset of the psychotic symptoms. Now, if we have to kind of integrate this particular understanding, there's an evidence from the electrophysiological data to suggest that although that there is sensory input that is giving us a lot of information in the form of what we see, what we hear, and what we perceive, which is integrated at the level of the thalamus, which then becomes a percept. It is the meaning attributed by the prefrontal and the limbic cortex, which is in a healthy sense modulated by the gamma oscillations, which gives rise to a healthy understanding of self and the environment. Now, we are talking about the neurocircuitry disturbance and the neurophysiological disturbances which occur simultaneously leading to persistence of symptoms in some of the structures which are essential for comprehension area, which can then lead to the manifestation of formal thought disorders per se. When we find it difficult to understand the entire conceptualization of the disorders of the symptom domains of schizophrenia, the role of GABA also becomes important, wherein GABAergic dysfunction can be explained in terms of a pre-existing susceptibility in the form of gene mutations, and which coupled with the environmental insults can lead to GABA circuitry disruption and a disrupted gamma synchrony, which can then lead to the deficits in sensory processing, reduction in selective attention or salience, and an impaired cognitive capacity, which can perhaps lead us to a better understanding of the negative and the disorientation domain of the schizophrenia illness. There is evidence to suggest that schizophrenia is a disorder of the connectome, meaning to say that it is not a simplistic neurocircuitry disturbance, but it involves the important role of the paralbumin and the basket cell neurons, in regulating some of these neurocortical structures, and therefore it is actually a disorder of connectivity which leads to the symptom domain of schizophrenia. Having understood these basic underpinnings about the symptom domains of schizophrenia, we now move on the famous hypothesis that was made by House and Kapoor, wherein they talked about probably the two types or two dopaminergic subtypes in understanding resistance in schizophrenia, as to why some people show resistance at an earlier stage and some people show resistance at a later stage. There was a landmark article which came out almost 20-30 years ago, which talked about the neuroleptic induced supersensitivity psychosis. This particular supersensitivity psychosis, or what we call as the dopamine supersensitivity psychosis, has given us a better understanding of what leads to differential treatment resistance in schizophrenia. To speak about it simply, we talk about a normal stage wherein there is a D2 receptor and dopamine, which leads to a normal dopamine activity. If the person is normodopaminergic, or what we call as type B, then in that particular person, there is a normal dopamine activity response to the particular, despite the presence of an antipsychotic, which can lead to lack of a response. However, if the person is preferential or type A, wherein he shows a hyperdopaminergic kind of a response, then we see that there is an increased or a better response to the antipsychotic treatment. Having understood these two, we now understand that after treatment, a person can have an increased expression of the D2 receptor density in the postsynaptic membrane, which then leads to increased dopamine activity despite the lack of the endogenous ligand that can stimulate these receptors. Therefore, they stipulated that the dopamine supersensitivity is perhaps a condition in which at least the antipsychotic exposure should be there for about 3 months. And after 3 months, we see that there is a presence of a rebound psychosis immediately after there is a change or a reduction in the dose of the antipsychotic within a few weeks for an oral antipsychotic and within a few months for a depot antipsychotic. And there is a gradual degree of tolerance that we observe to the antipsychotic, and symptoms are emerging despite the higher doses of the antipsychotic. And probably the onset of dyskinesias or the presence of tardive dyskinesia, which gives us a clue that we are talking about DSP as causing the treatment resistance. Now, when we talk about genetics, specifically with respect to the treatment resistance, there are various studies that suggest that the dopamine transporter variations can actually lead to better clozapine response or the lack of a clozapine response. And there is also the DRD2 polymorphism that are associated with dopamine supersensitivity psychosis. And so emerging evidence to suggest more number of copy number variants associated with treatment resistant schizophrenia. However, when there was an amalgamation of all the available literature to look at whether the polygenic risk score can be predictive of schizophrenia, the available meta-analysis as on date doesn't give credence to this hypothesis. But however, there is a trend level significance to suggest the polygenic risk score can show a differential susceptibility to or a response to clozapine. When we talk about the neuroimmune stress and the treatment resistant schizophrenia, there is a preferential activation of the monocytic pathways, which leads to an increase in the expression of the soluble TNF receptor 2 and the MCP1 ligands, and a decreased BDNF, which can actually express in the lack of response to the antipsychotics. There have been various studies that have tried to elucidate the neuroimaging correlates of treatment resistant schizophrenia, which has been aptly summarized in this particular slide, wherein we see that there are gray matter volume reductions in treatment resistance, particularly involving the frontal and the temporal regions. And this particular abnormality shows an susceptibility for treatment resistance, and the treatment resistance also is associated with the disruption to the white matter tracts, particularly the cause callosum. There is also evidence to suggest that there is an increased perfusion of the basal ganglia and treatment resistance, but this hasn't been replicated in large-scale studies. Now, towards an individual domains and an integrated framework. When we try to understand as to why we are trying to elucidate the correlates of the treatment resistance, of course, Professor Venkat will talk about the importance of these when he talks about TDCS. But we are trying to understand that there is the presence of deficient activation of the prefrontal cortex, which is associated also with a decreased N-acetyl aspartate levels in the frontal cortical regions. And also at the same time, there is an hyperactivity at the temporoparietal junctions with significantly increased glutamate levels, which can then lead to an understanding of both the positive symptoms of schizophrenia and the negative symptoms of schizophrenia. There is also a better understanding of the negative symptoms of treatment-resistant schizophrenia, wherein we now know that perhaps when we talk about the negative symptoms, we talk about two important circuits, that is the motivational salience circuit and the motivational value circuit. And the presence of dysfunction of the motivational value circuit can lead to problems in evolution, whereas the presence of dysfunction in the motivational salient circuit can lead to a generalized apathy that is presenting in the resistant schizophrenia. To kind of summarize the understanding of biological underpinnings of treatment-resistant schizophrenia, we see that in the clinical profile that perhaps there is an earlier age of onset, there is a more severe and a familial form of an illness, which is possibly associated with more rural residents, but it has not been replicated, which potentially specific cognitive deficits involving verbal learning and memory, but it is definitely associated with poorer outcomes in the quality of life. I've already summarized the neuroimaging correlates of resistant schizophrenia, but to summarize the biological underpinnings, we can perhaps say that there is pharmacogenetics that implicate the DRD2 but show conflicting results. But there are certain novel targets beyond the neurotransmitters that are being evaluated, nothing that comes to the level of level 3 evidence also. And there is perhaps enough evidence to suggest that the response to clozapine is something that can be ascertained through the selective understanding of the pharmacogenomics in precision medicine when we deal with individual patients with treatment-resistant schizophrenia. Perhaps when we look at the future with optimism, we can then understand that the gut microbiome hypothesis can give us a better understanding of why certain patients do not respond to oral antipsychotics, but they respond to the long-acting injectables. Perhaps the gut might hold the key to some of the other clues towards understanding the resistance in schizophrenia. The key take-home points from this particular talk is that the dopamine supersensitivity hypothesis accounts for treatment resistance in patients only who initially responded to an antipsychotic, and therefore it is limited in its construct. And there is differences in dopamine synthesis capacity that might be there from an illness onset per se, which might dictate treatment resistance. There is genetic susceptibility which can explain resistance, but which is not exclusively linked to the dopamine-related genes. There is also a glutamate hypothesis, which is suggested by neuroimaging studies and the preferential involvement of glutamatergic systems in multiple symptom domains, and also in understanding as to why specifically in treatment-resistant schizophrenia we see the role of glutamatergic modulators in alleviating the positive and the cognitive symptoms. Future work should perhaps focus on understanding the inconsistencies in definition of TRS, and the TRIPS hypothesis is one step towards that, and probably to look at larger sample sizes in the studies so that we can then come to some synthesis of the available data to better understand treatment resistance in schizophrenia. I want to end my talk by telling that although that we do not know extensively about treatment resistant schizophrenia with respect to the neurobiological correlates, we have come a long way since Bloiler, who had said that do we need to study the brain or the psychological conflicts of a person with schizophrenia. So we have come a long way from there to understand that we are several steps down in understanding the neurobiology of schizophrenia, and there is a very important question that we all need to ponder, whether resistant schizophrenia is a more severe form of schizophrenia with a greater symptomatology, with a similar neurobiology, or is it a distinct subtype with a unique neurobiology, which needs to be answered. But having said that, a journey of 1,000 miles begins with the first step, and we are probably further along the way in our understanding of schizophrenia and neurobiology as we look to the future for more answers. Thank you. Over to the chairperson, sir. Ma'am.
Yeah, thank you so much. Sir, can we now proceed to the next talk?
Dr. Venkat?
Yes, hello.
Yeah, Dr. Venkat, are you ready?
Yes, yes.
Okay, please. Yeah.
Yeah, I'll project my, I'll share my screen.
Yes.
Yeah, just 1 minute. So good afternoon again. And am I audible? My screen is visible?
Yes. Yeah.
Yes, it
Okay.
is.
Thanks again for this opportunity to talk about the utility of TDCS in treatment-resistant schizophrenia. So TDCS is a non-invasive safe technique that involves application of low-intensity direct current in the strength of 1 to 2 milliampere. And this current is delivered using bioconducting electrodes placed on the scalp. And the mechanism is believed to be polarity-specific neuromodulation and the resultant neuroplasticity changes. To expand on the TDCS mechanism, essentially it is based upon the membrane voltage changes. If you look at the effect of anodal TDCS, as we see in this slide, what happens is the resting membrane potential gets relatively depolarized, whereas if we apply cathodal current, the resting membrane potential becomes relatively hyperpolarized. What is important to note is TDCS by itself does not lead to a spontaneous action potential generation, which means the risk of for seizure is very, very minimal. The second set of mechanism involves neurotransmitter changes with the anodal inhibiting GABA transmission, so the net effect is facilitatory, whereas the cathodal TDCS inhibits the glutamatergic transmission, hence the net effect is inhibitory. And there are also neuroplastic effects in terms of secretion of BDNF being facilitated by TDCS. So this also contributes to some of the clinical benefits. And it is also important to note that though the current application is very superficial, due to the network interaction, the effects of TDCS could be quite remote and deeper, in the sense, as we see in this slide, a superficial application targeting the frontoparietal brain regions can have deeper impact, extending as much as up to hippocampi. Because of these variety of mechanistic effects and its relative safety, TDCS is attracting lots and lots of attention. And this was one of the seminal publication by Brunelin and colleagues from France, who demonstrated add-on transcranial direct current stimulation to help persistent auditory hallucinations in schizophrenia. So based on that, we started implementing this technique using this weak intensity modulation, not only with TDCS, but also expanded into a wide range of weak intensity stimulation techniques under this WISER neuromodulation program, ranging from transcranial direct current stimulation, alternating current stimulation, and high definition TDCS, and some of the newer variants. This is my colleague, Dr. Janardhanan, who works closely with us and coordinates several of the activities under the WISER neuromodulation program, in which we have standardized several of these TDCS application protocol. One important aspect I want to emphasize here is the safety of this technique across multiple age group is established. And very interestingly, we were also able to demonstrate a case application of TDCS during pregnancy. A woman who was pregnant, and in the first trimester, the pre-existing schizophrenia symptoms worsened. without any further change in the antipsychotic treatment, add-on TDCS helped in the clinical management. One of the major avenues for the clinical utility of TDCS in schizophrenia is auditory verbal hallucination. If we step back and look at the neurobiological basis of symptom genesis in schizophrenia, there is a consistent line of evidence that suggests the positive symptoms happen, perhaps one of the contributing components being the temporoparietal junction hyperactivity, whereas the negative symptoms might be due to the hypofrontality. And there are a set of coherent findings which support this kind of postulate. So in that context, TDCS offers a nice venue through which the aberrant hyperactivation could be inhibited using cathodal current, and the hypoactivity may be enhanced with an anodal current. So this is the cartoon reflecting the TDCS application protocol in schizophrenia. The conventional TDCS using 35 centimeter squared electrode with a stimulation intensity of 2 milliampere, twice daily sessions of 20-minute duration with an intersession interval of 3 hours. So what we found with this application protocol in the initial set of open label studies is that TDCS could show improvement in insight of schizophrenia patients with concurrent reduction in the auditory verbal hallucination score. We followed up this open label finding using rigorous randomized double-blind sham control design, and where we were able to replicate the findings of the Brunellin's group that was published a few years before. And in addition, we also found when we gave TDCS to patients that did not respond to the sham stimulation, that is in the open label extension phase, an active TDCS, we were able to show that these patients also showed a significant improvement as a group in the persistent auditory verbal hallucinations. So which added to the evidence base for the application of TDCS in schizophrenia. Of late, we have been using a refined version of transcranial direct current stimulation, that is high definition TDCS. In high definition TDCS, there are several optimizations. The first being the electrode size. In the conventional TDCS, the electrode size is rather large, 35 centimeter square, whereas in the high definition, it is much smaller with a diameter of 1.2 centimeter or 12 millimeter sized ring electrodes. In conventional TDCS, if we have to stimulate a brain region, we need to identify another brain region which has to be inhibited, whereas through the ring configuration of high definition TDCS, we might be able to either stimulate or inhibit. For instance, as demonstrated in the schematic representation, if I'm interested in injecting 2 milliampere of anodal current, I may want to identify the central electrode as the electrode of interest, and the return current will be shared equally by 4 electrodes, so that the cathodal current shared across these 4 electrodes is very minimal, with less likely significant effects in terms of both biology as well as possibly clinical impact. So in that case, the high definition TDCS offers an avenue to selectively stimulate or inhibit a particular brain region. Because of this kind of selectivity as well as the focality, high definition TDCS is more amenable for advanced modeling, so that the hope is to implement more precise stimulation with a potential for personalized neuromodulation. So these are some of the simulation studies which predict a high definition TDCS to be more focal with optimal peaking of voltage in a predictable pattern in comparison to the conventional TDCS. So some of the initial set of open label observations we had with the high definition TDCS has reported the application of this technique in patients with persistent verbal or auditory verbal hallucinations. This is the schematic depiction of the electrode application with the cathodal current on the left temporoparietal junction. So what we do in this technique is, in addition to the neuromodulation technique, there is an option to do what is called as a neuro-targeting. And also we can use structural MRI data to precisely locate the scalp placement of these electrodes. This is the work that we have published recently, which is led by Dr. Sriraj, where we could find the high definition TDCS to reduce persistent auditory hallucinations in schizophrenia patient, but in an open label design. So a follow-up randomized sham control design experiment is on way. We also have done some of the clinical neurobiological studies where we were able to understand the likely mechanism of action of TDCS in schizophrenia. One set of study involved what is called as a corollary discharge paradigm, in which we could show that add-on transcranial direct current stimulation results in improvement of corollary discharge deficit. This is a work of Dr. Anushree Bose as a part of her PhD thesis. The initial open label study, we could extend it further and examine in a randomized sham control design, where we were able to show the effect of TDCS to indeed result in meaningful attenuation of corollary discharge deficit correction. There are also other neurobiological studies that we have done with respect to examining the resting state functional connectivity data. Again, work of Dr. Anushree, and we were able to show that the true TDCS led to reduction in the resting state functional connectivity of left temporoparietal junction with left frontal region, which essentially suggests that the aberrant hyperactivity of this region perhaps may be suppressed by add-on TDCS. There are also interesting effects that we have observed. This is the work done by Dr. Mahavir Agarwal as a part of several ongoing works from our team, in which we could identify potential interaction between the medication type and the clinical benefit with TDCS, with a suggestion that patients that are treated with weak D2 receptors were found to do better in terms of clinical response to TDCS. And if you look at patients that were treated with high affinity D2 antagonist, they did not respond so well. So this might be one of the clinical lead which can help in choosing TDCS in future. Coming to the application of transcranial direct current stimulation in schizophrenia, especially the future avenues, what we are baffled by is significant inter-individual variability in response to this treatment, at least with auditory verbal hallucination. While part of it could be due to the disease heterogeneity, it is highly likely that there are several factors that may influence the varying outcome. So essentially the goal is to do a set of informed experiments and controlled studies through which we are able to reduce this inter-individual variability so that the optimality of benefit is enhanced. So this is the kind of design that needs future work. And there is also an exciting potential where TDCS, given its safety and relative simplicity for implementation, and very importantly, affordable neuromodulation technique in comparison to the other available ones, there is a scope for home-based TDCS. Already there are studies that have been initiated in other countries. So this is one area which is worth exploring, especially given the chronicity of the disease in the context of schizophrenia. So to sum up, taking on the principle of weak direct current can modulate neuroplasticity, TDCS is a re-emerging neuromodulatory technique that has several adaptive neuroplasticity effects. And in this presentation, I briefly touched upon some of the neuromechanistic basis of TDCS, and then shared some of our findings with respect to the utility of TDCS in treating auditory verbal hallucinations or persistent hallucinations in schizophrenia. It went on to show some of the differences between conventional and high definition TDCS, and then summarized some of our studies on corollary discharge deficits. And if you look at the safety profile, the data that we published recently shows TDCS is quite safe and well tolerated in a large number of patients across different age groups. So that is something which is very, very encouraging. And given the portability and tolerability and easy to train and cost-effective treatment, this is something which is worth exploring for home-based application. So I think with this, I will stop here, and thanks again for the opportunity.
Thank you, Dr. Venkat. It was a very lucid and interesting presentation. So who will be speaking next? Who is
Dr.
the...
Vijay. Yeah, Dr. Vijay here, madam. I go ahead with me.
Okay, yeah, please.
Yeah, please go ahead. I think we are going on time.
Yes.
I request the host to allow.
Please go ahead.
Dr. Vijay?
Yeah, yes, ma'am. Just,
yeah.
Thank you. Some reason I'm not able to share my presentation.
I think the technical team can help you.
Yes, ma'am.
Akanksha?
Yes, ma'am. I'm Shailen from technical team. How may I help you, sir?
The screen sharing is not happening.
Sir, your PPT, yes, sir. Presentation to select. It is the center bottom. You will get the option of the screen share with green color sign arrow.
Yeah.
Hello.
Hello. Yeah.
Yes, sir. Sir, center bottom में green color का sign होगा जिसपे लिखा होगा share.
Share and screen.
I did that. After that, it's coming.
Then after that, the multiple screen will be open. Please select your presentation and then share it with the blue. फिर right hand side में share लिखा होगा blue color से. Screen select करके and then share. Yes, sir. Sir, maximize your slideshow. Once it will be open. हाँ, yes, sir. अब इसको sir यहाँ से.
Can you see now?
Yes, sir. Done. Perfect.
Sorry for the initial. Good afternoon to all. Thanks for this opportunity. I'll be primarily focusing on the utility of therapeutic drug monitoring to optimize treatment in schizophrenia, but the focus will be on closure. As we all know, TDM means quantification and interpretation of either the plasma or serum concentration of a drug to optimize the pharmacotherapy. Why TDM is needed is we are generally in our clinical practice, we know that we give the medication and we observe for the clinical effects. But there are a lot of factors which work in between the prescription of a dose and its pharmacodynamic effect. And in this particular review, they highlight that the inter-individual variation in the drug concentration of for a prescribed fixed dose can be up to 20 times. It can be due to absorption of the medication, distribution, metabolism, or excretion. And as we are aware, many of the factors mentioned there, including the age and gender, do influence most of these factors, leading to inter-individual variation. So therapeutic drug monitoring in that such a scenario helps us to optimize the pharmacotherapy in multiple the following clinical scenarios where we are suspecting in the influence of the age on the serum or the plasma levels, or there may be drug interaction that are affecting the serum or plasma levels, or it can also be it may also be due to distinct particular genotype the individual is having, leading into either a poor metabolizer or rapid metabolizer, which would affect the serum or plasma levels. In that context, therapeutic drug monitoring will help to optimize the effectiveness of the antipsychotic. One, at the same time, it also helps to ensure the better safety of the prescribed medication. So in this context, therapeutic drug monitoring will be especially useful whenever we have non-linear dose concentration relationship for a particular drug, and when we have a narrow therapeutic window, as we are all aware in the case of lithium. And particularly, I would like to focus on the issue of suspected adherence in the context of treatment-resistant schizophrenia. In general, in not being treatment-resistant schizophrenia, in any chronic disease, the report says that nearly 50% of the medications are not taken as prescribed. It's not only for mental disorders, it's in general for any chronic disorder in medicine. So improvement in adherence, the WHO report says that improvement in adherence may have a far greater impact on the health of the population than any other specific improvement in the medical treatment. That is the significance of adherence with respect to medications in medicine in general. Specifically coming to schizophrenia, this was a study which was published in Journal of Psychopharmacology in 2015. In the test, from the patients who were referred to tertiary center for the management of treatment resistance, what they could find was the medication for which it was recorded that the patient has been given adequate trial and there is no response, that medications were not detectable in about 20% of the patients, and the medications had subtherapeutic, they were in the subtherapeutic range in their serum levels in about 2 or 25% of the patients. Put together, it suggests that nearly about 44% of the patients with treatment-resistant schizophrenia probably had not got an adequate trial with another antipsychotic. On similar lines, in another study, which was not only for clozapine, not only for ERS, for all the patients, including all the patients with schizophrenia, they tried to find the correlation between subjective and objective measures of treatment adherence. What they found was plasma concentration did not have any correlation with either the physician rating of the adherence or the patient's self-report of so-called adherence telling that I'm taking medication. And even with the other objective measures like pill count and electronic monitoring. Does mean that whether you do pill count or electronic monitoring, or you talk to the patient and try to get the information, that may not exactly correlate with the real adherence of the patient with the medication. So considering this, therapeutic drug monitoring is generally indicated when the medications are not effective, or the medications are effective, but there are significant adverse effect reaction. And whenever we are suspecting significant pharmacokinetic variations due to multiple factors, and in conditions like pregnancy and breastfeeding, where changes in the volume of distribution as well as the cytochrome activities are known to influence the drug levels. In addition, they are also indicated in special populations and individuals with medical comorbidity, as well as in forensic psychiatry patients. It's not that all the TDM is, as of now, is recommended for all the antipsychotics. Based on the available evidence at this point of time, primarily based on the RCTs, TDM is strongly recommended for medications like clozapine, olanzapine, fluphenazine, haloperidol, and perfenazine. And for many of the other medications, it is either recommended or it is considered to be used. So in this context, I would like to focus on therapeutic drug monitoring of clozapine. As we all know, that clozapine is primarily metabolized by cytochrome P1A2, nearly 70% of it, and other cytochrome enzymes do contribute for its metabolism. Primarily, it is metabolized into norclozapine, but other byproduct is clozapine inox. What is the recommended clozapine dose for treatment-resistant schizophrenia? If you see the recent APA guidelines, it says that the target dose is somewhere between 300 to 450 milligram per day. And in some individuals, higher dose up to 900 milligram per day may be needed. But what is baffling here is it's a kind of blanket statement. The target dose, it's like 300 to 450. For whom? Do we have any stratification based on gender, smoking status, or other important factors which are known to influence the serum clozapine levels? No specific guidelines have been, no specific recommendations have been given on this particular important aspect that are known to influence the serum clozapine levels. Even on similar lines, not only APA, if you see the recommendations from multiple authors in the US, they say they give some dose range, but nowhere this kind of a stratification primarily based on at least gender and smoking status is not mentioned. The only this recommendation, this evidence for this recommendation from a very strong, very rigorous double-blind study is very much limited, because as of now there is only one double-blind study which has looked at the dose between 300 to 600 milligram per day of clozapine, and which showed that in that range patient with TRS do respond to clozapine. But subsequently, what we have, the data on clozapine utility in TRS largely is based on either database or retrospective studies. So based on that, without strong evidence, an expert review recommended that female non-smokers may need around 300 milligram per day of clozapine, and compared to male smokers requirement of about 600 milligram per day of clozapine. In the Europe also, this same confusion continues. There also you get the broad ranges without specifically referring to stratification based on gender and smoking. That's it's about clozapine dose. But what is the recommended clozapine level? Do we have a definitive lower and upper limits? Is the question to be addressed. This is the only one double-blind controlled RCT where serum clozapine levels, the effect of serum clozapine levels was assessed to look at the effectiveness, to look at the treatment response. In that, there were 3 arms which looked at the treatment response with 50 to 150 nanogram per ml was one arm, 200 to 300 nanogram per ml was the second arm. Third one was somewhere between 300 to 450 nanogram per ml. What they found was the arms B and C. In B, it's there. If the patient had a serum clozapine level of somewhere between 200 to 450 nanogram per ml, they had superior efficacy compared to clozapine levels of somewhere between 50 to 150 nanogram per ml. Subsequently, based on whatever the database, the data from the retrospective studies, across multiple reviewers, the agreement is that probably we need at least a minimum of 350 nanogram per ml of serum clozapine levels for it to be effective. This is the recommended clozapine level lower limit. But what about the upper limit? If 350 nanogram per ml is lower limit, what is the upper limit? If the patient is not responding at that level, to what level we can further increase the serum, can increase the clozapine dose and serum clozapine level. At this point of time, we do not have any definitive consensus. Okay, because no prospective double-blind RCT has examined the clinical response and the side effects beyond 450 nanogram per ml. With respect to clinical response, once again, the expert review, expert's opinion, as well as based on the data from the database from the nationwide databases, the recommendation is somewhere between 600 to 838 nanogram per ml may be the upper limit. Beyond that, there will not be additional clinical improvement, but the side effects may improve. That's why this particular group recommends that the upper limit should be somewhere between 600 to 838 nanogram per ml. And with respect to adverse effects, some studies have found no correlation between the serum clozapine levels and the adverse effects. But there are some other studies which have found the correlates. That's why the cutoffs have been with respect to adverse effect. It's varied somewhere between 600 nanogram per ml up to 1300 nanogram per ml. So this is again the same thing. Then one particular fellow finding that beyond 1000 nanogram per ml, we need to add one anti-epileptic drug. But there are also other reports which suggest that patient could tolerate more than 1000 nanogram per ml without any adverse effects. So considering that at this point of time, we are not sure what is the upper limit of serum clozapine level till what we can optimize the clozapine treatment, taking into consideration both the response as well as the adverse drug reaction. This is all about the acute management of a patient with TRS when we are starting the antipsychotic. But what about maintenance treatment? Whether the serum clozapine levels needed in the maintenance treatment of TRS is different from acute treatment. There is only one report which is available, which states that during the maintenance treatment, probably we need a serum clozapine of about 200 nanogram per ml, which is largely about 40% reduction from the acute treatment serum clozapine levels. Moving on to the utility of clozapine for TDM for relapse prevention. The TDM studies suggest that if there is fluctuation in serum clozapine levels at different 2 or 3 different time periods, then it does predict a relapse of psychosis in TRS. So in that context, TDM may also be useful for the relapse prevention in treatment-resistant schizophrenia for those fellows who have responded well to TRS, responded well to clozapine. Moving on to the important factors that do affect serum clozapine levels, I would like to focus on 4 or 5 important factors. To begin with, it's the gender. As you all know, estrogens decrease cytochrome P1A2 activity. It suggests that the females require less per clozapine dose. If we keep all other factors constant, the consensus is about 15% lesser dose is needed in females compared to males. Moving on to the smoking, which is we commonly come across in patients with TRS having comorbid nicotine dependence syndrome. Smoking of about 1 to 5 or 6 to 10 or more than 10 cigarettes, that's differentially influences the serum clozapine level, and we have to increase the clozapine serum oral clozapine dose by at least by 1.2 times or 1.5 times or 1.7 folds, depending upon the number of cigarettes that individually smoke. Maximum induction of that particular enzyme would happen at 20 cigarettes per day. So beyond 20 cigarettes, it doesn't make doesn't make any sense to increase the clozapine dose further. Moving on, the other important factor is that induction of this CYP1A2 enzyme with smoking happens between 2 to 4 weeks. But once the individual cuts down the smoking, that the baseline activity of the CYP1A2 activity, it tends to baseline within 3 to 4 days. That's why, especially when a patient with TRS smoking, having nicotine dependence syndrome, when they are admitted, many of them may suddenly stop smoking. So it carries the risk of serum clozapine levels increasing by around 30 to 40% or 50% time, 50%, at least by 50%. So the recommendation is post cessation of smoking, at least we should decrease the clozapine dose, oral dose by at least 20%, and we should monitor for next few weeks looking at the dose dependent adverse effects. And if these adverse effects appear, then there is a scope for further reducing the clozapine dose, maybe up to 40 to 50% of the baseline dose. Then moving on to the many inducers and inhibitors of in the context of cytochrome P1A2, we all know that many of the antidepressants, including fluoxetine and others, are inhibitors. Important thing is the fluoxamine. Fluoxamine is a very potent inhibitor, and it may increase it may cut down the clozapine dose requirement by about 5 to 10 times. So considering that if before fluoxamine an individual was taking 200 milligram per day, just add fluoxamine, the clozapine dose requirement may come to around 20 to 100 milligram per day. It can be as low as 20 milligram or 25 milligram of clozapine. So fluoxamine needs about 100 milligram per day for near maximum inhibition of fluoxamine, near maximum inhibition of clozapine metabolism. Beyond 100 milligram per day, there will not be further increase in the serum clozapine levels. So there are also other advantages of adding fluoxamine with clozapine, but whenever we are adding fluoxamine to a patient who is on clozapine, ideally we should not, ideally there should be a facility for therapeutic drug monitoring, and we should not prescribe fluoxamine with clozapine in the absence of therapeutic drug monitoring. Among the inhibitors is oral contraceptives. The correction factor is 0.5 in a sense that if the patient is already on a oral contraceptive while on clozapine, we need to cut down the dose by nearly 50%. For inducers like carbamazepine and rifampicin, the correction factor is about 1.5 to 2. It means that we need to increase the clozapine dose by at least by 50% to 50 to 100%. The data on valproate is still controversial in the sense that some studies have shown that valproate inhibits the clozapine metabolism, whereas the other shows that valproate induces the clozapine metabolism. We'll come to the Indian data on valproate slightly later. With respect to obesity also, increase in the fat tissue generally decreases the clearance of clozapine. So, but it becomes clinically relevant only if there is extreme obesity. In other situations, it may not be clinically significant, but it does suggest that the individuals who are more obese may require lesser clozapine dose, clozapine dose to achieve therapeutic serum clozapine levels. Inflammation in general is known to increase it's known to inhibit cytokines are known to inhibit cytokines are known to inhibit CYP enzymes. So in that context, we need to cut down the clozapine dose, as if we do not cut down, it may result in clozapine toxicity. Now moving on to the very important factor, and which is being discussed in the recent times, about the influence of ethnicity on the clozapine metabolism and the clozapine dose requirement. All this started in 1997 when in Taiwanese patient, for the first time it was seen that when it was compared with the Caucasians, the 100 milligram per day of clozapine results in nearly about 30 to 50% higher serum clozapine levels in Taiwanese compared to Caucasians. It was subsequently in a review of all the Caucasians as well as the Asian studies published, overall it suggests that to achieve a serum clozapine level of 350 nanogram per ml, we need about 220 milligram per day of clozapine in East Asians compared to around 330 milligram per day in Caucasians. The Indians, from the available data of the two studies, suggest that Indians need roughly about 160 milligram per day of clozapine to achieve the serum clozapine level of 350 nanogram per ml. It is reflected in the the clozapine dose that's been prescribed in Asians. It's a review which was published. It suggests that in majority of the Asian countries, the clozapine dose given was almost less than 300 milligram, except for Sri Lanka and Malaysia. So, based on these findings, there is also a recommendation that Asian patients may require only half the clozapine dose as that's been prescribed to Caucasians. Now, moving on to the Indian studies, there were only two studies. One study which has been published from our center. In this study, with about 88 patients who are not on any confounders like either non-cytokine inducers or inhibitors, including smoking. The mean dose required in males to achieve 350 nanogram per ml of serum clozapine was about 130 milligram, and in females it was about 120 milligram. And nearly 52% of the patients on clozapine dose of less than 150 milligram per day had therapeutic serum levels, and only in 10 to 15% of patients we had to give more than 300 milligram per day to achieve the therapeutic serum levels. In our study, valproate induced clozapine metabolism, which is much more similar to a finding, from CMC value. On stratification with respect to gender and smoking, male smoker in our study we needed about 280 milligram per day of clozapine to reach 350 nanogram per ml of serum clozapine, while compared with female non-smoker who needed around 120 milligram per day of clozapine for the 350 nanogram per ml of serum clozapine levels. Similarly, in CMC study also, they did find about 30-fold inter-individual variability in serum clozapine levels. And in their study also, caffeine decreased the serum clozapine levels, whereas valproate increased the same. So they did also find that serum clozapine level about 750 nanogram per ml increases the risk for seizures by about 5-fold. So to conclude my presentation, therapeutic drug monitoring obviously helps to optimize treatment, balancing the effectiveness and adverse drug reaction. But the need of the hour is population-based pharmacokinetic models. Especially, we need a prospective trials across the continents, and pharmacogenetics and therapeutic drug monitoring plays a very important role in precision medicine, enhancing the balance between effectiveness and adverse drug reaction. And with respect to clozapine TDM, further systematic research is needed. Thank you.
If the chairperson permits, I could start my presentation.
Dr. Naren?
Yeah.
Yeah,
Shall I
please start.
Hmm?
Yeah, please do.
Thank you. So
Yeah.
what I would be focusing in the next 15 to 20 minutes is more practical and clinically oriented topic of what are all the pharmacological treatment options in resistant and refractory schizophrenia. After hearing the neurobiology and the brain stimulation and therapeutic drug monitoring, this talk will mainly focus on the what are all the available treatment options and what is the current level of evidence. I'll be focusing more on the clozapine resistant schizophrenia more than the regular treatment resistant, because clozapine is still the standard care treatment for treatment resistant schizophrenia. As you could see in this graph, compared to any other available antipsychotic, in cases of treatment resistant schizophrenia, clozapine still has an edge. So this is far better compared to any other available antipsychotic. So there are several studies which have looked at positive symptoms, negative symptoms, depressive, overall symptoms. In overall and positive symptoms, clozapine definitely has an edge. It also has an edge in depressive symptoms associated with schizophrenia. When it comes to negative symptoms, there are other molecules which may be as good as clozapine. So in cases of treatment-resistant positive symptoms, clozapine is still the drug of choice. There is no other molecule which can compete with the clozapine. So the older data still holds good. So, however, clozapine has some specific indications like suicidal attempts, and it also decreases the hospitalization. So even though there are several reports of intolerable side effects, many studies have shown that clozapine has better reduction of suicidal attempts in schizophrenia. So, however, 30% of patients receiving clozapine remain symptomatic. So they have been given different names like clozapine resistant schizophrenia, ultra resistant schizophrenia, super refractory schizophrenia, or clozapine unresponsiveness. Depending on the research team, the criteria used for this differ. But in a nutshell, most of these studies look at whether patients received adequate trial of clozapine and for adequate duration. Dose and duration of the trial was adequate or not. Okay. So when we speak of clozapine resistant schizophrenia, it is not that the patient is resisting treatment, that is the pseudo-refractory because of poor compliance. So that we have discussed in the previous presentation, where Vijay mentioned that at least 50% of the patients may not be taking the medication. So we are not speaking of pseudo-refractory, or it is not due to poor treatment, that is inadequate trial, that in which the therapeutic drug levels are not reached, or despite the doctor giving the adequate dose and patient taking that, there could be several other factors like was mentioned in the previous talk, that we may not have reached adequate level. Okay. So if we consider all these three factors, and if all of them are taken care, that we have reached adequate drug levels, but still somebody is resistant to schizophrenia, they are termed as clozapine resistant schizophrenia. So this is the commonly used treatment criteria, that they should have received at least 8 weeks of treatment with plasma levels of more than 350, and there should not be at least 20% reduction in PPRS score. So they should have persistent positive symptoms, that is the psychotic symptom, and they should have moderately severe illness. So negative symptoms are not taken into consideration when defining clozapine resistant schizophrenia. So it is mainly towards the bias towards the positive symptoms. So we have several options under the pharmacological strategies. We also have several non-pharmacological strategies, which we have heard before. Among the pharmacological strategies, the commonly used option is the augmentation with antipsychotic, but there is evidence to suggest some of the antidepressant as well as mood stabilizers may be useful. And I will speak briefly about the available evidence with other agents which are more of an experimental and not commonly used for other indications. Then among the non-pharmacological management options, we have transcranial magnetic stimulation, the time-tested ECT, cognitive behavior therapy, and we already have spoken about the TDCS. So let me look at the available evidence in brief. Among the antipsychotics, the most widely examined antipsychotics are risperidone, amisulpride, aripiprazole, ziprasidone, and haloperidol. There are also other antipsychotics which have been examined, but these have more number of studies compared to others. So as you could see in this graph, the evidence is mixed. Some studies have shown risperidone to be useful as an augmentation with antipsychotic. However, other studies have not shown such an effect. So one interesting thing is that whenever studies have used BPRS as the rating scale, which is heavily loaded with general psychopathology, the response is shown to be positive. However, it is not very consistent when we use other rating scales. Among amisulpride, the outcome is fairly consistent when compared to the risperidone studies. However, the effect size is not very good, but the outcome is fairly consistently reported in several studies with respect to amisulpride. So what has been upcoming is the augmentation with aripiprazole. In the last decade, there are several studies which have shown that the overall symptoms, as well as if we look at only the negative symptoms also, augmentation with aripiprazole may actually be useful. And this is emerging as one of the main molecule to augment clozapine in cases of clozapine-resistant schizophrenia. So this is a recent network meta-analysis which has looked at all available augmentation strategies. And as per this meta-analysis, as you could see, several studies are available for aripiprazole and consistently report that aripiprazole is better compared to placebo when it comes to augmentation of antipsychotic, augmentation of clozapine. So on the other hand, risperidone and amisulpride, though they do show some promise, the main difference is not as good as the aripiprazole. So maybe aripiprazole and amisulpride could be one of the first line treatments. There are few studies with respect to penfluridol and with respect to olanzapine augmentation. However, they are not replicated in other studies. So in the absence of replication, it's hard to, or the evidence is not very convincing. So to summarize the antipsychotic efficacy, it's the aripiprazole and amisulpride followed by risperidone, which may be useful, whereas other antipsychotics are less likely to be useful as augmentation agents in cases of clozapine resistance. So this is another study which looked from a real life data. So this was the effectiveness data based on a large registry. This also showed that when it comes to clozapine augmentation, or even in general when it is used as a clozapine therapy, when compared to monotherapy, clozapine plus aripiprazole seems to be much better when compared to clozapine alone. So both in cases of augmentation as well as in cases of non-augmentation, the clozapine plus aripiprazole combination seems to hold a better edge compared to clozapine plus risperidone or clozapine plus olanzapine or any other antipsychotic agent. So among the antidepressants, which I discussed about fluoxetine and fluoxamine, so both because of the pharmacokinetic as well as the pharmacodynamic interactions, they have well examined. There are few studies which have examined mirtazapine also. Because of its safety profile, citalopram also has been examined. The main indication in clinic has been on for the treatment of clozapine-induced OC symptoms or clozapine-worsened OC symptoms and the presence of the depressive symptoms. Maybe as it was discussed, fluoxamine and fluoxetine may increase the serum levels, and people have tried to examine whether this could actually give an edge with respect to clozapine-resistant symptoms. However, when it comes to the clozapine-resistant positive symptoms, fluoxetine did not have any edge. Similarly, fluoxamine had edge only in the open label studies. We don't have any RCTs. Citalopram did not have an edge on the positive symptoms, but it had an impact on the negative symptoms. Mirtazapine has been examined because there are 3 published studies There are 2 positive studies and 1 negative study. But as you could see in this graph, there is a substantial heterogeneity. So it seems to have some signal, but we need bigger studies with better methodology to have a convincing evidence. So mirtazapine may hold some advantage when compared to other antidepressants, but it's too preliminary to conclusively tell. So among the mood stabilizers, people have been using valproate and lithium. So there are studies which have examined that, and recently few studies have examined lamotrigine and topiramate. So lithium, there are 3 studies, 2 positive and 1 negative, but it also worsens some of the side effects. People have been traditionally adding lithium because it may increase the WBC counts. But it's important to note that the amount of WBC count increased by lithium is too less when compared to the amount of WBC drop that could happen with clozapine. However, when it comes to carbamazepine and valproate, because there is an added risk of bone marrow suppression, so in those cases, lithium may be a better choice. Valproate, there are 2 low quality studies which have reported improvement in positive symptoms, but if you look at the real life data, this is one of the molecule which is very commonly used, may also be because of its anti-convulsant property more than its efficacy in clozapine resistance. So when we go up on the dose of clozapine, maybe it's a useful add-on molecule, but we don't have very good evidence to suggest that valproate is very useful. On the other hand, the upcoming evidence suggests that lamotrigine may actually be much useful compared to valproate. It also has the added advantage that the metabolic profile is far better compared to valproate when we use it with clozapine. Except for its delay in reaching the threshold dose, lamotrigine, the evidence is fairly consistent. Out of the 5 studies, 3 studies had shown better than placebo, whereas 2 studies were almost similar to placebo. So there are no studies which showed better efficacy with placebo. So lamotrigine seems to hold some promise compared to other mood stabilizers, may also be because of its glutamatergic action. So topiramate has been examined because of its favorable property of both mood stabilization as well as its weight loss property, but studies suggest that it's not very useful when it comes to the efficacy in treating symptoms of schizophrenia, and the studies are a little heterogeneous. So other glutamatergic agents which have been tried are D-cycloserine. There was some studies suggesting improvement in negative symptoms, but there was no improvement in positive symptoms. D-serine, there was no improvement. Glycine, N-acetylcysteine, they are very early studies. N-acetylcysteine, there is one study which showed positive result when it was added to clozapine for clozapine-resistant schizophrenia. So modafinil, it is useful to decrease fatigue and somnolence induced by clozapine. However, there is no improvement in positive or negative symptoms in a single study. Interestingly, there was no worsening of positive symptoms in this study. So that may be one reassuring thing when we use it with clozapine for treatment of somnolence. Otherwise, it may not hold much promise for treatment of negative symptoms which are resistant to clozapine. So 3 studies have used omega-3 fatty acids along with clozapine. However, the sample sizes are small, but there was improvement in both positive and negative symptoms in 2 studies. So if somebody can tolerate the high dose of omega-3 fatty acids that are required, so please note that it is 3 grams per day. So with the available preparations, we may have to give close to 5 to 6 capsules every day if we are planning this as an add-on to clozapine. So if somebody can tolerate with the gastrointestinal symptoms because of its useful properties, omega-3 fatty acid may be an attractive option. A few other molecules which have been tried are, one is sodium nitroprusside. It's a nitric oxide donor. There are 2 clinical trials which were very promising. So this was termed as the ketamine of schizophrenia because the improvement was very rapid within 4 hours in these studies. However, following this, there were 3 additional studies. The subsequent studies did not show improvement, which were reported in the earlier studies. However, it's important to note that the previous studies, which were small, used younger patients, whereas the later studies had taken older patients. So it may be useful in early in the course of schizophrenia if we have young and severely ill patients. Whether it is useful is something that we need to still examine and check before disregarding the sodium nitroprusside. So memantine, there are 4 studies which reported, and 3 of them actually reported improvement in negative symptoms. However, there are several methodological issues and they prevent one from definitive conclusions. If somebody can tolerate and memantine, so it may be an useful addition if the clinician wants to experiment. So as of now, the evidence is not very convincing. So one treatment which has shown significant effect compared to other treatment modalities is ECT. So this is a very well conducted sound methodology, a randomized controlled trial of 12 ECT add-on to clozapine resistant schizophrenia. And as you could see, the blue line was clozapine alone, whereas the red line is the clozapine plus ECT. And as you could see, by the end of 4 weeks, there was a clear gap between the clozapine alone versus clozapine plus ECT. And it was not only in the symptoms of schizophrenia, but also in the global impression, which was rated by the clinician. So both in terms of functioning as well as in terms of symptom remission, ECT seems to still hold the promise. So efficacy of TMS is still uncertain. High frequency TMS over DLPFC, low frequency over temporoparietal cortex has been tried. The efficacy in terms of clozapine resistant schizophrenia is not very clear at this point of state. So to summarize, 30% of patients are resistant to clozapine treatment. Important thing is we need to rule out pseudo-refractoriness either because of poor compliance or inadequate trial or because of poor serum levels due to various factors. So if it is true resistance, then the best available treatment option as of now is ECT, but it's only based on one study. The good management options are aripiprazole. The evidence is sound with multiple studies and also in the meta-analysis. Then we have valproate, amisulpride, risperidone. So the evidence is equivocal. So among the 3, I would suggest maybe the amisulpride holds better promise compared to risperidone and valproate. Lamotrigine is upcoming, so it's consistent when compared to other mood stabilizers, better than valproate, but the experience with valproate with many clinicians is far outweighed compared to lamotrigine. Evidence-wise, lamotrigine holds better than valproate. Antidepressants and mirtazapine are questionable. Maybe N-acetylcysteine and omega-3 fatty acids have potential utility, but we need to examine them in more systematic trials. So to conclude, though I have discussed more from an evidence base, absence of evidence should not stop clinicians from employing interventions which do not have evidence in individual patients. So maybe there are a few individual experiences which may be very useful, and those molecules may need to be examined in systematic trials. Thanks for your patience.
Thank you, Dr. Naren. A very nice presentation. I would like to thank Dr. Satish, Dr. Venkat, Dr. Vijay, and of course, Dr. Naren. Dr. Ralim, you have something to say?
Organizers, do we have any questions for the panel, or we can wind up?
We can wind up actually because we are a little, beyond time.
So thank you all the panelists, the organizers. Thank you, Dr. Ruma. And any word you want to say, Dr. Ruma?
Like I said, it was a very good presentation on treatment-resistant schizophrenia. some information which I really didn't know, and it was really enlightening. So I guess we can proceed to the next session. If you have something to say.
Thank you. Over to the next session.
I would like to thank the organizers for having us as chairpersons. Dr. Malay Dave, are you ready with your presentation?
Yeah, I am ready.
Okay, good. Good afternoon.
Good afternoon.
And I guess I think the next chairpersons would be there as well.
I guess so.
Yeah, I am there.
Yeah, Dr. O.P. Singh, good afternoon.
Good evening. Good afternoon, Ruma. Good afternoon, Malay. And good afternoon, everybody.
Good afternoon, everyone.
Yeah, Dr. Devashish is there as well. So you
Devashish
can carry on.
Good afternoon.
Good afternoon.
Good afternoon, sir.
So,
please take over.
You will be posting the slides?
Yeah,
or we should start?
We can get started right away.
Someone can introduce Dr. Malay.
Devashish da?
Hello, am I audible?
Yes, yes.
Am I audible?
Yes,
yeah,
yes,
yeah.
you are audible.
Yes.
Yes. Before we.
There's too much of echo.
I think sir login has 2 devices. आप 2 device से login है इसी चक्कर में echo आ रहा है.
Dr. Malay?
Yeah.
Are you like starting?
Yeah, I think
They
I'm
are
just
posting the slides, perhaps.
Whenever the chairperson say, I'll start the presentation.
Yeah, you can get started right away.
So, no need to introduce Malay. Malay is, of course, the leading guru of biological psychiatry, and everybody is aware of his contribution towards the knowledge. So I invite him, and he will be talking about the we all use antidepressant, but optimizing the dose and how we can get the best results. So we will not take much time, and we ask Malay to start.
Thank you, chairpersons. Thank you, the organizers, for giving me this opportunity to speak on the topic. I'll share my screen and we'll begin without delay. So the topic for today is antidepressants and how do we optimize the therapeutic response. The fact of the matter is that depression is a very common psychiatric illness and affects over 300 million individuals worldwide and is responsible for most of the annual suicides that are reported by various agencies across the world. Obvious that we are dealing with a huge load of patients, many of whom are either not able to come to us for treatments or treatment is not available to them. And many of them who have been diagnosed adequately, but the treatments are not working for them. And for some, it would be that the diagnosis is not done properly. So whatever the matter is that it is obvious that we are dealing with a substantial number of people on earth who are in need for proper and adequate treatment. Now, what I'm going to do is cover the basics of how we can approach patients clinically and what best we can do in terms of titrating or selecting treatments for our patients. Now, this is a snapshot of the NICE guidelines, the updated NICE guidelines up to the last 2 years, till 2018. What do these guidelines in brief mean? And what we are supposed to learn from this is that, first of all, antidepressants are not recommended as a first line treatment in recent onset mild depressions, which can be better addressed with active monitoring of symptoms, if there are fluctuations, individual guided self-help, CBT, or exercise. Most of the guidelines are similar to NICE guidelines in telling us that the first line treatment for mild depressions is not pharmacotherapy. That is one thing we need to look at. But anything that is more severe than that, moderate, severe, and complicated forms of depression are, of course, absolute candidates for antidepressants therapy. So, and even for dysthymia, a form of depression where the symptoms are going on and on for 2 years without any kind of remission, or chronic depression, for all these things, medication is the first line of treatment, and of which SSRIs are recommended as first line in most of the treatments, most of the treatment guidelines. Apart from the fact that if there is an obvious uh, uh, people are not tolerating it, and it comes to the point that we have to either discontinue it, but till that point SSRIs are the first line. What we need to inform people all the time, and which has been emphasized in most guidelines, is the withdrawal or the discontinuation effects of antidepressants that people may experience when after, let's say, the first episode of depression which is being treated, and the treatment has now come to an end. We have probably given enough time for treatment and now we need to stop it. That is the time some people may experience withdrawal symptoms, and we need to be made aware of them, and this has been repeatedly told to us by various guidelines. When it comes to treatment resistant depression, augmentation is necessary with lithium antipsychotics or a second antidepressant. We'll come to all these things little later. But this is the gist of what happens when we are faced with patients with when we are faced with patients having depression in its various formats. 2 prior episodes and functional impairment should be treated for at least 2 years and more, depending on family history, the types of the severity of the symptoms, the need for hospitalizations, suicidal behaviors, and ECTs in severe and treatment-resistant depression. This is the overview of most guidelines. I've put up NICE guidelines here because most of us do read these guidelines. These are very simple and very easy to understand, follow. They are available in the form of the Maudsley book, which is there in terms of good charts and diagrams. So quite a few of my points and the diagrams of the charts are from the Maudsley book. Okay. Now, to start with, the most important thing when we need to optimize treatments for any psychiatric disorders, including depression, is how do we assess this? Do we go by guideline, or do we go by the criteria that we have, DSM-5, ICD-10, and now ICD-11? Because that is only going to give us a cut cross section of symptoms that the patient is presenting us with. How severe is the episode? What is the duration? Past history, risk of suicide, contributory stress factors, patient's resources, because that is going to be important as to what the patient is going to be able to afford, not afford, whether he will be able to continue follow-ups, and how is this depression affecting his social sphere, his or her relatives, friends, so on and so forth. Now, what is also important to understand is, as I mentioned, that the diagnoses that we currently make are based on the diagnostic criteria that are available to us in the form of DSM-5 or ICD-10, 11 is soon to come. All this give us a categorical diagnosis at a certain point in time, though DSM-5 and probably ICD-11 will also give us the means to look at and to include various other contributory factors to the depression, but none of these diagnostic criteria will look at the biology of depression in terms of what is actually happening in the brain, because unless and until we know exactly the etiology of what is going wrong in the brain in terms of its structure, microstructure, cellular structure, functions, connectivity, so on and so forth, even at a genetic level, epigenetic influences, unless and until we know these things, very accurately, the treatments that we are going to advise will be based on something like this, on the criteria, on the studies that are available to us, the meta-analysis that are derived from the studies, and so on and so forth. So it is going to be a work in progress. It is not going to be accurate. The only thing that is at the heart of this is how, as a psychiatrist, am I able to interact with my patient? How am I able to maintain and manage that patient in a therapeutic alliance, because it's going to be a long treatment. This is going to be the most important thing, which is going to allow me to have a proper assessment, look at the factors impacting, and maybe when down the line, maybe 2 decades, 3 decades down the line, when more refined tools, when genetic studies, when genetic tools are easily available to us, we'll probably be in a better position to give them a proper personalized, tailor-made, custom-made treatment individual for each patient. Generally, the treatment would go according to this chart. It is nothing great. It is actually what we do clinically on a daily basis on each and every patient, whether it is depression or something else. But since we are talking about antidepressants, this is what we follow, knowingly or unknowingly. I mean, of course, we take into account the possible therapeutic effects, adverse effects. That is, we try and roughly estimate whether what are the symptoms that a patient is presenting with, and what if I give an SSRI may happen to these symptoms. What if I give the patient a TCA? What is going to happen? Patients always ask us how much time they're going to take to get better, and so on and so forth. So we start an antidepressant. Well, if there is no effect, we switch to another one. No effect, third one, and so on and so forth. If it's an effective treatment, then 6 to 9 months at full treatment dose. Once the symptoms are sort of stabilized, they are in complete remission. This is generally the chart that we follow. So what are the basic principles that we look at when we are trying to prescribe any antidepressant for depression in a particular patient? We have to discuss the patient's choice of drug and utility, availability of other and non-pharmacological treatments, necessary but not always available. And sometimes it becomes very tricky when patients are more Google informed. They know everything about all the drugs that even as a psychiatrist sitting in a clinic and having years of experience, I might not know some of the very rare side effects that Google puts it up in the list, and the patient comes and says, I do not want to have this side effect. Discuss with the patient likely outcomes, that is gradual improvement of symptoms over several weeks. Patients will come with the idea that, oh, I've been suffering for the last 6 months, 8 months, 2 years, 5 years. Now I want to get better by tomorrow. And basically I should get better. I should start feeling better immediately after I write a prescription without even taking the first dose. To prescribe a dose of an antidepressant that is likely to be effective, so how am I going to adjust the doses? For a single episode, as I mentioned before, 6 to 9 months after resolution of symptoms is the least that can be done for a patient of depression having the first episode. Even in the first episode, if there are certain kinds of symptoms, we may need to probably increase the duration of the treatment. And of course, multiple episodes will require longer, and this has to be made very clear to them. It is not that we'll see next week and we'll see at next follow-up. This is it. This is the diagnosis of depression, and according to all the guidelines, anywhere in the world, this is what is going to happen. Without withdrawing antidepressants gradually, patients should always be informed of the risk and nature of discontinuation symptoms. Many a times they'll feel better, they'll stop the treatment suddenly, and then they'll come up with symptoms, probably symptoms which are more intense, more a different kind of symptoms, a lot of anxiety, a lot of somatic complaints which were not there before. And then they will tell us that the depression is worsened, where in fact they might be having the discontinuation syndromes. Well, this is for us as well as the patients. We need to be very, very clear that antidepressants are effective. There are a lot of people, a lot of physicians who are not psychiatrists, for whom antidepressants are sleeping pills. They will just put me to sleep, or they'll do something fancy, but not given the status of effective medication, effective psychopharmacotherapeutic agents. Studies after studies have stressed on the robust effects of antidepressants. For subsyndromal depression, we may not treat because we do not know what that subsyndromal depression is to start with. But if in the course of a depressive illness, let's say the remission has happened for an episode, and then there are subsyndromal depression, then we may really need to look at and see whether we need to treat them because they might signal a next episode that is coming. But otherwise, subsyndromal depressive symptoms to start with may not be treated. Dysthymia, that is symptom duration of at least 2 years, will benefit definitely. So for dysthymia, there is ample proof that antidepressants have to be given. Adverse effects associated with antidepressant treatment may weigh any small benefits seen. Can happen sometimes. Patients may be constitutionally, genetically sensitive to certain side effects, whatever drug may give. And all of us have patients like this, a few of them, where any medication you give, including a multivitamin, and they'll come up with some or the other adverse event, which is very difficult to explain just on the dose that may be given, the duration that has been, for which the treatment has been given, and so on and so forth. Onset of action is from studies, and we have been told this time and again that it takes around 3 to 4 weeks for some effect to be seen and 4 to 6 weeks for the effect to stabilize. But when we look at patients from the clinical in our clinics, and when we look at when there are RCTs done, they always focus on the improvement in scores on certain scales. So if only we look at mood symptoms or anxiety symptoms, these symptoms, the core symptoms, probably respond faster than what is this 3 to 4 weeks of what we commonly believe. The idea is that effect is usually seen by 2 weeks, but of course there are going to be different patterns of response. In some individuals, the response is slow to start, and in those who are ultimately showing some response, they will show some treatment, some improvement in 3 weeks. So 2 weeks for the effects to start, variable types of responses, but by 3 weeks definitely some improvement will come if the patient is going to be responsive to that medication. And even though they might be having a slower rise in the improvement from 2 weeks to 3 weeks, they will go on, many of them, to respond fully to treatment. So 3 weeks rather than 4 to 6 is the outer limit of response. So if we look here in that diagram that I have shown here, if the response is not seen after 2 weeks, then we may consider a change, not 3 to 4 weeks. By 3 weeks, it will become evident whether the patient is responding or not. So 2 weeks for the effects to start, 3 weeks, some effect will definitely be there if the patient is going to respond. The choice of antidepressant depends on many things. The most important thing is the side effect profile. And in this, generally, SSRIs have got a better side effect profile than SNRIs, which have got a better effect than TCS. The commonly used agents, if you look at it, will group like something like this. SSRIs, I mean, each category has their own specific side effects. And in some people, the side effects are going to be really problematic, no matter what. But if we look at groups and we look at the overall picture, then the TCAs will have the maximum side effects which are problematic compared to SNRIs and compared to SSRIs. The second thing is interactions. Pharmacokinetic interactions, mainly what we are aware of are the CYP450 pathways that are inhibited. And most of our drugs, fluoxamine, fluoxetine, paroxetine, are enzyme inhibitors. So we need to be careful if the patient is on multiple other drugs, especially when we look at elderly patients, patients who have got lifestyle non-communicable diseases where they have got plenty of other medications and ours is going to be added to that. So that is going to be problematic if we are using this drug. So we need to be careful, and this is the pharmacokinetic profile. Now, apart from CYP450, there would be other pathways which we are not fully aware of, which we may, which we'll need to look at when it comes to interactions. Pharmacodynamic interactions are basically gross effects at systems level. MAO inhibitors and tyramine, that is a cheese reaction. Tricyclic antidepressants, they are hypotensive because of the action on the noradrenergic system. So if an antihypertensive is given, then we need to see what happens. SSRI, SNRI, the serotonin, GI bleeding, so on and so forth. Third thing is suicidality. What do we do when we have patients who have suicidal risk? The risk is high. I mean, all agents are implicated. There is not a single antidepressant which is not associated with treatment emergent suicidality, which seems to be maximum at the starting of treatment and the stopping of treatment. Start when the effect starts, and that is where all these black box warnings will come. But there is no single drug which is free from this side effect or an effect. So it is better that we can tell, better we tell our patients that something like this you could expect. If it is too much, then we'll need to see what to do. And switching antidepressants may be a marker of increased risk of suicidal behaviors in those who initiate antidepressant treatment aged 75 years and over. So whenever there is going to be switching of antidepressants, effect not coming, I'm not feeling okay, one drug, second drug, third drug, this is the risk that there is going to be an increase in the suicidal behaviors in elderly patients. And of course, this is the list of anti-discontinuation syndromes. So all categories have got their peculiar discontinuation symptoms, which we need to tell people. The commonest ones are that we use in our patients are SSRIs, and in that paroxetine and venlafaxine, SSRIs and SNRI will have the maximum treatment stoppage related symptoms, flu-like symptoms, shock-like sensations, a lot of anxiety, irritability, that kind of thing. TCS also, of course, amitriptyline, imipramine, again, two common ones. And MAOIs. MAOIs have just come. We have got tranylcypromine just available. So we'll need to build up our experience on that in our country, and then see what is going to be available, what we can tell our patients on that. Features, when we treat patients, we'll need to have a stepped approach. So that is what we looked at initially, the guidelines, that mild depression do not touch, moderate severe start with medication, other forms of depression start with treatment. That is a stepped approach. You start with the simplest and then go to a single drug, then add and things like that. Options in the group, I mean, approximately 1/3 patients do not respond to the first antidepressant. If you take 100 patients, first episode of depression, 60%, 65 will respond, 35 will not respond. And then they will need to have either an initial dose escalation to the maximum in that dose range, or maybe slightly higher than that, depending on tolerability, switching to a different drug, and number of augmentation strategies. A small proportion of non-responders will respond with each treatment change. So let's say first 30% didn't respond here. This 30% we do something. Some little more will respond here, but not completely. And as we keep on going from steps to step, the effectiveness becomes less, the response becomes less. So when do we add? What to do? When there is no or partial response to first-line medication, we add a second compound to the antidepressant. This is called as combination therapy if the second compound is an antidepressant itself. So if the first line is an SSRI, let's say escitalopram, patient is not responding, then we add another second antidepressant. So let's say bupropion, for example, or let's say there's venlafaxine. Then it is called as combination because both the medications are antidepressants. Or we can go in for augmentation, where the second drug is not an antidepressant, but something else. Let's say lithium, let's say atypical antipsychotics like quetiapine, olanzapine, aripiprazole. That is called as augmentation. So the second drug is not an antidepressant, but it is going to increase the effect of the antidepressant in that particular individual. So we do not have a lot of evidence in large-scale randomized trials, but the evidence for the benefit of augmentation therapy is there for low-dose atypicals and for lithium. And there have been some studies of lithium with amitriptyline, which is good. So lithium augmentation and atypical antipsychotics are the augmenting agents for us clinically available right now. So this was the STAR-D trial. They started with escitalopram. So 28% responded to escitalopram. Okay. Uh, uh, just excuse me. Just excuse me for a minute. Just excuse me.
Malay sir is leaving now.
Now?
Good afternoon, Khan sir.
Yeah, do we have any questions? I don't think we have. No.
It's not finished.
No, even then. Yeah.
Okay.
Dr. Singh, how many patients do you, in depression patients, in how many patients would you use more than one antidepressant with your vast experience in clinical practice?
So more than one antidepressant or more than one molecule?
I mean, more than one, definitely more than one molecule.
So more than one molecule will be in almost 90% of the patients.
Right.
The only thing I want to discuss, since
Yeah, sorry.
Yes,
with
he's
all the
back.
guidelines,
Yeah.
he has come.
Yeah.
Yes. Dr. Dave, please continue.
Yeah. So there was a slight network
issue.
issue. Yeah. Just give me a moment. I'll just log in. Right. So as I was saying, this is the STAR-D trial where they started with escitalopram. So many patients, around 2,876, started on escitalopram. They had to switch over to another antidepressant because of a failed citalopram trial. And the second line, so this is the first line SSRIs. The second line was bupropion versus venlafaxine versus sertraline, and an augmentation that was with bupropion or buspirone. This is second line. So either there was a switch to another antidepressant or there was an addition of something which was not a typical first line antidepressant. And again, in that, some of the patients who failed to respond were given mirtazapine, nortriptyline as antidepressants. So this is third line, second line antidepressants, or augmented with lithium or T3. So this was another augmentation. And those who failed were given trinylcypromine, that is MAOI, or mirtazapine plus venlafaxine. So this was basically the design of that study trial. But what it showed us that at each and every point, there was a significant number of people who failed to respond to either the main drug, to a switch, or to augmentation, and they had to go for another molecule which was either a switch or again an augmentation. So, and at each of this point, the response here it is 28%, but here as we go down, the numbers start reducing. So the first effective molecule will give the best response. And after that, whatever strategies are there, do not probably give the same response, the same type of a response in those individuals who have not responded to the previous one.
So the first line augmentation or substitution would be with lithium, which is I mean, when I just accidentally, there was that issue with the network. I was just listening to the conversation that was going on. Dr. Sanyal was asking Dr. OP Singh, what about two antidepressants most of the time? And in fact, it would be there. This is the first line. And in that first line, the antidepressants, at least in STAR-D and NICE guidelines, would be an SSRI with bupropion, an SSRI or venlafaxine with myanserin and mirtazapine. So yes, we can give two antidepressants, preferably not the same class. Because what people believe is, what people have found out is that even for SSRIs, the only difference in the clinical effect seems to be side effect related more than the antidepressant effect. So if one is not giving a good response, then switching to another SSRI may not be the good thing to do. But again, there's a lot of difference of opinion where people say that it is okay that if I have started a patient on escitalopram and the patient has not responded to that, I can go on to sertraline, not a problem. But most guidelines will not be in favor of that. They would be in favor of switching the class of the drug to another category itself. So yes, antidepressants can be added to an already going SSRI. We can add aripiprazole, starting with very low doses from 2.5 milligrams to maximum 20. But the biggest problem with aripiprazole is the akathisia-like effect that comes initially, which makes many patients very, very uncomfortable. Lithium, as I mentioned, has got its own set. It's not only that the depression has to be bipolar type to be indicated for lithium use, but lithium is also a good augmenting agent and maybe a maintenance prophylactic agent for patients who have got a very let's say treatment resistant depression, who have got a lot of functional impairment, hospitalizations and things like that, and of course suicidality. The importance is 0.4 to 0.8 is the serum level which needs to be maintained when we are using lithium here. Olanzapine, fluoxetine and quetiapine. I mean, olanzapine, fluoxetine was the study, the combination was used for depression, which was mostly bipolar in nature, but depression nonetheless, and quetiapine. So these actually are the common things that we are doing, but we need to understand that the idea is that we need to be better informed as to what level of treatment, what is the step of the treatment that is happening, and where do we need to, I mean, what will be our path of negotiation through the various categories of medication. The second line after this first line means the first substitution or augmentation. The second line of augmentation or substitution is not going to give, as I mentioned previously, that the same kind of effect that the first line of substitution or augmentation is given. And here people have studied medications like ketamine and esketamine. Yes, good molecules, but for ketamine the problems are short lasting effect. We do not know for how long to give, and there's always a problem of dependence, bladder toxicity, two main things. So ketamine and esketamine, we need an anesthetist. Most of us are not confident enough to give it by ourselves. It's better to always have an anesthetist at hand. We can add lamotrigine, which is a good option, again, not only for bipolar depression, but for also unipolar depression. But again, the rash. SSRI plus buspirone, yes, good effect. High dose venlafaxine, more than 200 milligrams we can give. So actually venlafaxine is at two levels. One is it as a first level along with an SSRI. Second with by itself in higher doses, but they have their own side effects. So lamotrigine has the rash. Buspirone doesn't have a rash on it. It's a pretty well tolerated molecule. High dose venlafaxine, there's always this risk of emergent treatment, emergent hypertension, which we need to be very careful about. ECTs, in fact, in our setting, at least in my setting, I would give an ECT much earlier. I will not wait till it comes to this level. If the symptoms warrant enough caution in treatment, in the sense patient is not eating well, not looking after oneself, a lot of suicidal ideas, poor response, before going to a second or even on a second line, I might add SCTs to the trial. T3, T4, add triiodothyronine, T3, add risperidone. Risperidone adding to an antidepressant has got a lot of side effects, a lot of akathisia-like effects, hyperprolactinemia, and it is not generally well recommended in terms of evidence base. And then people have tried a lot of other things, amantadine, buprenorphine. These are all individual studies, not for on large populations, not on large patient populations, not necessarily replicable. So we have got pro-dopaminergic agents like amantadine, cabergoline. We have buprenorphine, D-cycloserine both for anxiety, and also for it's a glutamatergic agent. So even in the previous presentation, it was mentioned as one of the treatments for resistant schizophrenia. Mecamilamine, pindolol, tianeptine. Tianeptine is again a molecule which I, in my practice, use a lot. Very few side effects. It's a very mild kind of a drug. It's not very effective, but it does work in some patients. There is no specific what kind of patient profile is going to respond to the molecule. Tryptophan and zinc, all small studies. Ziprasidone, MAO inhibitors, and TCA. This was actually a very old combination that was used, but we did not. I have no experience with MAO inhibitors. Most of us do not have, unless we are very senior. Dexamethasone, small study, very limited data. Hyoscine, ketoconazole, modafinil, so on and so forth. Estrogens, pramipexole. Pramipexole can be used basically for restless leg syndromes, but it does have a pro-dopaminergic effect, does work in some patients. So a lot of things which are very small studies, very few patients, very less data, difficult for us to prescribe with confidence. But if we know our patients well, if we know the side effect profile, if we are comfortable using particular molecules, we may try. So as was mentioned in the previous, at the end of the previous presentation, that lack of evidence doesn't mean that there is no evidence. Maybe more studies will need to be designed. We need to use the drugs more to build up our confidence. So ketamine we have talked about. Another category of drugs which is really useful when and which we need to consider is the category of stimulants. That would mean modafinil, armodafinil, methylphenidate. These three mainly. We do not have dextroamphetamine available to us. So these three molecules which we have can be good as augmenting agents for many of our patients. So stimulants, they reduce fatigue, promote wakefulness, and are mood elevating. Can be used for refractory depression, can be used in monotherapy, but we need to avoid it in uncomplicated depression because they'll only make the person more alert without having much of a change in the cognitive processes. And it can be, it can lead to anxiety in many patients. So they feel very restless, they feel alert, but they feel very restless. Adjunctive, we can use modafinil or armodafinil. In studies where people have used stimulants, that is both modafinil and methylphenidate, for bipolar depression, because in bipolar depression, the symptoms are more of tiredness, fatigue, lack of interest. Symptoms like this have responded well in studies with no emergent mania. So we can use these without really worrying about manic episodes coming up. But yes, patients can become very uncomfortable with the initial anxiety that is seen in many patients. In depressions in other settings like late stage and terminal cancers, they have been used, that can be used as monotherapy or as an to SSRIs depression in the elderly, post-stroke depression, depression secondary to medical illness, depression and fatigue due to HIV. The dosings is regular, whatever we are using in terms of, let's say, modafinil 100 to 2 milligrams, 200 milligrams per day, or armodafinil, which is half the dose, about half the dose. Methylphenidate up to about 40 milligrams, gradually up titrated. So this dosing remains the same. When we are talking of augmentation or adding another antidepressant, we need to understand that the dosing is going to be as much as we are going to use if it was a single agent. So the dosing remains the same. The only thing is we need to be careful about side effects or additional effects that can come, synergistic effects. So the up titration is going to be a little bit slow. but more or less it is going to follow the same pattern as if it was a single molecule that was being used. ECT, as I mentioned, poor oral intake, poor self-care, psychotic depression, is the first line. Because where previous treatments have failed, it is more effective than an antidepressant given along. It has got rapid effects. But again, there are few studies which say we can give a maintenance ECT treatment which will keep the effect going on. But a combination of pharmacotherapy and psychological treatments is necessary. Only ECTs may not work in the long-term maintenance. So other treatments that can complement or that can help to build up a good response to antidepressants is deep brain stimulation, vagal nerve stimulation, and TMS. Again, we do not have guidelines for their use. There are some people who use DBS, not necessarily for depression, but TMS, yes. So we do not have actually guidelines for long-term use of TMS. Bright light treatment, especially in winter months. Therapies. For acute depression, which is mild, yes, CBT can be used. It has got strong evidence. When it also comes to relapse prevention, CBT plus an antidepressant is better in relapse prevention than maybe any of those modalities alone. Whether CBT is effective for patients with severe depression is not very well studied. Another therapy is interpersonal therapy. So combining interpersonal therapy with medication also reduces relapse rates. But other forms of therapy like short-term dynamic therapy, not very clear. Exercise in mild to moderate depression. So when it comes to therapies, the best studies, the best that we have to offer is CBT at all points and probably in all severities of depression, if we are able to give that. For psychotic depression, antidepressants with an antipsychotic cover is definitely going to be used, olanzapine, quetiapine. In this type of depression, TCAs are more effective than SSRIs, whereas SSRIs and SNRIs, unlike first line, here are second line, where TCAs are not very well tolerated. How long we are going to treat this with a combination, we do not know. But once the patient is better, once the psychotic symptoms are controlled, then the first drug that we can reduce and consider stopping is an antipsychotic. ECT is to be considered in such patients. In pregnancy, continuation of an SSRI during pregnancy is not a problem. For most patients, we have to use, we can use all SSRIs, but be very cautious with using paroxetine because there have been some reports of its association with cardiac anomalies in the fetus. The risks of an untreated depression in pregnancy is much more than what is associated with the medication. So we have to stress this fact upon our patients that the treatment might need to be continued if the depression is moderate to severe. Mild to moderate, if it is done well, we can consider tapering down and stopping the medication. The risk of SSRI treatment in pregnancy are low. There can be a self-limiting neonatal withdrawal syndrome. A very small risk in a small increase in absolute numbers of pulmonary hypertension of the newborn. Paroxetine I mentioned, cardiac effects. And some studies have mentioned the increased risk of autism in offspring, but again, the association is absolutely unclear. But if people ask, definitely no. In breastfeeding, during breastfeeding, a variable amount of the molecule will come or get excreted into the breast milk. So breastfeeding can be continued, of course, keeping a watch on the fetus or on the infant for sedation and feeding difficulties. That's about it. So even for lactating mothers, SSRI is a good option that can be continued. In childhood and adolescent depressions, CBT is a first line approach, CBT and IPT. Medication responses are not very robust in this group of patients as compared to the adults. And all these treatment emergent suicidal effects, other side effects are common in this age group. So the best evidence is a concurrent use of antidepressants, mainly fluoxetine, because in all studies, in all recommendations, fluoxetine is supposed to be associated with lesser treatment emergent suicidal ideation compared to other SSRIs along with CBT. Depression in the elderly, is complicated by a lot of these things: physical comorbidity, general frailty, increased risk of suicide, and this makes no molecule an ideal antidepressant. All of them will have their side effects, drug interactions, and some of them may contribute to the worsening of cognition. So the general rule is start low and go slow. But again, we need to remember is that whatever molecule we are using, it is going to be on the same principles that we talked about before. Mild depression, maybe nothing needed. Moderate depression onwards, or dysthymia like picture, or a psychotic depression, whatever molecules we have used before, we have talked about before, are the same that are probably going to be used. The only difference is we'll need to be very slow in starting, smaller doses. The increase or the titration, up titration of the dose is going to be slower than the general adult population, and we need to be prepared for a lot of side effects. We all know them, so it's just listed here. All of them have side effects. So at the end of it, well, what is important for us to customize treatment or give a proper or look for or target a proper optimal effect of our medication is a diagnosis of the primary condition as well as the comorbidities. We need to look at the individual preferences and the medication profile in terms of effects and side effects. We need to be able to communicate properly what is the nature of the illness, what is the treatment duration going to be, and we need to be able to keep them in a therapeutic alliance for the entire course of treatment. Thank you so much.
Thank you, Dr. Dafi, for an excellent pragmatic presentation. Do we have any questions from the audience, the participants? I don't think there is, because we are running behind the schedule. Does Dr. Singh has anything to comment?
No, it was really comprehensive. He has touched every area. Only thing I just want to ask, that all guidelines say SSRI should be first, but in practice, sometimes we need to start with SNRIs. So is there any guideline or any way to determine which patients are going to respond first?
We need to only be able to understand what are the symptoms of the patients. If usually the commonest group of drugs that we are going to use is an SSRI almost by default now. If it was, let's say, 20 years before, an SSRIs were just coming into the market, it was the tricyclics. But there are so many studies and so many guidelines over the years that the fallback automatically with eyes closed in the middle of the night, if someone wakes me up, is going to be an SSRI. But if there are symptoms, let's say a lot of somatic complaints which are there, then a little bit of a noradrenergic activity probably works better. And that is where there is a lot of somatic complaints, a lot of anxiety. That is probably where I'll think of an SNRI better than, or as a first line, slightly on a higher platform than an SSRI. I mean, and if there is, of course, somebody has tried an SSRI before and the patient has not responded or has had side effects, and then I'm not looking and I'm not sure whether I want to expose the patient to the same group of drugs, then maybe an SNRI.
Yeah, possibly the most important clinical denominator to dictate the response to antidepressants has been the presence of comorbid anxiety, the intensity of the anxiety, and with this comes the construct of anhedonia. And maybe with, this is something which we have to probably look into. The radiological role of amygdala,
yes,
in treatment-resistant depression and in depression resistant to treatment. Concerning Dr. Singh's query, yes, maybe we can probably, if there's a family history of SNRI, which is a good response to SNRI, or a history of a repeated failed response, poor response to SSRIs and non-SNRIs, maybe SNRI could be the first choice.
And,
if there's no other
one
question,
more,
I would like to terminate this session.
Dr. Devashish Rai, Dr. Dhabe,
One
Yes,
more
sir.
indication, what you have added, one more indication, I like to add SNRI than SSRI if there is a suicidal ideation. In those cases, I like to start with antidepressant like venlafaxine first. I don't know, is there any evidence-based study?
Yeah, why would you do that?
Because I think sometimes when we stuck to SSRI, the second choice will be SNRI. Definitely, and in most of the cases, it acts very well. So I don't want to take any chance when don't want to wait. The response will be better as a non-adrenaline system also involved. That is what I am using. If the patient has a suicidal ideation, I start with SNRI most of the cases. Venlafaxine, what I want to make.
Okay.
There
Thank
is
you,
an
Dr.
added
Saha,
risk
for
over here is the
mentioning very
increased
pertinent
lethality of
clinical
venlafaxine.
points.
Sorry. Yeah.
Thank you.
Well, I would like to thank our chairpersons, Dr. Debashish Ray and Dr. O.P. Singh, sir, for chairing this session. It was a pleasure to have you all here. And of course, Dr. Malay, always a pleasure to hear you. We now move to our next session. Our chairpersons for the next session is our Dr. Deepak Gupta and Dr. Manjari Deshpande. Dr. Deepak Gupta is a child and adolescent psychiatrist associated with the Sir Gangaram Hospital, New Delhi, and he holds the privilege of being one of the few qualified child and adolescent psychiatrists in India. Founder of the Center for Child and Adolescent Wellbeing in New Delhi. He's an honorary member of the advisory panel of Akhil Autism Foundation, New Jersey, USA. As for Dr. Manjari Deshpande, she has done her fellowship in child psychiatry with over 10 years of clinical experience in child and adolescent psychiatry. Passionately interested in it, and she's the head of ICGC, that is In-Laws Child Guidance Clinic, which is one of the one-stop, all-inclusive, comprehensive centers designed to meet all kinds of academic, emotional adjustments and behavioral problems of children and adolescents. And her main interests are counseling of children for conditions like anxiety, OCD, depression, teenage problems. So I hand over now to Manjari and Dr. Deepak.
Yeah, good evening, everyone. First of all, thank you very much to the Indian Association of Biological Psychiatry for inviting me for the chairing this session. I've been asked to introduce the speakers. We have Dr. Mansi Somaiya and Dr. Alka Subramaniam, and they'll be talking on this fascinating topic on newer advances in the treatment of autism spectrum disorders. It's a very challenging area, very difficult area to work with, autism spectrum disorders. And psychiatrists and child psychiatrists struggle with it to get the right answer. What they say, to fix the puzzle, to get the right puzzle solved in a right way. And Dr. Mansi Somaiya, let me introduce her. She's an assistant professor in psychiatry, TNMC, and BYL Nair Hospital, Mumbai. And she has also been awarded with the Young Psychiatrist Fellowship Award, Japanese Society of Psychiatry and Neurology in Kobe in Japan, 2018. We also have Dr. Alka Subramaniam along with her, again from same college. She's an associate professor, Department of Psychiatry, TNMC, and BYL Nair Hospital, and she's still serving there. And after a basic training, she was awarded the Har Gobind Fellowship and trained in State University of New York. This training led her pioneer to the establishment of the Learning Disability Center, Autism Diagnostic Center, and the Vivekanand Remedial Center at the Twin Institutes beside the Psychogeriatric Clinic. So we welcome both of them, Dr. Mansi and Dr. Alka. And I know I can see they have a big presentation, and I'm sure that we will learn from this presentation. And as I presume we have 30 minutes for this presentation, so I'll request the speakers to make sure that they restrict themselves to around 25 minutes so that we can have a few minutes for the discussion. Thank you very much.
I hope I'm audible.
Yes, please. Carry on, please.
So thank you very much. At the outset, I would like to thank Dr. Gupta for such a wonderful introduction of the topic and introducing us as speakers. Also, thank you very much to Alka ma'am, who has given me this opportunity to share this presentation along with her, and the organizers of IABP for this opportunity to be able to share insights of a topic which has intrigued multiple researchers across so many years, so many decades, where we are on the look of finding that one molecule or that one treatment modality. But unfortunately, the brain is so complex, and there are various neurochemical changes, transmitters implicated in the emergence of this disorder. So let's try and look at the presentation. The scope of my presentation cannot only be limited to newer advances, because without having a complete know-how of what has actually been researched, it will be very, very difficult for us to grasp the newer advances and the newer modalities. So just a short introduction to the topic, with the various symptoms and manifestations of the disorders along with comorbidities, what we truly know about the treatment modalities that have existed and have stood the test of time, what future holds for us, and a take-home message. So we're aware that autism spectrum disorder is a neurodevelopmental disorder where it presents with varying severities and involvement of supports in such individuals, characterized by a deficit in social interaction, a language delay, communication difficulty, difficulty understanding emotions, expression of emotions. They could be the domain of restricted repetitive behavior, which could manifest in the form of lower order and higher order in the form of insistence on sameness, sensory issues, impaired attention, executive dysfunction are the higher cognitive functions which are involved. Now, in autism spectrum disorder, almost in all the cases in individuals, comorbidity is a norm. Now, one is the neurobiological, the etiopathogenic process that goes on between a comorbid disorder and the primary disorder or autism spectrum disorder. But the second aspect is that ASD by itself can offer certain issues which can make an individual more vulnerable to secondary emotional disorders and etc. So where we stand from the treatment perspective, researchers have looked at how we can best address the core deficits, right from social interaction to communication and language communication, behavioral issues, where most research has actually looked at non-pharmacological approaches, behavioral modalities, which have been used and stood the test of time. There have been pharmacological molecules which have been used to treat certain behavioral issues, such as stereotype behaviors, self-injurious behaviors, restrictive, repetitive behaviors, which have some success, which don't have success. When it comes to comorbidity, yes, there have been a combination of pharmacological and non-pharmacological approaches, which we will try and understand as the presentation goes by. So to start with, a case vignette where Miss A was, I think my screen is, yeah, Miss A is a 5-year-old who is brought to the clinic by her parents, who's already diagnosed with autism. Both parents are well read, informed, they're well aware of the different developments, and they come to you because therapies have failed and the child has terrible meltdowns, aggressive behavior, speech is regressed, and no school is willing to take her. What do you do? Now, of course, we know it's a case where a child with autism presents to you with irritability. Now, irritability has its roots in emotional dysregulation, which is a dysfunction evidence in the form of certain neurobiological processes that will lead to either vocal or motoric outbursts and expressive of anger, frustration, distress, and then they will show up as temper tantrums, rages, meltdowns, or certain problem behaviors, which could be directed acts of aggression with potential to harm self, the other, or property. And, a good clinician must keep in mind any comorbid mood or anxiety disorder while we are evaluating a case of irritability. Now, we're aware that the cortex, the prefrontal cortex and the anterior cingulate cortex is predominantly the neural substrate for top-down inhibition, right? So they are more inhibitory, and the amygdala and the insula are, responsible for the emotional processing, and they are associated with the bottom-up drive. Now, what happens in individuals with ASD, the reduced emotional awareness is because of the dysfunctional limbic system involving the anterior insula and the amygdala. What has also been seen in individuals with ASD, it is the dysfunction that occurs in the mesocorticolimbic pathway and the alteration in these dopaminergic pathways, which can manifest either as social deficits or as repetitive behavior. So, for example, the dopamine transporter polymorphism is responsible for repetitive behaviors. That happens because there is a suppression of dopamine transporter expression in substantia nigra and results with increased dopamine neurotransmission in the striatum. Blocking of this dopamine transmission results in behavioral improvement. So, Campbell was the one who started research with antipsychotics for irritability in children with autism spectrum disorder. Although her start was with haloperidol and then she began to use various antipsychotics, it's not in the purview of and scope of the presentation to be able to share all the data on antipsychotics, but choosing the very significant risperidone, which has been used in various randomized controlled trials and has shown superior effects on irritability, on the ABC, which is the aberrant behavior checklist, and the CGI, which are the clinical global impression improvement scale, where irritability increased significantly as compared to placebo. But it also came with certain metabolic effects. And because risperidone stood the test of time, it was approved by the US FDA. Now, following risperidone, aripiprazole was also used because they were looking for a certain molecule where there could be less metabolic changes. So, aripiprazole in the treatment of irritability was used. These are the two landmark RCTs which proved aripiprazole's efficacy in treating irritability, and that is why aripiprazole was approved by the US FDA in the treatment of children with autism spectrum disorder. So, like I just mentioned, what was new after all? Of course, we know this is, the decade before the previous, the decade before the current decade, the previous decade where risperidone was used and various other antipsychotics were tried, and subsequent trials on aripiprazole, longer trials, and what they found was that even aripiprazole was associated with metabolic changes. So aripiprazole also comes with some of its side effects, especially the metabolic changes. So in a nutshell, these are the two antipsychotics which have been used. Now, researchers have expanded their research by using molecules which target inflammation, immune dysfunction, uh, mitochondrial dysfunction, and modulators such as N-acetylcysteine, which have properties such as antioxidant and anti-inflammatory activity, have been tried in individuals with ASD. What they have found, and these studies are done in this decade, which is kind of new, we can say, when compared to the placebo, the NAC has been well tolerated, and there has been a significant improvement on the irritability subscale. However, there have been studies where there have been no significant differences well in the Wink et al. Study. So we do need larger clinical trials to assess the response and the clinical utility of this molecule. Now, another molecule which is on its way, which is under research, brexpiprazole, which is being used for schizophrenia, for depressive disorder, but the efficacy and safety in ASD is not yet determined. There is a phase 3 multicentric randomized double-blinded control trial along with a placebo, which is being carried out, and hopefully it should offer some kind of scope in the treatment of irritability in such individuals. Another aspect that researchers have tapped is the imbalance that occurs in between the excitatory and the inhibitory neurocircuitry in the brains of children with ASD. Now, what has been observed is that there occurs an alteration in the GABA synthesis enzymes, the GAD6567, and a reduced GABAergic gene expression, and hence they have used modulators such as the GABA B agonist, which functions to dampen the hyperexcitability in such individuals. Well, the research has, in an open label study, it has shown some hope, but in the RCTs that have been performed in the last few years, there has been no change in irritability. So we need more longer duration and well-designed studies to be able to tap this aspect, this molecule. Minocycline was, which is, we know, an antibiotic, was also tried in an open label study, but and another placebo-controlled study, owing to its anti-inflammatory properties. But again, these molecules are just still under research and have not proved the test of time in the treatment of irritability in such individuals. Another very common comorbid condition along with ASD, which one can say one has, the studies which have looked at both individuals with ASD and ADHD have found commonalities, similarities in the involvement of brain areas in both these individuals and certain neurocognitive functions. And hence this vulnerability where children with ASD, individuals with ASD, very commonly present with ADHD. So the molecule most commonly used, which is methylphenidate, has also been tried, and in a recent review where carried out in this decade, where they have found the efficacy of methylphenidate, which favors decrease in symptoms of ADHD in this population. But it comes with certain adverse events, especially in population with ASD and ADHD. They present more with decreased appetite, greater insomnia, more depressive symptoms, and greater irritability levels. And atomoxetine, which is another molecule that we use, has also shown its efficacy by in the two trials where the hyperactivity has significantly reduced in such individuals. Clonidine has also been tested, although these are molecules which have been used for a very long time. Now, using the theory of the opioids, a very old theory as expressed by Panskep, where social behaviors are proposed to the level of endogenous opioid peptides which occur in the brain. And what they have found in individuals with autism spectrum disorder is that the levels of beta endorphins were very, very high. There were alterations in the levels of beta endorphins. And they also observed that this correlated with the social deficit. They were more refractory to pain. And because they were more refractory to pain, they were more likely to self-stimulate, and hence the self-stimulatory behaviors, hyperactivity. So, typically in ASD, there is the flooding of the immature brain with beta endorphins, and that delays the maturational manufacturing of enkephalins, and hence the autistic brain continues to remain in that infantile stage, which prevents responsiveness to the sensory and social environment. And hence there has been a growing interest in finding out whether naltrexone, opioid antagonists, can really work for behavioral symptoms in children with autism spectrum disorder, right? And what they have seen is some of the studies had seen that there has been an improvement in hyperactivity and irritability. There have also been, recent review in 2020 where they have collated various studies and seen that it also helps in the self-injurious behaviors and the restrictive repetitive behaviors in such individuals. However, it has failed to detect any improvement in the core autistic features. Now, another aspect, another comorbidity along with ASD is obsessive compulsive disorder, and it is very, very essential for a physician, for a clinician, to differentiate between obsessions and compulsions, versus restricted repetitive behaviors in autism spectrum disorder. It becomes very difficult and challenging, especially when the child is nonverbal or there is intellectual disability, and that's where the role of a functional behavioral analysis is plays it plays a very big role here, because that helps us to understand the purpose of this a certain behavior, because obsessions and compulsions can actually cause more distress. They are more disturbing to the child. They're more ego dystonic in that sense, but restricted repetitive behaviors actually function to probably attract attention or grab that tangible object or escape a certain behavior, or so in that sense they are actually meant to reduce anxiety. They decrease arousal states. It's more to do with increasing the pleasure, so they are ego syntonic, and hence it becomes very, very difficult, very, very important for the clinician to identify this so that appropriate treatment interventions can be offered to the child. Now, when it comes to OCD, CBT we know has been used, right? CBT has shown mixed results, especially when the child has, is low functioning, has a cognitive disability. But what is new is certain modifications that they have used in CBT. So there is more attention that the therapist would pay to affective education, making the child be enabling them to identify certain cues of anxiety, like they are feeling uncomfortable, there is a shallow rapid breathing, instead of just calling it anxiety, identifying certain environmental triggers that could trigger anxiety in them by identifying what makes them feel a certain way. So this would also involve a lot of emotional understanding, and at the same time progress further to hierarchy generation. And even when they are generating hierarchy, like the classical subjective unit of distress that we have in OCD, instead of calling it that, a feelings thermometer, so different terms, so that simple language is being used which is understood by the child or the individual, so as to make it simpler for the child to understand and address the anxiety. There's more parent participation, handouts can be given, problem solving techniques which are used, and there are more in vivo exposure activities, so taking them probably to a social situation where there could be an interaction with a peer, very concrete exercises, instead of involving or trying to change the cognitive schema by thought challenging and Socratic questioning, which children or individuals with ASD may not be able to carry out. So these are a certain modifications like usage of visual schedules, simple language which is used by the patient, and ERP and CBT can also be combined and used. So in that sense, the adaptation in CBT is what one can say is an advance. The role of SSRIs and tricyclic antidepressants. Now, the efficacy in these patients is mixed. So, SSRIs and TCAs have been tried, like, for example, fluoxetine with low dose has resulted in a decrease in repeated behaviors. But when it came to high dose and a larger study, there was no significant difference using a placebo on the CY-BOX scale. Citalopram did not show any difference in a CY-BOX scale in one of the studies. Fluoxamine, another very, very important aspect is the behavioral activation, the side effects that come with SSRIs, which these individuals are very prone to, and the clinician must take cognizance of these side effects. And clomipramine also has shown in one of the studies to decrease obsessive compulsive symptoms. When it comes to antipsychotics, the research of antipsychotics on OCD in individuals with ASD has not per se been in individuals with OCD, but have been used for irritability, and as a result, they have shown a decrease in obsessive compulsive symptoms. Hence, the role of antipsychotics is still not very clear when it comes to OCD and anxiety. When it comes to the treatment of restricted repetitive behavior in individuals with autism spectrum disorder, and they took like the plethora of molecules, right from the SSRIs to oxytocin to fluoxamine, buspirone, what they found was SSRIs and placebo in the treatment of the RRBs or the restricted repetitive behavior, there were no significant differences. Another molecule that we discussed, which was naltrexone, is one of the advanced one can say, which has been used in the treatment of RRBs with some success. Now, anxiety and depression in autism spectrum disorder, we cannot forget the symptom overlap, because autism spectrum disorder and individuals who have to fight their anxiety, which comes as a result of discomfort in certain social situations, they are aversive to certain sensory stimuli, very insistent on sameness, upset with a routine. So that manifests as anxiety. Now, SSRIs, SNRIs have been used in the youth with ASD. The effectiveness is limited, and there are very few well-designed randomized controlled trials which have been conducted in this population. Adverse effects such as increase in aggression, irritability, insomnia, disinhibition is more common in this population than the ones who are, with typically developing individuals with anxiety. Now, just like that in OCD, there are adaptations for anxiety disorders, even in ASD, where non-pharmacological approaches, where parental involvement is more, visual aids, and they will also see certain fixed specific interests of the child, which can serve as reinforcers. So there are a lot of behavioral approaches in the form of token economy, social skills training, which are incorporated in the therapy for such patients. So systematic exposure to anxiety provoking stimuli without escape, or that ritualistic engagement, is the most critical component of CBT for anxiety. So when there is exposure, it promotes habituation to say that anxiety, by teaching the child that without having to escape from that situation, the anxiety will decrease. But again, a lot of in vivo practice is being used, and even the models of the non-pharmacological models which have been used in the treatment of anxiety, in improving social interaction and communication, use these techniques. Again, adapted CBT has shown some positive treatment response when it comes to comparing it with placebo. Novel treatments in the form of internet-based CBT has also been used. So this is a program which is called the Camp Pope a lot, where computer-based CBT program, nothing different from the individual CBT, but using it by means of computer sessions, have been used by the researchers. However, they could not see any difference in efficacy between individually doing it and doing it using the computer. Biofeedback has also been tried in such individuals, where a child or the individual is taught how to monitor, measure, and it gives feedback. So in that sense, there's more awareness of one's physiological functions and establishes more control over anxiety. Now, researchers have tapped melatonin, using its property to modulate and regulate the circadian rhythms, because they have identified disturbance of melatonin, especially in children with autism, where circadian rhythm disorder, synaptic dysfunction, or immune dysregulation has been observed. Tapping this aspect, they have used melatonin for sleep disorders in such individuals, anxiety which can present with sleep symptoms, abnormalities in melatonin secretion and circadian rhythm abnormalities in children with ASD has been observed, and hence they have used melatonin and seen that there is a decrease in sleep latency and increase in sleep duration in such individuals. So melatonin used with CBT can, has shown superior efficacy in reducing symptoms of insomnia. In case of depression, there are no major controlled trials in depression in terms of SSRIs, and hence a Cochrane review in this decade mentioned that one has to use it case-to-case basis. Tricyclics have been tried, but the evidence is still limited and conflicting. And hence, it's very, very essential. I think, in the previous presentation, Dr. Malai Dave sir also has very clearly elucidated how in children and adolescents, they are more prone to behavioral activation when we use SSRIs. So when it comes to another vulnerability in form of ASD, that makes them even more prone. RTMS has also been tried in one of the open label trials in the recent years, where they have seen a decrease in depressive symptoms where 40% had remission. But again, it's an open label trial. We still need more research to validate and bring it to clinical utility. Now, oxytocin and vasopressin, the yin and yang neuropeptides produced from the hypothalamus, have also been tried in children with or in individuals with autism spectrum disorder. Now we know that oxytocin plays a very quintessential role in establishing the social and the emotional self, because it has a role in interpersonal bonding, establishing trust, and the release of oxytocin is very sensitive to certain emotional and social contexts. So, what has been observed in individuals with ASD is alterations in plasma oxytocin levels and genetic variants of the gene that produces the oxytocin. There are alterations in the same. So what researchers have done is, with the use of oxytocin, they have seen through fMRI studies that there is activation of those brain areas on social perception, amygdala, which have, implications in social emotional processing. It has also been seen to reduce repetitive behaviors in some studies, but we don't know about the long-term side effects. So it's shown some promise, but we need larger studies to find very clear-cut benefits. Another molecule, which is the MC4R agonist, which stimulates the release of endogenous oxytocin, and when combined with behavior therapy has also shown, but again, there's more research that is required. Another molecule, vasopressin, again implicated in social cognition and behavior. What they have found in individuals with ASD is that when there is a variation of the vasopressin receptor, that's very commonly that's associated with ASD, and antagonists to this receptor have been like a novel target for treatment of social deficits. Balovaptan, which is a V1 receptor antagonist, which the US FDA has termed the breakthrough therapy designation, which we will come to know only which will unfold only over a few years, could show some proof in improvement in social communications. So there was a small trial where they did see improvement, but now there's a currently underway. There is a trial on phase 3 compared to a placebo to see if it is actually effective. Psychosis and ASD, with its shared vulnerability, which is being seen in the symptom manifestation, in the neuroanatomic and the etiopathogenesis. We know that psychosis is very common. Psychosis is a comorbid disorder with ASD, where antipsychotics have been tried, but the evidence is still lacking. There are very few RCTs. What they have actually observed is a reduction in the disruptive behavior, the aggression and hyperactivity. Again, they have more so used risperidone and aripiprazole, where positive and disorganized symptoms have reduced in 2 of the studies seen. But again, we have to be watchful of metabolic effects. So one of the few challenges in managing these cases would be that they are more prone to adverse effects. There are less evidence as yet in this population, multiple symptoms to target in terms of intervention, and again, the diagnosis by itself is very challenging. Some more hope, immune dysfunction, inflammation, mitochondrial dysfunction has been implicated in autism. And that's why they have tried polyunsaturated fatty acids because of immune dysfunction, IVIG, cannabinoid oil, probiotics, but there is no convincing evidence that they have found. The take home message now, in terms of the core deficits of ASD, we stand where we are, non pharmacological interventions for core deficits. The known modalities when it comes to the comorbid conditions, irritability, risperidone, aripiprazole continue. Some treatment advances, brexpiprazole should offer some hope. NAC, arbaclofen need more studies. Hyperactivity, naltrexone, in that sense has been tried, but again we need more studies. Adaptations of CBT in case of OCD has is one of the is a non-pharmacological approach which still continues to be used, which is one recent advance which still continues to be used. Repetitive behaviors, it is still we still continue with the non-pharmacological approaches. Again, the role of SSRIs is still a query. Naltrexone has also seen an improvement in repetitive behaviors. Again, in anxiety, along with sleep, melatonin can offer some hope, which many clinicians have also started using. Adaptations of CBT, as we discussed, and internet-based CBT, but again, this is still tried in the West, not there still with us at this point in time. Depression, psychosis, we still continue to use the same molecules. Oxytocin, vasopressin antagonists seem to offer some promise, but we still need further evidence. Thank you.
Thank you, Dr. Mansi. I know it was a very exhaustive topic. It was a very big topic, exhaustive topic, but to cover up in half an hour is always a big challenge. It's a big challenge. Before I ask my other co-chairperson, Dr. Manjri, to talk and give her, because we are short of time, I think you have covered everything in a nutshell. Along with velofeptin, I think suramin is also one of the molecule which works on the purinergic system, anti-purinergic, which is also in the research. And one molecule which I found lot, and even some evidence is there, especially children who have this autonomic dysnomia, dysautonomia, propranolol is something very quite promising, which has some of the recent papers have come about using of propranolol, and I have also good evidence in my own practice. And one more thing, using of technology. Technology in the advances, new advances in the treatment of autism is using of technology and app. So some people have used even biometrics for the care of these children. And along with biometrics, some people have even used apps. Like one of the famous app is by the Apple group is Prolocue 4, which has been also used for working on the speech and language and communication, especially the communication. So, and one is LAMP, which is learning acquired through motor planning. So these apps and technology is something which has been used in autism spectrum disorder. So with this, I'll say thank you very much. Congratulations to you and Dr. Alka for this exhaustive presentation. I'll ask Dr. Manjri to give some few comments and then wind it up. Thank you very much.
Thank you, Dr. Deepak. Thank you, Dr. Mansi and Dr. Alka ma'am for a wonderful presentation. I think Dr. Mansi, you very nicely ran us through all the possible drugs that are being used in autism. But like you said, towards the end, I think it's more of therapies, and that's what most parents are willing for. And I think in our practice also, the number of medicines that we use for autism, unfortunately, is still very limited. And the mainstay remains, remains therapies. But yes, when therapies are getting impeded because of behavioral problems of children, we do resort to medication. But very nice presentation, Dr. Mansi. Thank you so much. Thank you to my co-chair, and thank you, Dr. Avinash, for having me as a chairperson. Thank you.
Yeah, thank you, everyone. Thank you very much.
Yeah, well, I thank Dr. Deepak and Dr. Manjri for chairing the session, and of course, Mansi for an excellent presentation. We now move to our next session, and I would like to invite our chairperson who's present here, Dr. Gautam Saha, to please come on the dais. Dr. Saha is the current president of the Indian Psychiatric Society, and he's attending here as his first event post becoming the president. He's a director of the Clinic Brain Neuropsychiatric Institute and Research Center, Kolkata. And he's actively involved, of course, in a large number of medical and non-medical activities. He's also a founder member of the Indian Association of Biological Psychiatry. I would now request Dr. Saha to take over.
Good afternoon, ladies and gentlemen. It's a really great pleasure to chair a session of the discussion, panel discussion, I think. This is a symposium. Participating Dr. Nishant Goyal, Dr. Chandramouli Rai, and Dr. Umesh S. Everybody is very known face in the field of mental health. Dr. Nishant is from CIP. He is the Assistant Professor of Psychiatry, KS Mani Center for Cognitive Neurosciences and Central Institute of Psychiatry, Jharkhand. Dr. Chandramouli Rai is a senior resident at CIP Ranchi since September 2020, and Umesh is is an assistant professor of psychiatry at the Center for Cognitive Neurosciences and FMI Center, CIP Ranchi. I think it will be really great session, and they will enlighten us regarding the newer aspects in the mental health, and all of you are eagerly waiting for this. And by this, I'll request Dr. Nishant, Dr. Chandramouli, and Dr. Umesh, please start.
Thank you, sir. May I request the organizers to help us do the screen sharing, please? Just a moment. Give me a moment. So I hope my screen is visible to all of you.
Yes, sir.
Yeah, thank you. Thank you, Gautam sir, for your kind introduction. I'll not waste much of time. Today we are here, me and my team, we are here to deliver a symposium on high definition transcranial direct current stimulation, that is HD-TDCS. So I'll be starting this symposium with a short introduction of principles of HD-TDCS. I would like to first thank the leadership of IABP and particularly Dr. G. Prasad Rao for giving us this opportunity once and again, and my team, Dr. Umesh, Chandramouli, and all my colleagues at the lab. I would like to acknowledge, the role of for neuromodulation in psychiatry. This is a multi-center project which we are part of. So coming to neuromodulation, particularly if you broadly classify neuromodulation, the platform varies in how energy is delivered and to what target. So in that context, we have, like classification is like implants, which talks about deep brain stimulation or spinal cord stimulation, in hospital stimulation. Most commonly, you all know about PMS and ECT, which are very commonly used. And there is a new category which has come up, which are called wearable implants or wearable, neuromodulation technologies, which include transcranial electric stimulation, different types of, and transcranial direct current stimulation, which we are more, interested in particularly. Why we are more interested in? Because transcranial electrical stimulation, the most important thing is it is targeted. It will deliver the stimulation where it is supposed to deliver, though it is less targeted than invasive ones, but at the same time, it is more safe. You can use any dose, and most importantly, from our perspective, from Indian perspective, they are cheap, and they are like you can wear it, use it, and then give it back to the hospital. So what TDCS does, it's basically is a very simple way I can explain. This is like a battery with a negative and positive terminal, which is basically providing a direct current. It is not the alternating current which we are aware of. This is the direct current, which is like a straight line. Now, in principle, you can see how it goes. So it has two electrodes. One is the positive anode and a negative cathode, which is connected to a battery. And what is cathode and what is anode? It's basically the target on the scalp which you want to stimulate. I'll come to it, how it matters and why this is important. So understanding this particular thing, how like whenever you are providing electrical stimulation, so from anode the current goes in the brain, it causes depolarization of the somatic or so the soma, and hyperpolarization of the apical dendrite, and as it returns back from cathode, it causes depolarization of the apical dendrite and vice versa. So this is how it creates a electrical field within the brain. So how do we do it? Depending upon the size of electrodes, the position where we are placing, the amount of current which we are providing, we use transcranial direct current stimulation or TDCS. So there are various areas you can use, premotor area, motor area, like that, and light force. And this is how the current flows. The current flows, or it follows a straight line over a period of 30 minutes. Usually, the convention is for TDCS, we give a current of 2 milliampere for 20 to 30 minutes. We can give more, we can give less as well. So these are various montages. Montages are simply, arrangement of electrodes. I'll tell how it is important. Now, coming to the advancement which we are talking about today is the high definition TDCS. Now, what is this? As simple as that, two electrodes, which are big electrodes, are basic, the padded electrodes are replaced by high definition gel electrodes. It's like when you do EEG. So there are small electrodes, silver chloride electrode. It is similarly, these are gel electrodes, and these increase the control on the targeting of the brain. And the most important part of it, Umesh will deal more about it, is you can do it with EEG simultaneously. So it gives a wonderful temporal resolution when it comes to providing stimulation and doing EEG at the same time. And that's why it is very important for clinical and research purposes. Conventionally, what we do, we use a 4:1 grid, where there is one central anode. This is kept on the target, and 4 surrounding cathodes, which are kept around 1 inch from it in 4 different directions. So what it does, it basically causes a focal unidirectional cortical modulation. How it goes, I'll tell you now. This is just in nutshell about how it does now. See, on the left hand side you can see there are the pad electrodes of TDCS, and the right hand side are the gel electrodes of HD TDCS, and in between you can see the anatomical MRI model of the current flow. So see what happens. Now in the TDCS, you can see there is a flow of current from anode to cathode, but in HD TDCS, there is unidirectional flow of current towards the anode or the area which is within the anode. And see the amount of stimulation by the color coding on the head model, that how precisely a particular area can be stimulated by HD TDCS. So what it provides us with, it provides us with a non-invasive, targeted, arbitrary waveform which can be used for neuromodulation, both for research as well as therapeutic purposes. So just, you might ask me what causes stimulation, what causes inhibition. So just a little bit of the mechanism of it. As I said, current flows from anode to cathode. Now what happens, if you can see, the electrode is placed on the head surface and there is the cortical neuron. So what happens when the stimulation is provided and the current is flown from anode downwards, it causes depolarization of the soma, which causes increase in the cortical excitability, or when you give it again and again, causes improvement in the cortical plasticity. Suppose depression. So what we do is we put the anode or the central electrode on the dorsolateral prefrontal cortex on the left side, and we provide anodal HD TDCS, which has been seen to improve depression in such cases. And on the opposite side, if you are putting the cathode on the target area, it will cause decrease in the cortical excitability. You can use it, suppose, for decreasing the cortical excitability in the temporoparietal junction, or improvement in auditory hallucinations. This is just in nutshell the mechanism. So this is what it says. The central assumption is that a classical TDCS design will have an active electrode or the anode over the target, and the polarity is selected. Whether you want excitation, you put the anode over there, or you want inhibition, you put the cathode over there. As simple as that. It is so simple. So how it does, the 4x1, you can see the same thing which I showed you initially. This is the amount of, you can see in the yellow circle, the amount of cortex which is stimulated by high definition TDCS. So this is how it goes. I'll not go into the details, like how important it is and why it is important. Because it is a unique combination of safe, highly tolerated, a procedure which uses extremely less power. It is simple, battery operated. Anyone can make it. It is wearable, it is portable, and of course, it is targeted and non-invasive. So these are the properties of HDTDCS which make them more, they have this potential of being used more frequently as they are right now. So I'll not go into the details of how we do the targeting. I think Umesh will talk more about it. So there are 4 ways of targeting the stimulus area using HDTDCS. One is the automatic optimization. When we know that DLPFC, there will be a decrease in the cortical activity, so we stimulate that for depression. We use closed loop targeting based on the EEG recording. This is more used for research purposes, which we have been doing. And then there is something called FEM monitoring or functional targeting and sub-vari targeting. These are some higher ends of targeting which we don't use on a regular day-to-day basis. So don't get hassled by that. It's very simple. We do have a software which helps us optimize TECS by target selection automatically, either using the subject's MRI, the patient's MRI, or using some, library. There's a library of MRI. You can use a like the nominal head model, and you can do that. You can use any waveform, and you can go for multi-target or deep stimulation as well. I'll not go into the details of how EEG causes, how EEG helps us hitting the target. I'll not go into the details of this. So over here, I would like to end my presentation by telling that this is has a very high potential of being used and utilized as a potent neuromodulation mechanism with better outcomes in treatment of depression, or maybe in future we might think of using it for wider perspectives. Why neuromodulation? Because as I said, the outcomes are specific. We can use it for clinical improvement. We can use it for rehabilitation, enhancing cognitive performance. There is a very potent area of using neuromodulation in cognitive dysfunction, particularly in old age, dementias, mild cognitive impairments, apart from use in stroke and Parkinson's and other things. It gives you an highly individualized, customizable and tunable therapy. We can hit the target more easily, safe, and most importantly, if you compare it with things like TMS or deep brain stimulation, it is highly cost effective and it is more accessible. As I said, it is portable and wearable. So it can be a powerful brain modulating device. This I would like to thank you all for your kind attention, and I request I'm stopping my screen sharing and I'm asking Chandramouli to please step over. Thank you. Chandramouli, over to you.
Good evening, everybody. I am Dr. Chandramani Roy, Senior Resident, Central Institute of Psychiatry, Ranchi, and I will be speaking on the topic HDTDCS in Psychiatric Disorders, a review. Now, before I begin, I would like to thank Nishan Goyal sir for the insightful presentation regarding the basic principles of HDTDCS. Now, continuing from the previous, the question arises as to why HDTDCS. Now, it is because it's a clinically enhanced version of TDCS. It's more focal, better sustained, and longer lasting in terms of its effects. It is focused delivery of current to the target, which increases the predictability of the effects. Now we all know it's focal, but then what's the evidence? Now the evidence comes from the finite element model analysis, which is known as the FEM model. It's based on the high resolution magnetic resonance imaging data. Now, what do the modeling suggest us? The modeling studies have concluded that 4:1 HDTDCS results in maximum electric field strength under the target electrode. The brain current flow constrained by the 4:1 ring radius results in a more spatially restricted electric field, and the electric field magnitude was assumed to correlate with the modulation and cortical excitability of the brain. Now we'll just focus on the FEM modeling, and we'll look into the FEM modeling in TDCS and HDTDCS. Here in this diagram, we can see the columns indicating the slices of the cortical areas. Here the stimulation was M1 and it was an anodal stimulation. Now in case of conventional TDCS, we can see diffuse current flow with local clustering. But in comparison to TDCS, what HDTDCS does is that it has a peak brain electric field of about 40%. So it's much lesser than what is being given in a conventional TDCS. And 75% electric field induced is in the M1, which is our target location. So the FEM modeling helps us to understand the focality and how much current is being delivered to the target area. Now, we all have been talking about 4:1 HDTDCS. Now the question must come into our minds. Do you have any other alternative electrode configuration? The answer is yes. We do have some electrode configuration other than the 4:1, which is a 3:1, 2:1, and 1:1 HDTDCS electrode configuration. Now, if you see this diagram, there is the electric field due to different electrodes in various M:1 HDTDCS configurations. In this diagram, we can see, irrespective of whether it's 4:1, it's 1:1, the electric field is very much focal. Now, before I go ahead and discuss about the psychiatric disorders and HDTDCS, I want to give a brief overview of how to develop HDTDCS protocols. So there are certain things which we must keep in mind before delivering or developing a protocol. Some of the key factors are site of stimulation, whether we want to give an anodal or a cathodal stimulation, the duration, the charge, and very important is the sham. I will come and discuss by one, first coming to the site of stimulation. Now the site of stimulation can be single. Here we can see the DLPFC being targeted. It can be dual. In this diagram, we can see the DLPFC as well as the parietal cortex being targeted. Again, dual can be of two simultaneous, the other can be a sequential. Now coming to cathodal or anodal stimulation, as we have discussed, cathodal stimulation leads to decreased excitability or plasticity. So how we can use it? So a perfect example would be targeting the temporoparietal junction in schizophrenia, because we all know that a hyperactive or an excited TPJ leads to increase in the auditory hallucination. So using a cathodal stimulation might lead to decrease in the excitability of the TPJ and provide symptom alleviation in patients of schizophrenia. Whereas if we talk about the anodal stimulation, it leads to an increased excitability or plasticity. And the examples can be using it on the target of DLPFC in schizophrenia or depression, where it's going to increase the excitability. Now coming to charge, the charge generally has varied from 0.5 milliampere to 3 milliampere. The duration, it varies from 10 to 20 sessions with 2 sessions per day and about 3 to 4 hours of intersession interval between the two sessions. Now, we'll focus on a standard protocol which we have been using at our lab at CC and CIP. Now here we can see the left AFC is the anode, which is the F3 area. Now the rest of the surrounding electrodes, the FC1, FC5, AF3 and F7, which constitute the cathode, and we can see the ring-like configuration of this whole electrode configuration. So as we have discussed, it's 4:1 grid-like arrangement. Now the rest of the parameters which we can use at 2 milliampere current for 20 minutes with 2 daily sessions for 5 days, equaling to about 10 sessions. So this is how we can develop a standard or a normal brain stimulation protocol by using HDTDCs. Now we all know HDTDCs can also modulate brain networks. So depending on the targeted networks, anodal stimulation can be given at various areas. For example, if you see in this diagram, if you want to modulate or target the temporoparietal network, so the anode would be somewhere near around the CP3, and the cathodes will be placed at a ring-like configuration at FT9, the FCZ, the POZ, and the PO9. Similarly, various electrode configurations can be made according to our needs. Now, developing sham. I mean, like, why sham protocols are so important? Now, sham conditions are equally important, and equivalent sensation with negligible current should be delivered to the patient or to the. And why is it important? It is important to avoid significant differences in sensory side effects as well as the severity. Now, there are two techniques of delivering a sham stimulation. The first is the fade-in, short stimulation, fade-out approach. In this, the current is ramped down following a brief period of delivery, and this is designed to induce the initial sensations that are thought to fade out slowly. But the more recent thing which has been coming up is the active sham conditions. So here current is continually applied and the scalp sensations are virtually indistinguishable from the active. In this, there is little or no cortical modulation. Now, how is it done? It is done by shunting a portion of the current through the scalp. Now, alternative multi-electrode configurations that manipulate electrode placement to shunt current across the scalps are warranted. Now, coming to HDTD experiments with healthy volunteer. Now, experiments with healthy volunteer are vital in elucidating the underlying mechanism of actions of HDTDCs. Also, it is important to modulate the neurocognitive functions. Now, the most of the studies with volunteers have been done with current ranging from 1 to 2 milliampere in a 4:1 HDTDCS fashion. Cognitive tasks has been used. The targets have varied from the DLPFC to the auditory cortex. And the most important is that the concurrent fMRI and EEG techniques have also been used. Now, coming to HDTD neurological disorders. Now, there have been a dearth of studies regarding HDTDCs and neurology, but still there are studies, and to be precise, there have been 3 RCTs which have been conducted, and I will discuss each of them one by one. Now, first coming to HDTDCs in traumatic brain injury. There was an RCT which was done, and it included a pre-post neurological battery, a central anodal stimulation to the pre-supplementary motor area was given. The active group received 1 milliampere current for 20 minutes. 10 sessions were given in a 2-week period. So what did the study suggest? The study suggested that there was significant improvement in verbal retrieval memory in TBI patients for 8 weeks. So this study implied the importance of TDCS in traumatic brain injury. Now, focusing on aphasias, there was an RCT which had a crossover study design, pre and post verbal retrieval task. Here, the central stimulation was to the cathode, precisely to the F6, which corresponded to the right Broca. Here, 1 milliampere and 2 milliampere cathodal current arms was given for 20 minutes. There were 10 sessions in a 2-week period. Now, the study showed there was significant improvement in verbal retrieval task post the 2 milliampere HDTDCS cathodal current as compared to the sham, but there was no significant difference between the 1 milliampere current and the sham conditions on verbal retrieval task. So we can see that 2 milliampere current helped in verbal retrieval tasks in patients of aphasia. Now, continuing with aphasia, considering the feasibility, there was another RCT done which had a crossover study design with TDCS and HD-TDCS arms. Here in this HD-TDCS protocol, there were 2 anodes and 2 cathodes. 1 milliampere current was in each. The highlighting point of this study was the location was ascertained based on computational models, and it was personalized for every patient. The duration of study was 5 weeks. The study showed that accuracy of trained items was significantly higher in the post-HD-TDCS arm as compared to the TDCS arm. But there was no significant difference in naming accuracy and naming response time between TDCS and HD-TDCS. Now, going forward, talking about tolerability, there was a tolerability retrospective studies, including all the RCTs and case studies, with HD-TDCS being given for 30 minutes. So the study showed that there was no difference between tolerability of active HD-TDCS, both 2 and 3 milliampere currents and sham conditions. So this study proved the tolerability of HD-TDCS in patients. Now talking about epilepsy, there was an open label study. Stimulation target was identified by long. The cathodes were placed respectively, but most of them were in the frontal and the central regions. Now the study showed that there was no significant change in epileptiform discharge with HD-TDCS treatment, but there was a significant improvement in attention and working memory immediately and after 1 month of HD-TDCS treatment. Like we all know that the epilepsy patients have a huge cognitive dysfunction. So even though HD-TDCS was not able to reduce the epileptiform discharges, it was still able to help the patients with respect to attention and working memory. Now coming to HD-TDCS in psychiatric disorders, again, there have been quite less studies which have been done, and most have been open label with a few RCTs. Now talking about the disorders which have been covered via the HD-TDCS, the most of the studies have been done on schizophrenia, and the other fields being child and adolescent psychiatry, life depression, dementia, PTSD, and OCD. Now talking about schizophrenia. Now I would like to show you guys a case report which had a central cathodal stimulation to the CP5, which is the temporoparietal junction. There was a 2 milliampere current being passed. So the case report suggested that there was a significant reduction in auditory hallucination with 5 days of HD-TDCS treatment. Going forward, there was another open label study which used the same electrode configuration, the central cathodal stimulation at left TPJ. The current was same, 2 milliampere, and there was a significant reduction in the auditory hallucination with 5 days of HD-TDCS treatment. So these 2 studies suggested that HD-TDCS can be used as a very good adjunct or as an alternative in treatment of persistent auditory hallucinations and schizophrenia. Now, talking about the correlates of HD-TDCS in auditory hallucinations, schizophrenia, there was a study which found that the percentage improvement in auditory hallucination score had a significant negative correlation with the gray volume. This study showed that variations may influence the response of auditory hallucination to HD-TDCS in schizophrenia. So most studies might be required which focus on more of the correlations of the brain with HD-TDCS. Now remaining with auditory hallucinations, persistent auditory hallucinations were covered in dementia. There was 2 milliampere current given for 20 minutes. And in both the studies, there was an improvement in auditory hallucination scores. Now coming to child and adult, comparing between conventional and HD-TDCS, there was an RCT which included a pre and post NBAC task in adolescents with ADHD. There was a central anodal stimulation of 0.5 milliampere to the right inferior frontal gyrus. This study showed that increment in the amplitude of D300 and N100, which are ERP markers with HD-TDCS session, were comparable with conventional TDCS. Now coming to a very which was done on individuals with high autistic traits. HD-TDCS was given on the right temporoparietal junction in high autistic traits adolescent using an eye tracking technology. Now, what were the results? Some the results were very interesting. Like anodal HD-TDCS significantly increased the fixation time and fixation count in the mouth area, but this effect was not found after sham stimulation. Moreover, this increased mouth recognition was shown in both happy and no remarkable difference was found in cases. So the basic crux of this was that HD-TDCS improved attention in adolescents with high autistic traits. Now coming to OCD, comorbid bipolarity, there was a case series where anodal stimulation was given to the pre-SMA. The results showed that significant improvement in OC symptoms, as well as there were no effective side effects noted during the course of treatment. Now coming to late life depression, there was an open label study with stimulation to the F3. It was an anodal stimulation, and there was significant reduction in the HAM-D scores from baseline, remission over time, reduction in apathy scores, and improvement in cognitive functioning and verbal fluency. Finally, going on to the disorder, there was central cathodal stimulation to the lateral temporal cortex. And this study showed that decrement in the PTSD scale subscores with TDCS at the right LTC, which is the lateral temporal cortex, were correlated with the altered connectivity between the LTC and the extended fear network on fMRI. Now talking about studies which have been done at CIP. So there is one study which is still in press, which talks about the adjuvant HD-TDCS for negative symptoms in schizophrenia, a pilot study. It was a randomized double-blinded using 10 sessions of HD-TDCS. And the result showed that there was improvement in negative symptoms in the active group. And it was statistically significant as compared to the sham group. Talking about the ongoing studies at CIP, there is a study titled Adjuvant HD-TDCS in craving, withdrawal severity, and brain glutamate and GABA levels in patients of opioid dependence syndrome. So this is basically an MRS study as anodal HD-TDCS at the left DLPFC. There is another study which deals with the neuromodulatory effects of adjunctive HD-TDCS on auditory verbal hallucination. So this study is a sham-controlled DTI study. And the anodal HD-TDCS is at the left region with pre and post DTI measures. Now concluding, like we all know, and we have read that there is substantial evidence for the use of HD-TDCS in various neuropsychiatric disorders. But more studies and more RCTs are needed to establish the efficacy. Integration with newer models and emergence of HD-TDCS useful treatment for various neuropsychiatric disorders. Now, finally, acknowledgements. I would like to sincerely thanks Dr. Nishan Goyal sir and Umesh sir for the invaluable support and guidance. My special thanks to all my teachers, seniors at CIP, my colleagues and my juniors, and a special thanks to IABP for giving me this opportunity to speak at this level. Thank you.
Over to you.
Am I audible? I'm audible. Okay. Thank sir and Dr. Chandramouli for making my job a bit more easier in delivering this important topic on high definition TDCS. So I'll be basically speaking about the various neurobiological mechanisms that takes place in HD-TDCS, along with the newer technologies in order to measure the various response markers in psychiatric disorders. So the first and foremost thing is what exactly neuromodulation is. So neuromodulation is fundamentally a technology impacting on the neuronal interface. That basically it involves the understanding of various stimulations, modification, regulation, as well as various therapeutic alteration. Most importantly, the treatment is non-invasive and it employs weak electric current or maybe focal magnetic field that implies to EMS, and ultimately they modulate synaptic plasticity. And most importantly, therapeutic utility has been claimed these days and it has found to be efficacious with lower number of side effects or adverse effects as compared to ECT and pharmacotherapy. And therapeutic possibilities are exponentially increasing as a monotherapy or as an augment to existing pharmacotherapy or psychotherapy. So most importantly, it is the three important factors that John Holzheimer had given when he talked about neuromodulation in therapy. It involves the therapy must be dynamic, ongoing, and the intervention should be occurring for a substantial period of time, and it should not be just a single or a non-recurring procedure. The activity of the specific neural networks should be affected because of the ongoing electrical or magnetic stimulation. And the third important factor is the clinical effect is continuously controllable by varying the different stimulation parameters to satisfy the patient's needs. So because of this, so there has been a substantial increase in the number of publications that has been taken place in the field of neuromodulation and more specifically in the field of transcranial direct current stimulation, and a lot of contribution has been there from NIMHANS and some contribution is even there from CIP and various part of India. So that has been definitely there. So if you look into the timeline of the TDCS innovations, we can see that the first CE mark was it was provided somewhere in the year 2005, and subsequently there has been a lot of technological enhancement that has been taken place to a precision-based treatment that has been currently under trial. So it has been approved at various places, including United Kingdom, Canada, Singapore, as well as in various European Union countries. So it is one of the most important field of neuromodulation. So when we talk about the basics, as Dr. Nishant has already mentioned about the basics about HTTDCS, but however, I'd like to just focus upon a few things. So basically, when we talk about anode and cathode, it is basically the current that is injected inside the brain. We don't go by the conventional thing that we read in our maybe +2 regarding the anode and the cathode about the galvanic things that flows to maybe light up an electric bulb, but it is just about the injection of the positive current inside the brain and the exit of the current from the cathode. That is the exit of the particular things. So we are not focusing much about the definitions of anode and cathode that is exactly mentioned in the technical field. So what exactly happens? So if we try to stimulate the brain repeatedly, so there is an increment in the resting membrane potential. And this facilitates the depolarization, and because of which there is an enhanced action potential, and subsequently this lasts for a substantially longer period of time because of the repeated firing of a particular neuron, which ultimately causes the neuromodulation of various neurotransmitters, maybe dopaminergic, serotonergic, or acetylcholinergic. So a seminal paper that was published way back in 1964 has been one of the basis for the understanding of TDCS or maybe HTTDCS. So it was published maybe in 1964 by Parpura and McMurphy. They gave anodal stimulation and subsequently the firing was substantially repetitive and very frequent. Over a period of time, and when the anode was off, the firing after a few minutes it has come back to the normal state. However, when it comes to the cathodal stimulation, you can see that the firing rate has gone substantially low or even to the level of isoelectric line. However, after a few minutes, it is once again starts firing repeatedly. So this paper has received more than 900 plus citations, and because of which it is one of the important papers in the field of neuromodulation or HTTDCS. So Nishant sir has already mentioned about the current flow, the hyperpolarization of the apical dendrites and the depolarization of soma when the anodal stimulation is provided, and vice versa, that is hyperpolarization of the soma and depolarization of the apical dendrites if there is a cathodal stimulation. So this is a paper which was published just recently in Asian Journal of Psychiatry, which talked about the various systematic, they have taken the systematic review on various psychiatric disorders, and they have given a brief overview about the mechanism of action. So they have mentioned activation of the specific dendritic layer, especially when it comes to anode. There's a depolarization of basal dendrites and hyperpolarization of the apical dendrites. And there is an increased local connectivity, and there is a decreased in long range distance coupling. Same thing is opposite when we talk about the cathodal stimulation. So if you look into the HTTDCS, it's already been discussed substantially that the focality is very important, and the amount of the stimulation at a particular site is given when HTTDCS is there. But however, when it comes to the conventional TDCS, the area that is covered is relatively broader. The electrical field is very precise. So when we talk about the long-lasting changes, until and unless when a current is stimulated to the brain, we have to talk about whether it is lasting for a longer period of time. So this was a paper that was published in 1962, which in fact said that when current is provided to the brain or the neurons, so at least the after effect can last up to 4 or 5 minutes or more. So this says that the after effect seems to be pretty substantial, but although I'd like to share a few of the articles subsequently. So this is the period when the stimulation was provided and the after effects was seen, and the firing seems to be at a higher amplitude as compared to the earlier firing. So the same thing holds true when it comes to the anodal stimulation. There is a gradual increment, and this is the after effect. Whereas when it comes to the cathodal stimulation, this is the neuronal firing, and the moment cathodal stimulation is provided, so there is a dampening of the neuronal firing. It may last up to 2 minutes. So subsequently, based on the earlier paper, Nisha and Paulus, this was the first paper, maybe in 2000, they started working on the TDCS and various models that were maybe tried in the animals. And subsequently, what they found is they tried to analyze by using the motor evoked potentials. So they said they found that when anodal stimulation was provided, so there was an increment in the MEP. And when the cathodal stimulation was provided, there was a decrement in the motor evoked potentials as measured by TMS stimulation. The possibility of non-invasive neuromodulation of motor cortex was one of the important landmark things that happened in the 2000, and when they applied a weak DC current over the scalp, and the excitability was such that it was around 40% of the enhancement of the TMS MEP that was observed. So this holds true that the after effect seems to be pretty important. Subsequently, they started understanding much about that. If you can see that when the anodal stimulation was provided at 1 milliampere, so after effects were lasted maybe up to 5 minutes, and when it comes to cathodal stimulation, the dampening of the MEP lasted maybe up to 5 minutes. So they started titrating various the currents as well as from 0.2 to up to 1 milliampere, and stimulation came from maybe first 1 minute to up to 5 minutes. You can see that if there is 1 milliampere stimulation, the MEP seems to be pretty higher and seems to be present for a substantially longer period of time. And even when it is being provided for 5 minutes, the MEP amplitude seems to be pretty high. So because of this, a lot of TDCS experiments has been taken care of as to what is the amount of current that needs to be provided, or maybe what is the duration in which the stimulation needs to be sent to the brain and all. So it is mentioned that when we provide a stimulation of up to maybe 30 minutes, the MEP can last up to 360 minutes or up to 6 hours in that hyperexcitable state. When it comes to cathodal current, even at HTTDCS, the current, the after effects may last up to 6 hours. It is relatively higher as compared to the conventional TDCS stimulation. Moving on to some biophysics, the effect of the weak depolarizing current depends on the strength of the current and the duration of the application. And DC stimulation is often described in terms of charge density, that is Coulomb per centimeter square. So this is basically some amount of physics. So 1 Coulomb is amount of the current electric charge transported in 1 second by a steady current of 1 ampere. That is basically what is required. And to stimulate a particle surface, it requires maybe around 0.013 to 0.3 Coulomb per centimeter square to provide a particle excitation. So, but the problem is current has to penetrate through a lot of structures, skin, skull, meninges, CSF, and finally stimulate the cortical and the subcortical structure. So a lot of shunting takes place in between. That is a problem with the transcranial direct current stimulation. If you look into the electrical conductivity values, so you can see that the CSF has a good amount of conductivity, because of which lot of shunting that takes place in the CSF as well as the scalp. And the most problematic thing is the skull, the compact bone, which has a very low, significantly lower conductivity, that is just 0.006. A lot of current that gets obstructed at this level, and subsequently the leftover current is very fast, some gray matter, and subsequently to the maybe white matter. We are not sure about that. So current takes the path transcranially, depends upon the head anatomy and the resistivity of each tissue type. Only a fraction passes, as I've already mentioned, and current crossing CSF gets distributed in the brain tissue. Cortical pyramidal neurons get stimulated with the peak of maybe 0.5 millivolt mm to 1 milliampere. So this is a diagram that shows this is the radial flow of the current. You can see there is a hyperpolarization, and subsequently there is a depolarization that is occurring at the soma. You can see the angle at which the things are passed, the electric current is passed. If it is radial electric field, the amount of voltage generated would be substantially higher, as well as to the tangential neuronal path. But when it comes to the perpendicular neuronal paths, these dendrites are relatively less stimulated, or maybe the hyperpolarization occurs more substantially at this place as compared to the tangential field or the radial field. This is very much important, because what happens in various researches is, if we consider that to be a globe, the head surface as a globe, then maybe it will be easier for us to understand the tangential as well as radial electric field. But in fact, we have a lot of gyri, sulci, and there will be a lot of convolutions. So because of which the direction of the flow of current is rather complex as it is thought. So when we go into the deeper level, maybe at the neuronal level, maybe we'll have to think about calcium that is basically involved in either LTP or LTD. So higher level of calcium is required for triggering LTP, whereas moderate level of calcium elevation is important for triggering the LTD or long-term depression. There's also two important areas which is called as the no man's land 1 and no man's land 2, where there is no neuroplasticity that takes place. So the amount of current that is provided should not fall somewhere in no man's land 1 or no man's land 2 in order to provide either LTD or LTP. So the problem is, if you stimulate the brain for a longer period of time, probably there is a chance of that ending into the no man's land 2, because of which we might not be getting any sort of effect. So if we see the amount of current, if it is there, maybe lasting properties would be pretty higher. At 2 milliampere, it is still maintained. 3 milliampere, it is still maintained. Probably if we go beyond that, maybe we'll not be able to find the same, as it might fall into that no man's land. So what is the reason? Basically, it's about the glutamatergic synapse that is basically the driver of the direct current stimulation induced plasticity, because a lot of studies that has been taken place where they have given dextromethorphan, which is NMDA receptor antagonist, and then seen the MEP. They have found that on providing dextromethorphan, the MEP actually is reduced. The same thing holds true for carbamazepine also. When they provide carbamazepine, the MEP is substantially lower, because the voltage gated sodium channels are blocked, and subsequently a lot of physiological studies have been done. I was talking about the non-linearity. So if we stimulate the brain for a longer period of time, maybe it can go into the non-linearity because of the changes in the calcium influx in the postsynaptic cells that is more than what is required, because of which the effects what is expected may not be received. So this is how it occurs. The glutamate at the synapse, there is a modulation of the glutamatergic receptor, subsequently increased calcium flux that occur, subsequently modulation of AMPA receptors, and subsequently because of which dopaminergic, acetylcholinergic, and serotonergic receptors starts modulating because of the changes that occur in the glutamatergic neurons. And this is the interneuron which takes maybe control on this particular modulation that is going on. So this is the same thing that I was mentioning about. The most important thing is it improves the functional connectivity between the brain region that I'll be sharing in the subsequent slides. When it comes to SDTDCS, as you all know, it is a 4:1 or maybe a different montage configuration. It also includes the FEM model that Dr. Chandramouli has already described about. So if we can see the metal rivets, if it is there, and the configuration when it is provided. So if something for 2 milliampere is there, so 0.5, 0.5, 0.5, and 0.5 will go evenly, and we are able to find the focal precise stimulation at a particular desired site. However, we can even get something which is even, partially uneven, or fully uneven sort of montage presentation, and the direction of the current can be effectively altered based on this. This is from one of our study which is recently published in Journal of ECT, which has used we stimulated dorsolateral prefrontal cortex and found some efficacy that Dr. Chandramouli has already talked about. So when we talk about the SDTDCS, when it comes to the modeling, so how well it is stimulating the exact area, especially the motor cortex, so you can see that the amplitude seems to be pretty higher as compared to the other regions of the brain. That means it is stimulating just the C3 electrode site, but not the FC3 or F3. And you can see that there's an isoelectric at both F3 as well as P3, but at C3 there is a maximum amplitude. So we can infer that the whatever stimulation is provided is going inside the P3. If we look more deeper into it, it is precise. So SDTDCS gives you more precise way in which the stimulation is provided. So when we go by the MEP amplitude again, if you look into the conventional and high definition TDCS, we can see the MEP amplitude is relatively higher and sometimes significantly higher as compared to the conventional TDCS. So we have to go for an optimal placement, and this is the FEM model because our brain is having a lot of convolution. So we have to know about exactly the what is the vector of the current flow, because of which there has a lot of modeling that has taken place, which has this tetrahedral mesh. Subsequently, it sees the direction of the field as well as the focal electrical field. They are basically simulation models. One such example is SimNIPS. Other examples are Rose pipeline and other things where you can simulate the electric current. Here the patient MRI is taken, or maybe the MNI template is taken, and subsequently MRI, it is segmented, virtual electrodes are placed in the anatomical model, the volume is tessellated into a mesh, basically the tetrahedral mesh. Finite element model is solved numerically, because of which the estimation of the current flow or the focal electrical field, the EF, has been generated, and we can understand what amount of electric field is generated at different parts of the brain. Okay, suppose when we get an idea of like that we are able to stimulate medial prefrontal cortex, so we can go for the simulation models where we can see whether the MPFC is getting stimulated or not. So when we talk about response biomarkers, the biomarkers are basically the biological measures of normal biological process, pathological process, or pharmacological response to therapeutic interventions. So one problem with if we remove the neurons and if we from the natural environment and we see the various effects on it, it will not be a very good idea. So probably we have to go for some in vivo experiment. It could be either invasive, semi-invasive, or non-invasive. However, because of all these shortcomings, TDCS effects is still remaining uncertain, and biomarkers hence offer a best way to identify the effects of TDCS. So used to guide the application of neurostimulation as well as fine-tuning of the protocols can take place in order to see the health effects, safety, and in order to enhance research. One important thing that needs to be thought whenever we measure biomarker is these comparing. We should not be like comparing apples and oranges as a randomized prospective study. So we should have a plausible hypothesis in understanding all those things. So this is an interesting article, one can go through it. So moving on to simultaneous measurements of maybe EEG, MEG, EEG with TDCS, they're all newer technologies that has been there. So EEG, actually it's measure of the potential difference from the scalp resulting from the ohmic current induced by the electrical brain activity. So it could be either sequential or simultaneous TDCS EEG monitoring. And MEG measures the magnetic field outside the head induced by the current flow within the brain. So maybe after TDCS, what is the effect of this that could be measured by with the help of either EEG or MEG. So if you can see that when the stimulation is provided, you can see the spectral power seems to be selectively enhanced when it comes to stimulation. This is the stimulation, so this is the spectral power which is there, and we can see there is an enhancement at various spectral frequencies. So if we look into the EEG classifications by using support vector machine or many other methods, we can see that the accuracy is also pretty higher when it compares like predicting TDCS treatment outcomes in major depressive disorder. And when they classify maybe responders, non-responders, you can see that alpha asymmetry was substantially higher in the non-responders as compared to the responders. So if you look into what exactly happens inside the neuronal oscillations when TDCS is provided, immediately what happens is there is an increment in the delta as well as the theta activity. However, the alpha, beta, and gamma activity relatively seems to be at the baseline or maybe at the pre-stimulation states. When it comes to the mu event-related desynchronization or event-related perturbation, you can see that after the stimulation, so there is an increment in the event-related desynchronization, whereas in the cathodal stimulation, there is a decrement. So basically, ERD can also be one of the measures where we can see that there is some change in the motor cortex or maybe the areas which are involved in motor mimicry. When it comes to integrating MRI and HT-TDCS, so a lot of advanced technology has been currently taking place. And once again, it's about measuring the sequential or maybe it is concurrent methods. The effect of TDCS can either be in the presence or during the absence of task, resting state, or maybe task-based. So the integration of TDCS with MR imaging techniques provides a technology or a tool to directly perturb neuronal function while monitoring the brain space. Okay. So if you look into the various fMRI TDCS paradigms, so first important thing is the fMRI timing. Second is how the study design is conducted, what is the control condition, what is the stimulation protocol, what is the imaging that is currently thought of, and what are the behavioral or the clinical measures, what the outcome measures that needs to be properly deciphered. So if we see some articles, so this is one of the articles that has been recently published in 2020 probably, it has seen there is an enhanced resting state functional connectivity in almost all the neuropsychiatric disorder, substantially seen in maybe ADHD or cerebrovascular accident or something like that. But you can see that after TDCS, there is a significant change in the resting state functional connectivity. So this is the meta-analysis which I'm quoting from. So something which is called as a target or precision based, some of the important things is there are three different types of study. One is montage selection studies, second is the prediction studies, and third one is the mechanistic studies which we usually perform at our lab. So not going into the details of this. So moving on to the last few slides on TDCS, FNIRS integration. So functional neuroinfrared spectroscopy is one of the measures of measuring like neuroplastic changes by taking the blood oxygen level, which is based on the principles of neurovascular coupling. So it could be the hemodynamic changes can be measured online, offline, during rest or during task. So it is a low-cost portable neuroimaging method, and one can definitely try out this method. You can see that pre-stimulation, so this is the blood oxygen levels, and subsequently after the stimulation, you can see there is an increment in the blood oxygen level as compared to those electrodes where the stimulation has not been provided. So these are the areas which was selectively stimulated, and these are the areas where the outputs were located. If you look into the systematic reviews, you can see that although there is no significant change in the hemoglobin levels, definitely there is a negative correlation between the oxyhemoglobin level and reduced psychosis scores after TDCS. When it comes to post-stroke depression, there is an increased oxygen HbO2 in the prefrontal cortex versus post-TDCS at baseline, and subsequently the working memory task, there is an increased oxyhemoglobin levels. So the last slide is on genetic polymorphism. Because of the higher inter-individual variability, like in the previous presentation, Venkat Subramaniam sir was mentioning about the inter-individual variability. So there is a high amount of inter-individual variability in response to the TDCS treatment. So probably there might be certain genetic interference or maybe genetic differences that may have been one of the contributing factors. So we have to see who are those who are basically responders to TDCS and who are basically non-responder to TDCS. So this is still a query. We don't know much of this evidence. However, there is a gradual search of such, although they were not able to find much, they're able to find only this particular genetic polymorphism. However, that did not amount to significance. Maybe they are trying some other genetic polymorphism study, maybe in future studies. So to conclude, TDCS biomarker with the help of clinical neuroimaging and maybe from the animal models can support hypothesis linking neurobiological mechanism as well as the behavioral effect. The doses can be optimized using the computation models of current flow, as well as we should understand the dose responses. If we do that, maybe in the future we can get something like a home-based TDCS where the clinician is monitoring distantly and a person is receiving a TDCS stimulation at his home. And maybe in the future we might get something of this sort, although it is from a fictional, maybe from a movie or something. So this is all about my today's presentation. Thank you for your patient listening. I'd like to thank the organizing committee of Indian Association of Biological Psychiatry, Dr. Nishant sir, Dr. Chandramouli, staff of CCN, and conflict of interest none to be declared. And this is the color of CIP. I'd like to take an opportunity to acknowledge Clinical Research Center for Neuromodulation in Psychiatry, a multi-center initiative to advance intervention psychiatry in India in collaboration with NIMHANS Bengaluru, CIP Ranchi, and Manipal University. So this is the webinar which is supposed to occur after a few days, and we request you to kindly register. Thank you.
Thank you. All these three speakers are excellent, Dr. Nishant Goyal, Dr. Chandramouli Rai, and Dr. Umesh S. It is a fantastic session. I think if any questions from the audience, please let us know, because there are lots of theoretical and practical. It's a beautiful combination of presentation and FNRI also. Anything else? Actually, what are the indication? I want to ask Dr. Nishant regarding the indication of the identity TDS. So what are the indications? One is major depressive disorder, especially in the resistant cases.
Sir.
Otherwise, what are the other indications where we can use?
Sir, see,
what are
the
the
direct
scope for
indication,
OCD and
yeah, absolutely, sir. See, the direct indication is yes, depression, maybe schizophrenia. But if you see the beauty of direct current stimulation, you can use it as a cognitive enhancer also, sir. And this cognitive enhancement can be used indirectly in all psychiatric disorders, like maybe chronic psychiatric disorders like schizophrenia, dementia, name it, you can use it in any psychiatric disorder. If you want to really target the symptomatology, yes, depression, OCD, dementia, schizophrenia. So, sir, the idea is that if you see the theoretical and the practical aspect and combine this, this can be a potent mechanism of treatment or model of treatment which is going to be highly cost effective. Not everyone can keep a 1 crore transcranial magnetic stimulator in their clinics, but a TDCS can be used, it's like a wearable device. You can keep it in your pocket.
Exactly.
And all those things, sir.
Absolutely do agree with you, because one of my experiences, I am saying, for RTMS definitely, one patient with resistant auditory hallucination, schizophrenic patient. So there are evidence-based studies that it works. So I have given to this patient. And ultimately patient said intensity come ho gaya, but auditory hallucination is still there. But overall, sir, it is a great improvement. I really like this treatment.
Absolutely.
That is the cognitive improvement.
Exactly.
I do agree with you 100%.
Exactly. So this is what we are trying to portray. Like that's why HTTDCS is a finer
Is
game.
very much happy, even the patient party. They are saying there's dramatic improvement. But I used it for the resistant auditory hallucination. Hallucination is there. They said intensity come ho gaya, but still it is there. But overall improvement is very.
Sir, patients become more productive. The quality of life improves.
Exactly, exactly. Even
So
whenever
it is not
we
only
see
about
this,
reducing
I saw that
hallucination.
patient. I
Yeah.
saw the improvement in clinically also.
Absolutely, sir.
Any other, Dr. Avinash? Okay, fine.
Okay, sir.
Then we
Thank
can
you.
conclude. It's a very fruitful and enlightening session. Thank you
you,
all
sir.
three of you.
Thank you, sir.
Over to Dr. Avinash.
Thank you. Thank you.
I thank Dr. Nishan Goyal, of course, Chandramouli, and Dr. Umesh S. for the presentation. So I think we're coming to the end of day one. Our last session, which was by Dr. Arun Ravindran, won't be happening. He's not here because of a personal reason. So this is our last session for the day. Indeed, yes, HDTDCS is something which we look forward to in the future. I would like to inform all people who are online that we will start again tomorrow morning at 9:30 with the Asha Award. So please be there for it and be there to cheer the people who are presenting. And yeah, and I would like to conclude day one. Thank you. Thank you so much.
Thank you all. Good night.
Thank you.
Good job, guys. It was a beautiful mix of
Lab में बैठा